Hello everyone. Very good evening to all of you. Am I clearly visible, audible? First, you have to confirm in the comment box if I'm clearly visible, audible, everything is good to go. We can start the session ahead. Can we start? I'm waiting for your comments. Is it okay? Everything is good to go? Thank you. Thank you. Thank you for confirmation. Thank you so much for confirmation. So very good evening to all of you. Those who are attending my session for the first time and don't know me, let me introduce myself. I am Dr. Priyanka Sachdev here. And today, I will be taking the demo session for third Prof Buster 1.0. The subject today is community medicine. So I welcome you all for today's session and let's start it. Let's start today's session. So most of the students who are attending the session today, I guess they must be third Prof students as it is third Prof Buster 1.0 demo. So before coming on today's demo, today's topic that is epidemiology in one shot, I would like to introduce the struggles, the problems which are usually faced by the third Prof students. We will quickly, in next few minutes, I will just summarize the struggles. Okay. So there are three types of struggles as you can see. Let me come on the academic struggles. First of all, there are 4 subjects in the third Prof. I mean, some universities have 4 subjects, some universities have 2 subjects. PSM, forensic medicine, ENT and opthal. All these 4 subjects demand equal attention. But you know, the learning style of all these 4 subjects is totally different. That is the biggest problem which is faced by third Prof students, I feel so. Okay. The second problem, difficulty in applying the theory clinically. Okay, most of the students feel difficulty in applying the theory clinically. I mean, they understand on paper but become blank in the viva. Okay, so this is the second problem which is faced by the students. The third is lack of revision structure. Students start with one subject, they forget another halfway through. Do you also feel so? This is your problem, yes or no? The next is fear of viva and spotters, especially when the simple questions are little bit twisted by the examiners. Students get confused in the viva and spotters in the university exams. The next type of struggles or problems is curriculum and NMC guidelines. Now, sometimes in some university, ENT opthal is included in third Prof. In some universities, it is included in fourth Prof. And it always creates confusion at the back of the mind in the students. Yes or no? So in your university, is it included in third Prof or final Prof? So it always creates confusion in the student as much as I have talked to the students and I know. Okay, but remember one thing, order doesn't matter. What matters is the mastery in those subjects. Now, whether ENT opthal or in third Prof or in final Prof, it doesn't matter. What matters most is you should know them with clarity and confidence. Yes, and better is to early start and early finish them. The next type of problems is time and energy struggle. Yes or no? Most of the students are juggling with too many responsibilities like community posting, ward posting, lectures, practicals, and they're still trying to find some time in the library for self-study. Yes or no? I guess this is the biggest problem most of the students face. Yes or no? And never-ending cycles of internals, seminars, and submissions. So that's why students don't find time for doing self-study and complete the syllabus on the time. Now, let me tell you the bigger picture. We have enumerated the problems. Now, let me tell you the bigger picture of the third Prof. Why third Prof matters most. Why it is most important Prof. Now, let me remind you, in the final Prof, you have 9 to 10 subjects, depending from university to university. You have 9 to 10 subjects in the final Prof. So if you are finishing your third Prof on time, you will start your final Prof subjects on time. And maybe some final Prof subjects you will finish in third Prof itself and it will be better for you. Yes or no? So if you are completing these 4 subjects timely over here, you will get time for your major subjects of the final year. That's why this Prof, the third Prof, is very important. And starting from the beginning and finish it quickly earlier is very important. Yes or no? Do you feel so? So by looking at all these problems of the students, okay, so the team we thought to launch the groundbreaking course that is third Prof Buster 1.0. So we are launching this course today in which Dr. Priyanka, I will cover all 4 subjects. Okay, I will teach you community medicine, FMT, ENT and ophthalmology. All these 4 subjects will be taught by me. I will take daily 2 to 3 hour live session. It is not daily, it is 2 to 1. 2-day lecture, 1-day break. 2-day lecture, 1-day break. Like it is 2 to 1 schedule. I guess the detailed schedule is already provided to you if you have inquired on the support number. Yes, so it is 2 to 1. And the entire session, entire syllabus will be covered in 4 months. The sessions will be in the evening only so that you can attend them live. Okay, and the entire syllabus of all 4 subjects will be completed in 4 months. The live sessions will be completed in 4 months, but the recordings of them will be accessible for 1 year from the date of the purchase. Okay, and for ENT Opthal, it will be available for 2 years, because in some universities, ENT and ophthalmology is in final year. So you can revise them later on after 2 years also. So start date is today. Today we are starting this course, and the end date will be 22 February. For detailed brochure, you can ask on the support number. So you can see the complete schedule, you can see the color coding of the 4 subjects, and you can see the complete schedule. We are starting today and we will end it successfully on 22nd of February. So this is the complete schedule of Prof Buster, third Prof Buster 1.0. Here in this course, I will provide you daily live interactive sessions, teaching with 3D models in the clinical subjects, that is ENT and ophthalmology. I will teach you both these subjects with 3D models. I will show you all the layers of the eye one by one by opening them. I'm having the 3D models with me. Okay, and recordings of these live sessions will be available. Digital notes, printable notes, that is the new things we are introducing this session. And annotated notes, all type of notes will be available for you. Quiz, question bank, all type of question bank, university exam question bank, and competitive exam, NEET, PG, NICT question bank will be available. And practical library. Now let me clarify. Many students have asked, is this course particularly for university exam or NEET, PG, NICT? It is for both. I will teach you all the topics in detailed, comprehensive way. Now after that, you can write the long question, short question also, and excel and get distinction in your university exam. And you can try any MCQ, any PYQ of any platform. Take my challenge. By watching only my session in this course, you can crack all the MCQs. So this course is for both, for university exams as well as for competitive exam preparation for these 4 subjects. Got it? So that is the inclusion in this course. You can see I will take total 87 live sessions. If something is pending in these, that will be recording will be provided. But 87 live sessions are there. Okay. And today is the first demo. So today we are starting with community medicine. The topic for today is epidemiology in one shot. Okay. So let me come on this topic. But this is not the last demo. We are having total 8 demo. So please stay connected for me with the next for the next 8 days. And you see how I will simplify the things, and it will be worth watching each and every lecture. Okay, so 2 sessions on each subject will be as demo, and you can see the topics are most important topics in all these 4 subjects. So that is about the demo. For any further details, you can WhatsApp on this number. Okay, so let's start. Let's start it. Can I start the topic for today? Community medicine, epidemiology in one shot. Can we start it? Are you people ready? How many of you are ready with me? Give me a minute. Can we start? Now I can see many students are doing inquiry about the course. For any further details regarding the course, just a second. For any further details regarding the course, you can WhatsApp on that number. So without wasting any further time, we should start the topic now. The demo topic today, that is epidemiology, community medicine, the most important topic in community medicine. You get many MCQs on this topic, and this is further very important topic for your university exams also. Can I start it? So let's start epidemiology. The notes of this topic is already available in the comment box. You can see the pinned message in the comment box, and you can go and you will get the notes. Okay, the PDF is available. So notes are already available. You can take a printout later on. Can we start? So let's start epidemiology. Before coming on the bookish definition of epidemiology, that is boring. You won't understand it directly. So let me explain you in simple words. What's epidemiology? Let me explain you in very simple words. What's epidemiology? Okay. Before I teach you what's epidemiology, what is the definition of epidemiology, you tell me, have you ever wondered why some diseases disappear while others explode into pandemic? Some diseases disappear, totally disappear, while other explode into pandemic. Have you ever thought? And that's the story epidemiology tells us. So here is the question that should arise in your mind before studying epidemiology. Okay, so what is epidemiology? It's a science that protects the people before it treats. It's a preventive science that is protecting the people before it treats. It's a very important branch of medicine. So it's a science where math meets the medicine. It's a science, where number have a purpose. Okay, we will solve many numericals also today. So I will come on the numericals, but here the numbers are with a purpose. Okay, now behind every public health success lies the role of a detective, and that's the true detective, that is the epidemiologist. Who, you know what is the epidemiologist? I mean, who is the epidemiologist? How epidemiologist differs from the clinician? Who is the clinician? Who is the epidemiologist? How they differ? Do you know that? Yes or no? Clinicians save one life at a time. Yes or no? But epidemiologists save communities before even they fall sick. Before even they are healthy, before even they fall sick, they save the communities. That is epidemiologist. This is the difference between clinician and epidemiologist. Or else you can say clinician fight the disease inside the wards, while the epidemiologist fights the disease before it enters the wards. Okay, and that's the real preventive power. So can we say medicine treat one patient, but epidemiology protects million of people. So with this understanding, now you will understand what is epidemiology. Now, frankly, you tell me, how many of you feel that epidemiology is a very dry, boring, monotonous topic? Tell me in the comment box. How many of you feel so? Do you feel so? It's a very boring topic. It's very boring, monotonous, dry topic. Yes or no? So trust my words. You attend my session just for next 2 hours. Okay, you be with me for the next 2 hours. You will see diseases like Sherlock Holmes sees the clues. Believe my words. Okay, just be with me for the next 2 hours and it will be worth watching. Okay, so let's start the topic now. You understood the introductory part. Okay, now let's start the topic. So what is the bookish language, bookish definition of epidemiology? So the definition of epidemiology is given by John M. Last, the greatest epidemiologist and a very expert public health expert. Okay, that is John M. Last. You have to write this definition in your exam that I'm going to tell you now. You don't have to write all these definitions which I taught you. This is just for your understanding I taught you. Okay, this one. You don't have to write. This is for your understanding. But what definition you have to write in your exam, or you have to, take in your MCQs, that is the given by John M. Last, the greatest epidemiologist, you can see. So this is the definition. You have to learn this definition word by word. Okay, so you don't have to mug it up. Now you will understand it because you have your concept clear. So what is epidemiology? It's a study. Obviously, it's a study of what? It's a study of health related events in a specific population, not in complete population of the world, not in complete population of the country. No, in a specific population. So we are selecting a specific population. We have selected a specific population. Now in this specific population, we are studying the health related events. It can be a disease, it can be any event, it can be death. It is health related events. So study of what? Study of, learn it, study of health related events. In whom? In whom? In a specific population. So health related events, what we have to study about the health related events? We have to study their distribution and determinants. So we have to study their D&D. So we have to study distribution and the determinants of health related events in a specific population. Not only this, after studying, we have to apply this knowledge in controlling the disease. We don't have to just study that. Study kiya, chhod diya. No, but we are studying and leaving it. No, we have to study and apply that knowledge in controlling the disease. So now try to figure it out, the definition. Say the definition with me. The definition of epidemiology. What's the definition of epidemiology? It's a study. Study of what? It's a study of health related events in a specific population. From the total population, I am taking a specific population. In this specific population, I am studying health related events. I am studying the distribution and determinants of health related events in a specific population, and I'm applying that knowledge in controlling the disease. That is the definition of epidemiology. Now if you have understood it, you can reframe in your own words. Okay, so that is the definition given by John M. Last that you have to write in your exam. Now before coming on epidemiology studies, okay, before coming on epidemiological studies, I will teach you what studies in detail: case control, cohort, cross-sectional, randomized controlled trial. We will see descriptive studies. We will see them, all of them, one by one, but not now. I will come on this topic later on. Before that, you have to understand the tools of measurement in epidemiology. Otherwise, you can't understand these studies. So we have to go step by step. We can't directly jump on the studies. No, no, that's not my way of teaching. So first we have to understand the tools of measurement in epidemiology. Okay. Those who are asking any doubts now, I will address, I can see in the comments, but in the flow of teaching, it's difficult for me to halt in middle and address your doubts. So those who are asking the doubts related to this topic, let me finish this, this particular topic and then I will address your doubts. Okay, chalo, come on. So let me come on the tools of measurement in epidemiology. There are three tools of measurement in epidemiology. We will quickly see them: rate, ratio, and proportion. First, we have to understand what is rate, what is ratio, and what is proportion. We have already seen them in mathematics, I guess in your 7th or 8th standard, but we will revise them today. Okay, so quickly we will revise what is rate, what is ratio, what is proportion, and then we will come on the studies. Okay, so in all of them, rate as well as ratio as well as proportion, in all of them, there is a numerator, there is a denominator, there is a time specifier, and there is a multiplier. Now, based on the differences between them, I will tell you the definition of rate, ratio, proportion. It's very easy. You just focus for 2 minutes. Okay, what is rate? Let's start them one by one. What is rate? What is rate? Rate is occurrence of some particular event during a given time, okay, in a particular population. Okay, you don't mug up this definition. If you try to mug up the definition, you will get confused. Okay, try to see the formula. You will understand formulas better and then reframe the definition in exam in your own words. Okay, got it? Now, for example, death rate is a rate. It's a type of rate. What I'm teaching you? I'm teaching you rate. There are three tools in measurement: rate, ratio, proportion. So I'm teaching you the first one. The first one is the rate. Yes. So what is rate? Death rate is a type of rate. So what's the formula? You have a look on the formula. In the denominator, we are having mid-year population, the total population of the country, mid-year population of India, for example. Okay, so the denominator having population, total population, mid-year population or total population. The numerator is number of death from that population. Okay, the people who are dying are from the population only. Obviously, they are not aliens. Okay, the people who are dying over here, okay, they are from the population only. So can I say the numerator is a part of denominator? Denominator include total people. Okay, let's say this is 2025 going on right now, the year. Okay, last year 2024 is already past, obviously. So in 2024, what is the death rate of India? What is the death rate of India in 2024? So you say, ki, ma'am, what was the mid-year population in 2024? You say that in denominator. From that, how many people died in 2024? From 1st January till 31st December. How many people are died? Huh? That will be the numerator. Okay, so numerator is a part of denominator. The people who are dying are from population only. They are from not some other planet. They are from the population only. So numerator is a part of denominator. In 1 year, we can say 2024, 2023, 22, any year that has passed. We cannot calculate for 2025 because it's going on. Okay, so any year. So there is a time specifier, and the multiplier is 1000. Usually 1000. It can be 10,000, it can be 1 lakh, it can be 10 lakh, okay, it can be anything but not 100. The multiplier can never be 100 in rate. Rate is never in percentage, mind my words. Rate is never in percentage, people. Rate is never, ever in percentage. Rate, the multiplier in rate, start from 1000. It can be 1000, 10,000, lakh, 10 lakh, crore, it can be anything, but it's never 100. It's usually 1000, but it can be anything. But it's never 100. So what is the definition of rate? You tell me the 4 things about the rate. You tell me about numerator and denominator. Numerator is a part of denominator. Numerator and denominator. So numerator is a part of denominator. First of all, the people in the numerator are from denominator only. Number 1. Number 2, time specifier. Yes, time specifier is usually 1 calendar year. 2024, 23, 22, anything. And multiplier is usually 1000. It can be anything. 10,000, 10 lakh. But it's never 100. It's never 100. You have to learn that. So learn the properties of rate. I hope you got it. What is rate? Now you see the definition. You can recreate it in your own words. So that is rate. Okay, that is rate. Now coming on ratio. I guess everyone know what is ratio. Dividing one quantity by another. Okay, suppose how many boys and how many girls are attending this class right now. Okay, suppose there are 10 boys and there are 3 girls. For example, there are 10 boys in a class and there are 3 girls in class. So what's the ratio of boys to girls? Boys to girls is 10 is to 3. And what's the ratio of girls to boys? It's 3 is to 10. You can see the ratios. Okay, so dividing one quantity by another. Here numerator is not a part of denominator. Just a second. You can see here numerator is not a part of denominator, neither denominator is a part of numerator. They are 2 separate quantity. What is boys upon girl? What is girl upon boys? Like that. Okay, numerator and denominator, they have nothing to do with each other. They are not part of each other. They are not part of each other. That is ratio. There is no multiplier. No 10, no 100, no 1000. There is no multiplier. Okay, so you can see numerator and denominator are two different entities. They are not part of each other in contrast to rate, where numerator was a part of denominator. Here, numerator is not a component of denominator. They are two separate entities. Number one, time specifier may be there, may not be there. In contrast to rate, where time specifier is always there, that is 1 calendar year. Here we don't have time specifier. It can be there, it cannot be there. It's not compulsory, I mean. And multiplier is absent. There is no multiplier, no 10, 100, 1000, 10,000, no multiplier. Got it? So that is the properties of ratio. Coming on the third thing, proportion. Can I start the proportion? Let's start the proportion. The third thing is the proportion. Rate is done, ratio is done, now proportion. In proportion, again, numerator is a part of denominator like rate. Like rate. Yes, you heard me correct. Numerator is a part of denominator. Now you may be thinking, ma'am, then what is the difference between rate and proportion? There also numerator was a part of denominator. But there we have a time specifier, na? 1 year. Here we don't have time specifier. No, it is instantaneous in time. If we don't have a time specifier of 1 year, 1 month, 1 day, we don't have time specifier. It is instantaneous in this instant. Instantaneous in time. No time specifier. We don't have time specifier. Number one. And number two, the multiplier in rate was 1000 or more than 1000. It was never 100. Here multiplier is always 100. So proportion is always in percentage. Proportion is always in percentage. I hope you got it. Now you read the definition, you will get it. Now for example, see the formula of case fatality rate. I will teach you all these topics in detail. What is case fatality rate? I am going to teach you today only. Okay, but have a look on the formula. Grossly, you just see the formula. You decide this formula is rate or ratio of proportion. You decide by yourself. You decide. See the formula. Number of deaths upon number of cases. So the people who are case, suppose there are 100 cases of cancer. Okay, say brain cancer. 100 cases of brain cancer. Out of which 80 are dead. So these people who are 80, they are from this 100 only, no? From these 100 patients only, these 80 are dead. The remaining 20 are surviving. Yes or no? So numerator is a part of denominator, first of all. Okay, there is no time specifier. You can't see 1 year, 1 month, 1 day. No time specifier. And you can see the multiplier is 100. Since the multiplier is 100, it's percentage and it's proportion. So I hope you got the difference between the three. So what are the properties of proportion, you tell me? What are the properties of proportion? Here, numerator is again a part of denominator. Like rate. Time specifier is absent in contrast to rate, where time specifier was 1 year. Okay. And here multiplier is always 100. It is expressed as percentage in contrast to rate. How many of you got it, people? Are you getting it? Yes or no? Kindly reply in the comment box. Are you getting it? Huh? Are you finding it interesting? So we have done the three tools of measurement. What is rate? What is ratio? What is proportion? So I have drawn a flow chart for you people. Can you see this flow chart? How to decide? And if I give you any particular formula, now in PSM we are having many formulas. So from day one only, let me specify. You have to make a separate copy for the formula. Okay, the notes are provided by me. So whenever any formula come now, so you write that copy community medicine formulas. You enumerate all the formulas at one place. So there will be many formulas in biostatistics, screening of the disease, and many chapters we are having So you just enumerate all the formulas at one place. It will be easy for you to solve the numericals by just revising that copy. Okay. Now come. So whenever any formula is given to you, you have to identify whether it is a rate or ratio or proportion. Okay. But you don't have to mug up. The students who don't have this concept, they used to learn. Like infant mortality rate is a rate. They used to mug it up. Okay. Like for example, maternal mortality rate is not a rate. It's ratio. Sex ratio is a ratio. Incidence is rate. But prevalence is proportion. So they used to learn that. I don't think so. You have to learn the formula, but you don't have to learn whether it's a rate or ratio or proportion. You have to decide on site. How you will decide it? So this is the flow chart. You have to follow step by step. How you will follow? First of all, look at the numerator and denominator. Okay. See the numerator of the formula, denominator. We will see the examples. Don't worry. So first see the numerator, see the denominator. Then you see numerator is a part of denominator. Say yes or say no. Say yes or say no. Numerator is a part of denominator, yes or no. These are two different entities. Numerator is separate, Denominator is separate. They don't have any correlation with each other. They are just two separate entities. Is it the scenario? If it is the scenario, it's ratio. There is no confusion. If numerator and denominator are two separate entities, it's going to be ratio. Obviously, we have understood so. So here numerator and denominator, they are not part of each other. They are two separate entities and it's a ratio. But if numerator is a part of denominator, if numerator is a part of denominator, it can be rate, it can be proportion. Now to decide this, you have to see the remaining two things. You have to see for time specifier and multiplier. If the time specifier is present and multiplier is 1000 or more than 1000, it's rate. But if the time specifier is absent and multiplier is 100, that is percentage, it's proportion. So if you are following this flow chart, there is no confusion. I don't think there is any confusion. So can we revise it quickly, people? Can you help me? Rate, ratio, proportion. Summary of rate, ratio, proportion. Say, so numerator, denominator, numerator, denominator, numerator, denominator. They all have numerator and denominator. Here, numerator is a part of denominator. Here also numerator is a part of denominator. But in ratio, numerator and denominator are two separate entities. They don't have any relation with each other. Okay, they are separate quantities. They are just dividing one by other. Okay, now coming on time specifier. What about the time specifier? Here we have the time specifier and that is usually 1 year. Here we can have, we cannot have. Sometimes we have, sometimes we don't have. And here definitely we don't have. We never have time specifier. We never have time specifier. Now third and the last thing, we have to see the multiplier. Here the multiplier is usually 1000, but it can be 10,000, it can be more than that. Here multiplier is absent. We don't have any multiplier. And here multiplier is always 100. So if you are remembering it by this or by this flowchart, anyhow, you can crack the simple MCQs in your exam. Yes or no? So look at the formulas. You have to learn these formulas. I'm not saying you don't have to learn these formulas. I will help you to learn each and every formula in the next 4 months. The next 4 months, I will make these 4 subjects a cakewalk for you. You just believe me. Okay, listen. So all these formulas we will understand. We don't mug up just. Okay, we will understand. And by understanding these formula, we will try to figure it out whether each of them is a rate or ratio or proportion. I'm not reading each of them. Have a look. You can yourself decide. Is it a rate? Is it a ratio? Is it a proportion? Have a look on the formula. See the numerator, see the denominator. You get many MCQs on that. Believe me, you get many MCQs, especially the MCQ portion is from this. Okay, theory portion is not from this. Now I'm having some MCQs. I want all of you to write your answer in the comment box. Let me see who is first and who is correct. Okay, chalo. The first question is in front of you. Read the question, tell me the answer. Let me help you to read the question. All of the following are true regarding ratio, except. The question includes the word except. Now read the 4 options. So which of the following is incorrect for ratio? Can you tell me which of the following? So numerator is the component of denominator. In the ratio, numerator is a component of denominator, yes or no? I don't think so. Numerator is not a component of denominator. Yes. Numerator and denominator are two separate entities. They are not component of each other. I think this one is correct. Yes or no? What do you think? Numerator and denominator are not related values. Okay. It is expressed as a number. Okay. So only this one is incorrect and the remaining 3 are correct. I forgot. It was the except question. So the correct answer is A and all of you are right. Let me see who's the first to answer. Nalan Deva. Yes, very good. Very correct. So Nalan, you are absolutely right. And the answer A is correct. Okay, so can we go on the next? Okay, you can see, you can decide your answer over here. The next, case fatality rate. Is it a rate, ratio, proportion? For this, you should know the formula of case fatality rate. You don't know the formula? I will tell you the formula. What is case fatality rate? What is case fatality rate? What is CFR? Case fatality rate. Here I told you the formula. Na? You can see the formula over here. It's the total number of cases and deaths. So numerator is a part of denominator. You can see the people who are dying are from cases only. But the multiplier is 100. Since the multiplier is 100, it includes rate. The word include rate, but it's not a rate. It's a misnomer. It's not a rate. Actually, it's a proportion. And it's a patent question of the examiner. Since case fatality rate include the word rate, it's a misnomer. Students get confused. They think it's a very easy question. Case fatality rate is a rate. No, it's not a rate. It's a proportion because the multiplier is 100. It's in percentage and there is no time specifier. Numerator is a part of denominator. So correct answer over here is C and most of you are right. Okay, most of you are right. I guess the first one is the Coven. Coven is first one to answer. And most of you are right. Yes, correct. Okay, now before I start the next topic, okay, you must understand what is mid-year population, because I will use this terminology very frequently. What is mid-year population? Before I teach you what is mid-year population, let me ask you a leading question. Let me ask you a question. Okay, you can see this is India. Okay, now in India in 2024, that's already passed. In 2024, what is the population of India? What is the population of India in 2024? Does anyone know? Huh? You see the population keep on changing every day, every minute, every second, I must say, and every moment. Okay, we are talking with each other right now. Okay, every moment, thousands of people are taking birth, and simultaneously thousands of people are dying every fraction of second, every moment, in India, in everywhere. So this thing is, it's a very dynamic situation. It is not constant. I shall tell you one figure. Every moment it keep on changing. So in 2024, it's a big time. Okay, there are 12 months in a year. So which fraction population shall I tell you? 2024 में कौन से moment की population we will take it as a final population? You are getting my point? Because every moment, in January it was different, in February it was different, in March, April, May, June it was different, because every second it keep on changing. People are taking birth, people are dying. So it is plus minus, every moment it is changing. Okay, so let me try to explain you. We will find out a solution for this. So as I told you, there are 12 months and I'm teaching you mid-year population. Mid-year population. So let's take 6 months this side. Let's take 6 months this side. Total 12 months. Approximately July. 1st July is the midpoint. 1st July is the midpoint. 6 months this side. 6 months this side. So 1st July population is mid-year population. The mid-year population is the 1st July population. Since it is the center of the year, approximate, not exactly. If you say that February have less days and all, but approximately it is at the center of the year. So we will take mid-year population as the population on the 1st July. Population on the 1st July every year. In 2024, in 2023, in 2022. Okay, the population on the 1st July is mid-year population. So you get an MCQ on that. 1st July of any year. That is known as mid-year population of that particular year. Okay, now I will use this terminology very frequently. Now, before I come on the studies, before I come on various types of epidemiological studies, case control, cohort, you must understand mortality and morbidity. You must understand what is mortality. You must understand what is morbidity. Not only this, you must understand the measurements of mortality and measurements of morbidity. How to measure mortality in any geographical population, in a country, in a city. How to measure morbidity in any geographical population. So before coming on the measures directly, you must have a understanding of the meaning of these words. Bhai, hota kya hai? What is mortality? What is morbidity? What do you mean by that? What is mortality, morbidity? What do you mean? Meaning kya hai? What is meaning? So let me start them one by one. Mortality. Mortality means death. Okay, the end point, the death. Okay, the end point of life. So death, if we take death as an event in a given frame of time, okay, that is known as mortality. For example, in community medicine, I will teach you infant mortality rate. Okay, it is a death in the infants. Okay, maternal mortality ratio, it is the death in the maternal period. Okay, so that is the mortality. Mortality means death. Mortality means death. What is morbidity? Okay, the two terms look similar, but you have to understand the difference. This is mortality, you can see mortality, and this one is morbidity. Please understand. Okay, what is morbidity? Morbidity means sick, illness, sickness, you can say. Okay, any departure from the health, any departure from physiological well-being, maybe subjective, maybe objective. Maybe the person is subjectively not well, maybe the person objectively not well. But if the person is not well, we will say morbid. It can be any disease. It can be fever, it can be typhoid, it can be malaria, it can be COVID, it can be diabetes, it can be cancer, it can be any disease. The person is not well. That is morbidity. Morbidity means sickness or disease state or illness, whatever you say. Okay, so that is morbidity. So you understand the difference between mortality and morbidity? I guess everyone have understood. What is mortality? It is death, you can see. And what is morbidity? Morbidity means sickness, illness. Okay, deviation from the physiological well-being. You can see the definition. Any departure from physiological well-being. Maybe subjective, maybe objective. But departure from the physiological well-being is morbidity. You have to learn these definitions. What is mortality? Death is the event. Okay, what is morbidity? Departure from the physiological well-being. Maybe physiological, maybe physical, maybe psychological, maybe objective. Okay, now you have to do the measurement. How to measure the mortality and how to measure the morbidity. Can you tell me the ways to measure? How to measure mortality and how to measure morbidity? For example, India 2024. Can you tell me the mortality of India in 2024? How to measure it? How shall I measure? Tell me the steps. What shall I do? I want to know the mortality of India, of a particular geographical population in 2024. We can take any country. For the sake of understanding, I am taking India every time. And we can take any timeline. For the sake of understanding, I am taking 2024 every time. But you can take any geographical population, any country, any part, and you can take any time frame. Okay. How to calculate mortality and how to calculate the morbidity? If I want to calculate the morbidity, how to calculate that? In India in 2024, what are the ways? What are the ways? For mortality measurement, we are having 6 ways. I will teach you all 6 one by one, the formula of all 6. And then we will see the numericals also. Okay, these are the 6 ways of measuring mortality. That's difficult and you get many MCQs on that. And it is important for theory papers also. Okay, and what are the ways of measuring morbidity? Morbidity means I have to say some disease. If I want to measure morbidity, I have to enumerate some disease. Which morbidity? So I want to know the morbidity of TB. Okay, or else I want to know the morbidity of diabetes. I want to know the morbidity of road traffic accident. I have to say any event, any disease. Okay, so you have to calculate the morbidity of that particular disease, particular event. Yes. So for calculating morbidity, we are having 2 different measurements, that is incidence and prevalence. So first we will see the measurement of mortality. I will teach you all these 6 one by one, and then we will come on the measurement of morbidity. I will teach you both of them one by one. How many of you are ready? How many of you are understanding the session? Say something, people. Yes, no. Let me see the comments just a second. Yes, I can see. Okay. Okay. Can we go ahead? So these are the 6 ways of measuring mortality. These are the 2 ways of measuring morbidity. So first we will start with the ways of measuring mortality. So these are the 6 ways of measuring mortality. Mortality means death. How to measure death in a geographical area, in a geographical population? How to measure that? There are 6 ways. What are these 6 ways? The first is crude death rate, known as CDR, crude death rate. The second is specific death rate, known as SDR, specific death rate. Crude death rate, specific death rate. You will see the differences between them. The third is proportional mortality rate, PMR, proportional mortality rate. You have to learn these short forms, CDR, SDR, PMR. You get MCQs like that only. You get an MCQ on PMR. You should know its full form. What is CDR? What is SDR? What is PMR? You should know what is survival rate, SR. You can see this is SR. You know what is case fatality rate? That is CFR. And what is standardized mortality rate? That is SMR. So these are the 6 ways. Okay, so we will make a table. Okay, in this table you can see all the 6 ways are written over here. These are the measures of mortality, that is death. Okay, the 6 measures of mortality. We will see the difference. It's a very interesting topic. You can see this is crude death rate, this is specific death rate, this is proportional mortality rate, this is survival rate, this is case fatality rate, and this is standardized mortality rate. So first of all, you learn their full form, you learn their short forms. Now make this table. Take out your notebooks. What you are waiting for? If you have not yet taken your notebooks, please take out your notebooks, take out your pen and start making this table with me. It will be very useful table for your exams. Okay, you have to write down the formula over here. Write down the 6th formula one by one. In each formula, you have to notice what is numerator, what is denominator, what is multiplier, and what is time specifier. And you have to decide whether it's a rate or ratio or proportion based on the formula. Looking at numerator is a part of denominator, yes or no? Multiplier is 100 or 1000 or multiplier is absent, or time specifier. If you are attending my session from the beginning, you are understanding what I am saying now. So I will tell you the 6 formulas. I will help you in understanding the 6 formulas. After that, you have to decide whether it's a rate or ratio or proportion. We will decide it together. After that, you have to write down the properties. You have to write down the properties of each on which you get maximum MCQs. So can we start one by one? People, be interactive. Can we start? Okay, chal. So let's start it. Let's start them one by one. So this table is already filled for you. One by one we will take it. This is empty table that we will fill again in the end. I will fill it for you again. but this is the pre-filled version. You can see. So write down the formulas over here. In the formulas, you have to mind numerator and denominator. See the numerator, see the denominator. And you have to see whether numerator is a part of denominator, yes or no. Numerator is a part of denominator, yes or no. Number one. Number two, what is the multiplier in each of them? Is it 100, 1000 or absent? And then you have to decide the time specifier, present or absent. And based on that, you decide whether it's a rate or ratio or proportion. That's why I taught you the tools first. Then I'm coming on the measurements now. And then you have to learn the properties. The properties is something based on the formula, you can understand them. Let's start one by one. Let's start the first one. Can you see? I'm starting with the first one. I'm starting with the crude death rate. Let's start CDR. Let's start the crude death rate. CDR. Say the full form. What is CDR? Crude death rate. So what is crude death rate? Crude death rate. Look at the formula. Don't look at the definition. Look at the formula and try to create the definition in your own words. Okay, it will be easier. If you learn the definition and create the formula, you will get confused. So according to me, you should learn the formula. So what is crude death rate? Crude death rate, see the denominator first. Always see the denominator first. In the denominator, you have mid-year population. Appreciate the mid-year population over here. Mid-year population, now you understand what is mid-year population of India in 2024? The population on 1st July, midnight, raat ko 12 baje. So midnight population of 1st July, snapshot, it is taken and it is considered as mid-year population of that particular year, 1st July. Okay, so mid-year population, suppose 2024 of India, and how many people were dying in 2024 in India? So suppose we are talking about India. You know the map of India? I'm drawing just a rough map. Okay, India. Okay, India 2024. India में 2024, what is the mid-year population and how many people were died in 2024? Total people dead from 1st January till 31st December. How many people were dead? You write that as a numerator. And what is the mid-year population on 1st July? You write as a denominator. Okay, and since it is having a time multiplier and the multiplier here is 1000. It's not 100. Mind my words, it's 1000. So this is the formula. This is the formula. Now you decide, is it a rate or ratio or proportion? You see, the people who are dying are from population only. They are not aliens. They are from this population only who are dying. The people who are dying are from this population. So numerator is a part of denominator. There is the time specified, that is 1 calendar year. And there is a multiplier which is 1000, not 100. So it's a rate. No need to learn, it's a rate. So crude death rate is actual rate. It's a rate. So you know, denominator is mid-year population. You get MCQ on that. Okay, among the 6, it is the simplest measure of mortality. Among the 6, there are 6 types of mortality. Now, I will teach you all. This one is the simplest. This one is the simplest. You get MCQ on that. It is not best. It is not best. The best one will be the last. The best one will be the last. Please mind my words. You get 2 questions. The simplest measure of mortality, answer is CDR. The best measurement of mortality, answer is SMR. Understand? Why? I will tell you reason also. Okay, got it? So this one is the simplest one, but not the best one. You can write down in the bracket, not best. It is simplest, but not best. You are getting it? What is crude? Crude का मतलब क्या होता है? What do you mean by crude? The word crude. Crude means all. Non-specific. Non-specific means all. So here in the numerator, we are including all death. See the word all. Highlight the word all. Mark the word all. You're getting it? All death. Whether the death is due to diabetes, death is due to cancer, death is due to heart attack, cardiovascular disease, death is due to cancer, suicide, road traffic accident, any death in India. Okay, death due to suicide, homicide, any death in India, all death in India we are including. That's why the word is crude. Okay, it is not specific because it does not specify any particular death. We are including all. That's why crude. And that's why it is the simplest, but not the best. Not the best. Okay, it reflects the health status of the area. If crude death rate of some area is more, more people are dying in that area. If crude death rate of some area is less, so it means that area less people are dying. Okay, so it indirectly reflects the health status of a geographical area of a country. Suppose we are comparing the crude death rate of India and US. We are having 2 countries. So what's the crude death rate of India? What's the crude death rate of US? And we can compare the health status of the 2 countries by comparing the crude death rate. It is the simplest measure of mortality. Yes or no? So these are the properties. We are done with the first one. Okay, crude death rate is done. We have to go with 6. Out of 6, 1 is done. Okay, remaining 5. Yes or no? You can see. Crude death rate. Learn the formula. See the denominator first. Make a habit. First we have to see denominator. The denominator is mid-year population. You know what is mid-year population. The numerator is all death. All. Include the word all. All death. And multiplier is 1000. Since the multiplier is 1000 and numerator is a part of denominator, it's a rate. It is the simplest measure, and we include crude. That is all that. Coming on the second one, you understand the second one by yourself now. It is specific death rate. This was crude. Crude. Say the word crude. Bolo. Say crude. Say the word specific. Specific is opposite of crude. Crude is non-specific. Okay, and I am teaching you specific death rate now. SDR. What is SDR? It's specific. It's not crude. It's specific death rate. The opposite of crude. Okay, it includes specific death. Okay, the denominator is same. The denominator is still mid-year population. The denominator is still mid-year population, like the crude death rate. But the numerator don't include all death. It includes death from a specific cause. Maybe the death due to diabetes only diabetes death. Okay, maybe the death due to TB, maybe the death due to cancer, maybe the death due to suicide, maybe the death due to road traffic accident, maybe death due to any particular cause, any particular group, any particular timeline. That is specific death rate. And multiplier here also we have 1000. So the people who are dying are from population only. The people who are dying are from this population. They are not aliens. I am saying again and again. So again, numerator is a part of denominator. Multiplier is 1000. It is also rate. It is also rate. But it is specific. Okay, the specification can be of three types. It can be cause specific, group specific, period specific. I will give you three examples. What do you mean by cause specific? What do you mean by group specific? What do you mean by period specific? What is cause specific? Okay, so denominator is mid-year population. Numerator is people dying due to diabetes. Cause specific, people dying due to TB, people dying due to cancer. Some specific cause. Okay, that is cause specific. Group specific, what do you mean by group specific? You can see total number of live birth, denominator, total number of live birth. From the total number of live birth, how many 1 year, less than 1 year, I mean infants. So we are taking a particular group. We are not taking particular disease. Here we have taken particular disease, specific disease. Here we have taken specific group. I mean infants, under 5. We can take any group, maternal mortality during pregnancy, like that. We are taking any particular group, or it can be period specific. So we are taking mid-year population of India in 2024. Always consider India in 2024. Okay, mid-year population, for example, India in 2024 का mid-year population, and numerator is number of deaths in the March in India in 2020. Okay, so we are taking period specific. Period. So it can be period specific, it can be group specific, it can be cause specific. So specification can be of three types. What are the three types of specification, people? It can be cause specific, I mean particular disease. It can be group specific, I mean any particular group, I mean infants, under 5, maternal, like that. Or it can be period specific, particular month, particular day, like that. So there is specific. It is not crude. We are not including all, I mean all disease, all groups, all months. No, we can take particular disease. We can take particular group. We can take particular period. So it is opposite of crude. You got my point, huh? What are the properties? Here also denominator is mid-year population. There also denominator was mid-year population. Here also it's mid-year population. It is also rate because multiplier in both of them is 1000. Okay, but it is good for comparison. It is good for comparison. What do you mean by that? For example, I'm comparing SDR of two diseases. Suppose SDR of diabetes and cardiovascular disease. Okay, cardiovascular disease in India in 2024. So what is the numerator? What is the denominator? What is the numerator? What is the denominator? Huh? Denominator in both of them is mid-year population. Okay, mid-year population. Here death due to diabetes, and here death due to cardiovascular disease. Multiplier is also same. Multiplier is also 1000. So I can compare now. People are dying in India. People are dying more of diabetes or more of cardiovascular disease. So it is good for comparison. It is good. Crude death rate is not good for comparison, but this one is good for comparison. I can compare all the deaths. Okay, and I can see what is the biggest cause of death in India. And we can compare. It is good for comparison. So learn this point. It is good for comparison between different causes with the same population. For example, our fixed population is India. So that is specific death rate. So we are done with two till now. Compare them. See, we are done with crude death rate. We are done with specific death rate. See the denominator of both of them. See, here also we have mid-year population. Here also we have mid-year population. See the numerator. Here we include all death. Here we include specific death. Specific death. Here we include all death. Here also 1 year. Here also 1 year. Multiplier is 1000. Both of them are rate. Okay, but this one is simplest and crude. This one is good for comparison. Got it till now? Everything is fitting, imbibing in your mind forever? Yes or no? Coming on the third. The third is PMR. What is the full form of PMR? What is the full form of PMR? It's proportional mortality rate. Is my speed is good? Am I too fast? I don't think so. I guess you are getting it. Yes or no? You are getting it? Write down in the comment box, please. Are you getting it? We will solve some numericals also based on that. Okay? Just a second. Okay. Yes. Yes. Perfect. Thank you. Thank you. Thank you for responding. So coming on the third one. The third one is proportional mortality rate, PMR. It is death upon death. What is proportional mortality rate? I call it death upon death. What do you mean by death upon death? What is PMR? Proportional mortality rate. The numerator and denominator, both of them are death. I mean death upon death. The denominator is not mid-year population. Mind my words, like CDR, like SDR. No, it is death. It is total death. Total death in India. How many people died in India in 2024? How many people died in India 2024? Total death. So total death is the denominator. Out of which specific death. Death due to some specific disease. Okay. Maybe diabetes, maybe TB, maybe any disease. That is the numerator. And multiplier is 100. 100. That is percentage. Okay. So it will be a proportion. It will be a proportion. Okay. So out of the total death in India, out of the total death in India in 2024, how many people were dead because of TB? So the people who are dying of TB are from the total deaths only. So numerator is a part of denominator and the multiplier is 100. Okay. So it is a proportion. It is a proportion. I hope you got it. So it is death upon death. You are getting my point. See, I call it death upon death. Death from a specific disease upon total death. Death upon death. Into 100. Mind it. Mark it. It's 100. It's not 1000. You can take any disease. Out of the total death, how many people died of TB? How many died of diabetes? How many died of cancer? Like that. So out of the total death, how many people are dying of a particular disease? Into 100. And that is expressed as percentage. And that is PMR. So PMR, denominator is not M by P. Denominator is not mid-year population. No. No, learn it. Like CDR, like SDR. It's not mid-year population. Okay. And the multiplier is 100. It is expressed as a percentage and that's why it's proportion. It's not rate like CDR, like SDR. Okay. And the specific thing is that it is the measurement of burden of disease in a community. We can see the burden of the disease now. Calculate PMR for TB. Out of the total death, how many people are dying of TB? Out of the total death, how many are dying of diabetes? Out of the total death, how many are dying with cancer? So what is the burden of TB in our community in India? What is the burden of cancer in India? What is the burden of diabetes in India? Like that. So it is helpful in calculating the burden of disease in a community. Burden of disease. Learn this word. Burden of disease. Okay. So that is the specific points regarding PMR. Appreciate the denominator here. Appreciate the denominator here. Appreciate the denominator here. Here it's mid-year population. Here it's mid-year population. Here it's total death. Okay. Appreciate the multiplier. Appreciate the multiplier. 1000. Here it's 100. Appreciate it is rate. It is proportion. Okay, this one is simplest measure. This one is good for comparison. This one reflects burden of disease. Please fit in your mind. You get many MCQs over here. You can't afford missing this topic. If you are not learning this topic, you are doing a big mistake. Okay, coming on the fourth indicator. Can I come on the fourth indicator? Let's come on the fourth indicator. The fourth indicator and fifth I will take together. Fourth and fifth I will take together. What is the fourth and fifth indicator? This is survival rate. This is case fatality rate. I will take them together because they are complementary to each other. You will understand them together only. First, you see the full form. What is the full form of SR? Say survival rate. What is the full form of case fatality rate? SCFR. It is case fatality rate. First, you learn their full form. Now, see. Listen. Everyone on the screen. Everyone here. Listen. See on your gadgets. Listen. So, this is a population. This is a group of people. They all have brain cancer. Unfortunately, they all have brain cancer. Suppose, okay, suppose they all have brain cancer today in 2025. Suppose, okay, for example, they all took treatment, chemotherapy, radiotherapy, okay, they all took the treatment, surgery, whatever treatment was applicable, they have taken that. So this is a group of people, they all have brain cancer detected this year only, 2025, they all are on treatment, they took the best possible treatment, chemo, radio, surgery, whatever possible for them, okay. Now after 5 years from today, that is in 2030, okay, this is 2025. 2025, they all detected brain cancer. They were treated. 2030, after 5 years from today, after 5 years from today, okay, some of them are lucky and they survived. They are still surviving after 5 years in 2030, but some of them were unlucky. After 5 years, they didn't survive within this 5 year. Maybe in 2026, 27, 28, 29, they are dead. Okay, so some of them are dead. Okay, they didn't survive for 5 years. You are getting my point, what I am saying. So this is known as survival rate. Okay, and this is known as case fatality rate. Okay, suppose these are 100 patients. Okay, count them. Suppose these are 100. They all took the same treatment in 2025 today. And after 5 years, 20 of them survived and 80 of them are died within the span of 5 years anytime. Maybe in 26, 27, 28, 29, maybe anytime. They are dead. So I will say survival rate is 20% and case fatality rate is 80%. So they are complementary to each other. If 20% are surviving, so obviously 80% are dying. 100 minus 80, 100 minus 20 is 80. So they are complementary to each other. I hope you are getting. I'm trying my best, people. Please respond. I have put so many images, animations, and flowcharts in a dry subject like community medicine. Have you seen the books of community medicine? They don't have images. Most of the books don't have images. But see my notes. See, my book is under publishing. See, it will be released soon. Okay, and they have abundant of images. Okay, same with the forensic medicine. They have abundant of images so that you have a better understanding in your mind. With the help of images, it imbibe in your mind. Yes or no? So what is survival rate here? 20%. And what is case fatality rate over here? It's 80%, you can see. So what is the definition? Now you see the definition. In both of them, what I have done. In both of them, what is the denominator? What's the numerator? You tell me. So survival rate, what is the denominator? What is the numerator? Case fatality rate, what is the denominator? What's the numerator? What is the multiplier? You have to tell me three things. Denominator, numerator, multiplier. The thing is over. That's it. Okay. Now denominator in both of them is cases. Case of brain cancer. For example, in our example, it was brain cancer. It can be any cancer. It can be any disease. So cases is the denominator. Out of the total cases of brain cancer, in both of them, the denominator is cases. Patients or cases, whatever you say. The denominator is not mid-year population like CDR, SDR. The denominator is not death like PMR. The denominator is cases, patients, cases who are diagnosed as disease, any disease. In our example, we took brain cancer. Out of the total cases, how many survived after a particular span? In our example, we took 5 years. We can take 10 years, we can take 20 years. It's our choice. Okay, so how many survived after 5 years? Okay, and here how many of them are died after 5 years? This is the definition. This is the formula of both of them. Multiplier in both of them is 100. Okay, now the people who are surviving are from cases only, and the people who are dying are from cases only. So in both of them, numerator is a part of denominator and multiplier is 100. So both of them become proportion. It is not rate, it is not ratio, it's proportion. Both of them are proportion. I hope you are getting it. People respond. Say, yes. So you understood what is survival rate and what is case fatality rate. Say. So this is survival rate, this is case fatality rate. See the formula of both of them. Now can I start? I shall start the next two. Survival rate followed by case fatality rate. See the formula. Okay. Now survival rate. You tell me the formula. What's the denominator? Denominator is mid-year population? No. Total death? No. Denominator is cases. Cases or patients. Total cases or total patient. Out of the total cases, how many survive? How many survive after 5 years? Into 100. Multiplier is 100. That is survival rate. You create definition by your own. Don't try to mug the definition. People in my class. If you try to mug up now, you will forget the thing. You will forget the concept. Learn the formula. From the formula, you can recreate the definition in the exam. In your own words. Learn the formula. Don't do the mistake in the formula. Especially in the denominator. If the denominator is right, definitely numerator will be right. And multiplier. You have to focus on the multiplier of each of them. Whether it's 1,000, it's 100, like that. Okay, this is survival rate. Okay, so you know the formula. You tell me the properties. What's the denominator? Learn the denominator. I have enumerated the denominator in all of them. So you have to focus on denominator. So here denominator is total cases or total patients. Since the multiplier is 100, it's proportion. It's in percentage. It tells us the prognosis of the disease. Now, here I told you the example. You see only 20% out of 100, only 20% are surviving. 80% are dying. That's a very bad thing. So can I say that brain cancer have a very poor prognosis? After 5 years, only 20% people survive and 80% usually die. So prognosis is poor. So looking at the survival rate, we can comment on the prognosis of the disease. Can we comment? Yes. So it indicates the prognosis of the disease. Understand it. You will never forget, people. If you try to mug up now, which is the indicator among the six of them, which is the indicator for prognosis of disease, you will forget. But once you understand, you will never forget. Okay? It indicates the prognosis of the disease. Not only this, it's the yardstick for the assessment of standard of therapy. Listen, again, one more example. These are 100 cases of brain cancer in 2025. They all have brain cancer. These are 100 cases of prostate cancer. They all have prostate cancer in 2025 right now. They are diagnosed with brain cancer, unfortunately. They are diagnosed with prostate cancer, unfortunately, 2025. Okay, they took the treatment of breast cancer, brain cancer, the best available treatment today's date. Okay, and they took the treatment for the prostate cancer after 5 years. Here, after 5 years, here, I mean in 2030. Let's see. So here, only 20% of them survived and 80% died. Here, reverse occurred. 80% survived and only 20% died. You see now why it's like that? Here 20% surviving and here 80% surviving. Huh? Why like that? After 5 years, both are cancer. So I must say treatment. Here the treatment which is available is not so good. Yet we have to discover better ways of treating them. It's under discovery. It's under intervention. Invention. Yes or no? But here we have good treatment available. That's working and that's why people are surviving. Yes. So can I say, looking at the survival rate, we can comment on the standard of therapy available for that disease. And survival rate are basically for cancer studies. We usually compare cancers for them. So these are the important properties you have to learn. Survival rate. Survival rate indicates prognosis of the disease, indicates the standard of therapy of the disease. Indicates two things. What two things? What two things it's indicating? Prognosis of the disease, and it is indicating the standard of therapy. Yes or no? And it is good for cancer studies. These are the properties. This you already know. So this is survival rate. After survival rate, coming on case fatality rate, you already know that. We have done the survival rate. Now we will come on case fatality rate. So let's come on case fatality rate. What is the formula? You tell me the formula. Huh? What is case fatality rate? This one is the case. The people who are dying after 5 years. The people who are not surviving. The people who are surviving is survival rate after 5 years of treatment. The people who are not surviving, they are dying. Okay, that is case fatality rate. So what is case fatality rate? Can I say? It is the complement of the survival rate. 100 minus survival rate is case fatality rate. If survival rate is 20, so case fatality rate is 100 minus 20. That is 80. That is 80. So can I say it is complementary? Complementary to the survival rate? Yes. It is a complementary of the survival rate. It is 100 minus survival rate. 1 means 100. Consider 1 as 100. 100 minus survival rate is case fatality rate in terms of percentage. Okay, so this is case fatality rate. What is the formula? Formula, denominator is same. Cases, total cases. Out of the total cases, after 5 years, how many are dead? After 5 years, how many are dead? They are not surviving. After 5 years, they are dead. And multiply here is also 100. So it is also a proportion. Okay, so denominator is same. Cases or patient. It is also a proportion. So it indicates the killing power of a disease. You are understanding? It is indicating the killing power of a disease. If I say the case fatality rate is 80% of the brain cancer, you will say my brain cancer is having a high killing power. It is killing 80% of the people in 5 years. Huh? Only 20% are surviving. So it is indicating the killing power of a disease. Or if it is a communicable disease, it is indicating the virulence of the organism. You know, bacteria, viruses, they have virulence. Virulence is tendency to infect the human. So it is virulence. It is indicating the killing power of the disease, or it is indicating the virulence of some organism. So survival rate indicates two things. Case fatality rate indicates two things. What are the two things they are indicating? You tell me. You have to learn the properties, people. I'm trying hard so that it fits in your mind during the session only. So survival rate indicates two things. It is indicating prognosis of the disease, and it is indicating the standard of therapy. Standard of therapy. Which cancer we are having good therapy, for which we are not having good therapy, like that. Okay, and here case fatality rate indicates two things. It indicates the killing power of a disease, and it is indicating the virulence of organism. You have to learn that. You have to learn that for your MCQs. Okay, so that is, we are done with the 5. Till now we are done with the 5. What 5 we are done? Now we will come on the last indicator of mortality. That is standardized mortality rate, the best indicator among the 6. Yes? You tell me what 5 we have done till now. You can see crude death rate. The denominator is mid-year population. Standard death rate. The denominator is again mid-year population. Here numerator is all death. Here numerator is all death. Here numerator is specific death. Specific death. Multiplier in both of them is 1000. That's why both of them are rate. Both of them are rate. Okay. Now proportional mortality rate is death upon death. Okay, death. But multiplier is 100. Multiplier is 100. That's why it's a proportion. Okay. Now the next two, that is survival rate and case fertility rate. The denominator of both of them is cases or patients, one and the same thing, cases or patients. Here numerator, how many of them are surviving after 5 years, and here numerator is how many of them are dead after 5 years. Multiplier in both of them is 100. That's why both of them are proportion. And learn their properties. Who indicates the burden of disease? Who indicates the prognosis of disease? Who indicates the standard of therapy? Who indicates the killing power of disease? Who indicates the virulence of the disease? Who is good for comparison? Who's the simplest indicator? You get questions on that. I tried hard to explain each of them with their formula, with their tool, and with their properties. Can I come on the last one? People, anyone who is interested, raise your hand. Say. Got it? Am I not audible? Abhishek is saying I am not audible. The one who are live, can you tell me, am I audible or not audible? Am I audible? Someone in the audience is saying I'm not audible right now. Kindly write down so I will continue the session. Am I audible? Sumanna, Bogla, Pragna, am I audible? Okay, thank you for responding. The people who have responded, thank you so much. So I guess the problem is with some student, they should check their internet connection. Yes, okay, thank you so much, thank you. Thank you so much. Thank you for confirming. Okay. So let me come on the last indicator of mortality. Okay, which is the best one among the 6? I have not yet told you which one is the best. I told you which one is the simplest. The simplest is the first one, crude death rate. But which one is the best? None of them is best. The best one is yet to come. That is standardized mortality rate, SMR. Standardized mortality rate is the best indicator of mortality. Why? Why is the best indicator of mortality and why we need so? What is the need? Before introduction of anything, you must understand its requirement. You must understand its need. Okay, let me come on SMR. What is the full form of SMR? Standardized mortality rate. SMR. Standardized mortality rate. Let me explain you what do you mean by. Let's take India. Okay, suppose currently I stay in Indore. Okay, it is in Madhya Pradesh. I'm staying here in Indore, Madhya Pradesh. I want to switch to some other city. Okay, due to any reason, I want to switch. Okay, now I'm having two options of switching. I can switch in Mumbai, I can switch in Delhi. For example, Mumbai and Delhi. Okay, I'm having two options. I can switch Mumbai, I can switch Delhi. So what should be my criteria? Okay, there can be lots of criteria based on which I can take my decision. For example, I want to compare the health status of the two cities. I want to change my city and I want to check the health status of Delhi and Mumbai. Okay, and the one which is having a better health status, I will shift in that city, for example. Okay, so for comparing the health status, I thought to compare the crude death rate. Okay, let's see what is the crude death rate of Delhi and what is the crude death rate of Mumbai. How many people are dying over here? And how many people are dying over here? Death is not a good thing. No? The people who are dying, the city where people are dying more, it indirectly indicates the health status of that city is not good. Maybe the hospitals are not good, doctors are not good, or the availability to the hospital or doctors is not good to the people. That's why people are dying more. That might be the common mentality, a common thought we all can have. So till now we are on the right track. I'm thinking the crude death rate. I will compare the crude death rate of the two cities and the one which is having high crude death rate. I will say, no, this is not a good city to shift because people are dying more. The people are not having good health status over there. Maybe not good hospitals, not good doctors, or not good facilities. That's why they are dying more. And the city which is having less crude death rate, that may have a good city because the people are dying less there. They may have better health condition, better doctors, better hospital, better facilities. So based on that, I can take the decision. So what I have done, I have taken the two cities, Delhi and Mumbai, and I suppose this is Mumbai map. I have not taken the exact map. Suppose this is Delhi map and I have compared the crude death rate, the simplest measure of mortality. I taught you the simplest measure of mortality. I have compared the crude death. These are arbitrary figures. People, please don't check them on the internet or ChatGPT or anywhere. These are just arbitrary figures to explain you. So don't put in the comment box that CDR of Delhi is this or it's Mumbai. I know these are not real figures. I'm just explaining you whatever figure came in my mind. I have just put it that. Okay, so CDR, suppose the CDR of Mumbai is 8.8 and CDR of Delhi is 11.5. What does it mean? So out of 1,000 people, 8.8 people die every year over here. And out of 1,000 people, 11.5 people die over here. Okay, so which city out of the two is having better health condition? Here people are dying less. Here people are dying more. Here out of 1,000, 8.8 people are dying. Here out of 1,000, 11.5 people are dying. So here more people are dying, no? So maybe this city, okay, don't have good health condition. Maybe this city have good health condition. Why people are dying more here? Maybe not good doctors, good facilities, good hospitals. Why people are dying less? They may have good facilities, health conditions over there. So that is a thought which is coming in my mind, and based on which I took the decision that I will shift in a city. Which is having less CDR, considering that this will have better health condition and me and my family will get the good health condition, and there are less chances we will die in the next 100 years. Yes or no? So based on that, I'm taking the decision. But is my decision right? Is it a good criteria to compare the mortality of the two population? Don't go on the figures, people. These are arbitrary, just for explanation. Say population X, say population Y, instead of saying the name of some cities. Okay, so population X and population Y. Yes or no? You are getting it? Huh? So based on which I took the decision, I will shift in population X. I will not shift in population Y. Okay, but no, my comparison is absolutely wrong, because I have not compared the composition of the population. I have seen total population, but I have not seen the integral composition of the population. Every population have old people, young people. Yes or no? Here also old people may be there, young may be there, obviously. Here also old people may be there, young may be there. Okay, now everyone dies. That is the eternal fact of life. No, it is not a spiritual lecture, okay, but everyone dies. We all have to die one or other day. Okay, no one is immortal over here. So, but old people dies, there are more chances the old people will ultimately die. Okay, young people chances are less. So the city, the population which is having more old people, the crude death rate will be more, obviously. Okay, and the population, the city which is having more of young people, they will have less chances of death, no? So there will be less crude death rate. You're getting my point. For example, here I got less crude death rate. Okay, here I got less crude death rate, and here I got more crude death rate. Okay, so but maybe why here it is more? I have put the wrong signs. Maybe here old people are more. Here maybe old people are more. That's why crude death rate is more. And here maybe young people are more, and that's why crude death rate is less. Maybe it is like that. Now I have put the conclusion here crude death rate is high because here health facilities are not good. But maybe it is not the reason. Maybe health facilities are more good over here than here. More good doctors, good hospitals, good facilities. But here old people are more. If old people are more, no one can save them at one point of time. Okay, got it? So that's why crude death rate is. So it is not a good criteria to compare the mortality of two population. If you want to compare the mortality of two population, you have to do standardization. It is not standard way of comparing. CDR is not a good way of comparing two population, the mortality of two population. So how to compare the mortality then? We have to consider the age groups. Okay, I mean we have to do the standardization of age. You are getting my point? So we have to take the third population in between, and that is known as standard population. I'm having population X, I'm having population Y. To compare them, I cannot compare them directly. No, there is no way I can compare them directly. If you want to compare two population X and Y, or A or B, or Delhi or Mumbai, whatever you say, any two population you want to compare matlab kya? Mortality comparison I am doing. Okay, I want to compare the mortality, the death rates of the two population. I have to take third population in consideration, and that third population is known as standard population. Okay, then only we can do the comparison. Now you come on the topic, you will have a better understanding now. You got the clue now why we are introducing standardized mortality rate. Okay, so standardized mortality rate. So same thing is written. If we want to compare the death rate of two population, if we want to compare the death rate of two population, population X and population Y, Delhi, Mumbai, any two population. Okay, but they have different age composition. One population have more of old people, one population have more of young people. Okay, they have different age composition. Then CDR is not a good way. We can't compare their CDR. CDR is a wrong way. It can, misdirect us. Okay, it is a wrong way of comparison. We can't compare them based on CDR. That's why if you want to make them comparable, you have to introduce a third population. And third population is standardized population. And that is the best mortality indicator because it is best for comparison. So here we are doing, here age is the confounding factor. No? What is confounding factor? I will teach you tomorrow. Okay, but age is the confounding factor here. One population is having more of old people. One population is having more of young people. So age is the confounding factor which is giving false results. Based on the false results, my decision is wrong. I'm shifting in Delhi, not in Mumbai, thinking that I'm shifting in Mumbai, not in Delhi, thinking that Delhi has poor hospitals, poor doctors. No, but that is not the fact. Actually, Delhi have more good doctors, good facilities, good hospitals as compared to Mumbai. But the thing is that their old people are more. So that's why death rate is more. So it is giving us false results. So we have to do standardization. We have to do age standardization. And that's what we are doing in SMR. SMR is standardized mortality rate. Now you must think, ma'am, why only age is standardized? You must standardize gender also, you must standardize race also, you must standardize everything. No? I mean, I'm having two population. Okay, so why you are standardizing only age? Okay, now here Hindus, Muslims, okay, Christians, here also Hindus, Muslims, Christians. That should also be equal. Na? That should also be comparable. Here also business class, service class, business class, service class. That should also be comparable. Married, unmarried, that should also be comparable. You should compare every criteria, but that's not practically possible. We cannot standardize every criteria. Ideally we should, but we cannot. So the biggest confounding factor is age. If we can standardize on all these criteria, that is the best one, but we can't. That's why we standardize only one criteria, that is age. That is the biggest confounding factor. Ideally we should standardize everything. We should standardize the religion, caste, business, service, okay, married, unmarried, all the factors that can be the composition of a population. Okay, but age is the biggest factor of the death. Okay, deaths in Hindus, Muslims, Christians don't differ much. Deaths in business class, service class don't differ much. But deaths in old and young differ much. That's why age is the biggest confounding factor that must be standardized by taking a third population, that is standard population. I hope you are getting it. It's a difficult topic. That's why with the help of images, diagrams, I'm trying my best to explain you. Yes or no? Till now everything is good? Everything is good? Okay, so coming on standard population. So what is standard population? The third population. You must ask me, what is this population? It is a population in which the death in each age group is known. The death in each age group is known. You can see the each age group. So in this, it can be any population. It can be national Indian population. It can be European population. It can be Selby world population. It can be any population in which this composition is known. Any population can be standard population in which this is known. I mean, 0 to 1, how many people are there? 1 to 4, how many people are there? 0 to 1 year, how many people are there? 1 to 4 year, how many are there? 5 to 15, 15 to 20, 20 to 25. At a 5 year of gap, how many people are there? You should enumerate this number. So this is standard population. Now, how we do the standardization? There are two ways of standardization. Direct standardization and indirect standardization. There are two ways of standardization. Direct and indirect. How we do the standardization? What is the difference between direct and indirect? In direct standardization, we take age-specific death rate of our study population. Study. These are two study population. Population X and population Y. We take the age-specific death rate of these population and apply on the standard. And then we compare. Then we compare the CDR of the two. Okay, we apply the age-specific death rate over here, apply it over this population. We take the age-specific death rate from here and apply it in this population. And then we compare the CDR of the two. Okay, that is direct. In indirect, we take the age-specific death rate of the standard population, not of study population, and apply it on the study. That is the indirect. Here we are taking ASDR, that is age-specific death rate. In every age group, we take the death rate. I will give the example also. So we take the age-specific death rate of the the two study population and apply it on the standard population. That is direct way of standardization. In indirect way of standardization, we are doing the reverse. Here we are taking age-specific death rate of the standard population and applying it on the study population. Okay, you don't have to go much detail, but you have to understand this difference. Here we are taking age-specific death rate of the study and applying on the standard. In indirect, we are taking the age-specific death rate of the standard and applying it on the study. So we are doing reverse. Okay, so that is direct versus indirect standardization. Okay, I will show you some numericals based on that. Here only you have to learn that. And here we calculate SMR, standardized mortality rate, standardized mortality ratio actually, SMR. Observed death upon expected death into 100. Observed death, okay, observed death in the study population, expected death in the standard population into 100. Like that we calculate into 100, and it's a ratio. It's a ratio. Okay, it's a ratio you have to learn. So we are done with the 6 formulas. People, we are done with the 6 ways of mortality with their formulas, with their tools. Is it a rate? Is it a ratio? Is it a... It is a proportion. You will decide based on the formula, based on the multiplier. Okay. And finally, you have to learn the properties. You have to learn the properties of all of them. Properties pay, you get many questions. Believe my words. Believe my words. Can we revise it together? If you people are interested, can we do so? But you have to participate. You can't be quiet. You have to say in the comment box. Okay. Can we revise the formulas first? Based on which we will say, is it a rate, ratio, proportion? In the finally, we will see their properties. Passive teaching is not my way. I can read it passively, but that's not interactive. Okay, we will fill it. We will fill it with full energy. Or better way, you can take out your notebooks, you can take out your pen and make this table with me. If I can make on such a big board, you can make it on your copy at least. Yes or no? So take such efforts, take out your notebooks, copy, and start writing. Make this table with me. Chalo. So can we, now first of all, you tell me numerator, denominator and multiplier in each of them. So write down the numerator and denominator. First denominator. So crude death rate. In crude death rate, it's mid-year population. It's mid-year population. Specific death rate. Here also mid-year population. Okay, then what's the difference between the two? What's the difference between the two? Here, the numerator is all death. All death. And here numerator is specific death. All death means crude. Or specific death means specific. Okay, as the name indicate. Okay, multiplier in both of them is 1000. Here also 1000. Here also 1000. Since the multiplier is 1000, both of them are rate. This is also rate. This is also rate. Okay, I'm right till now. Any confusion till now? I guess it's good. This one is the simplest measure. This one is the simplest measure of mortality among the 6, not best. And this one is good for comparison. Comparison of two population. Comparison of the two diseases in the same population. Yes or no? So we are done with 2. Coming on the third one. Proportional mortality rate, PMR. What's the full form? PMR. Proportional mortality rate. It's death upon death. Death upon death. The numerator is death. The denominator is death. The numerator, denominator is total death. Total death in India in 2024. In 2024, what is the total death in India? From all causes. From 1st January till 31st December. That is the denominator. Among them, specific death will be the numerator. How many deaths were due to TB? How many deaths due to diabetes? How many deaths due to suicide? How many deaths due to accident? How many deaths due to dash, anything? So specific death, the specific disease, specific group, specific period. It can be any specificity. Okay, so that is PMR. Okay, death upon death. But here the multiplier is 100. Multiplier is 100. Okay, since the multiplier is 100, it's a proportion. This was a rate, but this one is a proportion. Appreciate the multiplier. Multiplier is 100 over here. And this one indicates the burden of disease. It indicates the burden of disease in a community. Yes or no? Okay. Now next 2 we will take together. Can you help me with the next 2? They are easy. Survival rate and case fatality rate. Survival rate, case fatality rate. The denominator is total cases. The denominator is total cases. Out of the total cases, how many survive after 5 years? And out of the total cases, how many dead after 5 years? Okay, it is not only 5 years. We can take any time span, 1 year, 2 year, 5 year, 10 year, but particular period of time. Okay, so out of the total cases, how many are surviving? Suppose 100 patients with brain cancer. All of them are treated today with chemotherapy, radiotherapy. Now, after 5 years, how many are surviving? Is the survival rate of the brain cancer? How many of them are dying? Is the death case fatality rate of the brain cancer? The multiplier in both of them is 100. 100. That's why both of them are proportion. Both of them are proportion and they are complementary to each other. They are complementary to each other. What is the properties, people? They indicate two things. What two things they are indicating? Survival rate indicate what? Survival rate indicates prognosis of the disease and it indicates the standards of therapy of a disease. Okay, and case fatality rate also indicates 2 things. It indicates the killing power of a disease and the virulence of a disease. Okay, can I come on the last one? The last one, standardized mortality rate. So what we calculate here, the standardized mortality ratio actually. So here we have observed death, okay, in the study population and expected death in the standard population. We took the third population standard, okay, and that is a ratio. This is ratio. It's the ratio, and it is the best indicator among the six. The simplest one is crude. The best one is standardized mortality rate. And here we do standardization for age. Ideally, we should standardize all, but usually we do age standardization because age is the biggest confounding factor. Am I crystal clear in my words? Am I crystal clear in my words? Yes? Okay. Thank you. Thank you for your compliment. Thank you so much. Can we go ahead? So we are done with the measures of mortality. Yes or no? Huh? So it's time to solve some MCQs. Let's see how much you have understood. Let's analyze. Okay. You have to write down your answer in the comment box. Fast and correct. Okay. Let's see who is first and who is correct. So first question is in front of you. Read the question. Tell me the answer quickly. Let me read the question for you. Following can be used as a yardstick for assessment of standard of therapy. Standard of therapy. Which can be the yardstick for standard of therapy? Is it SDR? Is it CFR? Is it PMR? Or is it SR? The four options are in front of you. What is the correct answer? Yes, most of you are right. The correct answer is D, and the first answer is deep. Deeps is the first answer. Correct. So survival rate is the correct answer. D is the correct answer. I guess you know. So you can see this is the survival rate, and here I told you the two properties of the survival rate. It is the yardstick to measure the prognosis, and it's the yardstick to measure the standard of therapy. Yes or no? Be fast in your answer. Please, everyone participate. At max, you will be wrong. It's okay, but kindly participate. You will learn from your mistakes. Okay, the next question is in front of you. Read the question and tell me the answer. Estimating the burden of a particular disease is measured by burden of disease. Burden of particular disease. Is it PMR? Is it specific mortality rate SMR? Is it crude death rate CDR? Or is it incidence of a disease? What measures the burden of disease in a community? Yes, most of you are right. Yes, who's the first one to write? Vandana is first to write. Yes, good Vandana, good one. So correct answer here is proportional mortality rate, PMR. So I told you over here, PMR indicate burden of disease. It is death per death. It indicates the burden of disease in a community. So that is PMR. Coming on the next question, it's in front of you. Most useful parameter to predict the virulence of an organism or virulence of an illness. The four options are in front of you. Is it SMR, CFR, secondary attack rate, that is SCR, I will teach you, and what is incidence? So out of the four, what is the correct answer? What measures the virulence of the organism? Yes, you all are correct. The first is Monica. Yes, congratulations Monica, you are right, and the correct answer here is case fatality rate. So I told you here, case fatality rate is indicating the killing power of the disease as well as virulence of the organism. So correct answer over here is case fatality rate. Next question over here. What is the denominator of case fatality rate? What is the denominator of case fatality rate? Is it total death? Is it total number of hospital admission? Is it total number of cases due to any disease? Or is it total number of death due to a disease? Here, death due to a particular cause. What is the correct answer? Denominator of CFR. Yes, most of you are right. The first one is again Vandana. Yes, congratulations Vandana. The correct answer over here is C. It is the total number of cases. I told you now, in survival rate as well as case fatality rate, in both of them, it is total cases. Total patient money, total cases. After 5 years, how many are surviving is survival rate. After 5 years, how many are dying is case fatality rate. So correct answer here is total cases. Okay, one more question. Which is best in order to make comparison between health status of two populations? There are two populations, Delhi, Mumbai, population X, population Y. I want to compare their health status, so I can shift in one of the city. I will shift in that population, okay, which is having better health conditions. So me and my family should get a better health condition. So based on what we should decide. Shall I compare the SMR of the two population? Shall I compare the disease specific death rate? Shall I compare the PMR or shall I compare the age specific death rate? What shall I compare before taking my decision? What is the correct answer over here? Yes, most of you are right. The first one, I guess many people are right here. I guess Deep is again first, or Janvi. Deep and Janvi are first to answer. So correct answer is SMR. Most of you are right. Okay, so we can see SMR It is the best indicator where age standardization is done, and we can compare the two population. We can compare the health status of the two population over here. So we are done with the mortality indicators. How many of you got it? So mortality indicators are done. Now we are coming, since mortality, what is mortality? Death. Death yani mortality. We have seen the 6 indicators of mortality over here. You can see in all of them, the death certificate is provided. Whenever any person dies, death certificate is issued by the doctor. Yes or no? So being a doctor, being a medico, you should know about the death certificate, how to fill it, what lines does it contain, because sometime you are on your duty and some death have occurred in your presence in the hospital, in the casualty, in the ICU, and you must have issued, you should issue the death certificate for that particular event. Yes or no? So you should know what you have to fill, how you have to fill. You should have an idea about that. Yes or no? So it's very important aspect to learn. Death certificate. Since we have completed the mortality, before coming on morbidity, I will come on morbidity also, the measurements of morbidity. Mortality is done. I will come on morbidity now. But before that, we will see international death certificate. So mortality ka basis is death certificate. We consider a person dead if the death certificate is issued by the doctor. Okay, so we rely on the doctor who is issuing the death certificate. First, the doctor verifies that the person is dead. Okay, and the doctor will issue the death certificate. Okay, now for national and international comparison, WHO has recommended international death certificate. It's uniform. Whether you are practicing in India, in US, in any country, anywhere in the world, death certificate is same. Death certificate doesn't differ from country to country. It is international death certificate. It is international death certificate. It is same everywhere. It don't differ from country to country, place to place. It don't depend on geographical area you practice. Okay, so for comparability, WHO have given the guidelines for the death certificate. So you should know how many lines it have. Death certificate, apart from the deceased identity, its name, age, address, and all other things, but for what it was admitted to the hospital, what was the hospital stay, what is the time of the death, you have to fill all these things. Okay, apart from that, in the death certificate you have to fill 4 lines. How many lines? 4 lines. You have to fill 4 lines in the death certificate. What are the 4 lines in the death certificate? There are actually 2 lines, line 1 and line 2. Can you see? This is line 1, this is line 2. Line 1 have further 4 lines, 1A, 1B, 1C, 1D. Line 2 don't have ABCD. So basically these are the 4 lines. So you have to fill 1A, you have to fill 1B, 1C is compulsory, but 1D is not compulsory. 1D, if it is applicable, you have to fill it. If it is not applicable, you can leave it blank. But 1A, 1B, 1C is compulsory, and line 2 is compulsory. So being a doctor, being a medico, you should know what you have to fill on these lines. You can't write down anything random. Okay, you should write the relevant cause of death. So what cause of death you have to write down where? On these lines. What you have to write down on line 1A? What you have to write down on the line 1B? What you have to write down line 1C? 1D if applicable. Otherwise you can leave it blank also. But these 3 compulsory you have to fill. And what you have to write down on the line 2? You have to decide that. Yes or no? So 1A, we will write the disease or condition which directly lead to death on that moment. Suppose person dead right now. I'm a doctor, I'm working in an ICU, I'm on emergency duty, and there is one death occurred. Instead of trying hard, we couldn't save that life, okay, and the person is dead. So what is the acute cause of death? Right now, what was the problem because of which the person is dead? Directly leading to death. That we have to write down on 1A. But this problem is due to what? That is 1B. But this problem is due to what? That is 1C. And this what due to what? That is 1D. So the antecedent cause you have to write down on the next lines. With the help of example, you will have a better understanding. Okay, this is a real death certificate. It is like this. You have to put the lines 1A, 1B, 1C like this. And let me take an example. For example, in an ICU, I'm working in an emergency duty, and there is the person who is dead. Instead of trying hard, we couldn't save the person, and person is dead. So acute cause of death was renal failure, bilateral renal failure, acute bilateral renal failure, because of which the person was dead, unfortunately. Okay, so on 1A, I will write down renal failure. But why the kidneys were failed? You should think, why? Kidney cannot fail as it is. There should be some underlying pathology that is causing the renal failure, bilateral renal failure, acute renal failure. Okay, that is causing the derangements and the person is dying. So the person was having diabetic nephropathy. In both the kidneys, the person was having diabetic nephropathy. The kidneys were nephropathy. You know, in pathology, you must know what is diabetic nephropathy. I taught you in pathology very well. So person was having diabetic nephropathy, because of which the renal failure took place. Renal failure cannot be it is acute, but it cannot be directly. No, there should be some underlying pathology. So underlying pathology is diabetic nephropathy. But why the diabetic nephropathy have occurred? Because person was having diabetes since last 20, 30 years, and person was not on proper management. Instead of constant providing medications and insulin, person was not taking it regularly. Person was not taking medicines. Either the person was not aware, or person was neglecting it due to any cause, due to poor condition or due to lack of knowledge, but person was not taking adequate treatment. And that's why, because of uncontrolled diabetes, person had diabetic nephropathy. Okay, so that is the underlying cause. Okay, so here 1D don't have any relevance. We can leave it blank. We can leave it empty. And apart from that, on line 2, you have to write down other diseases the person is having, but that is not related to death. The person is having some other diseases also, but that is not related to currently the cause of death. Okay, so this person, apart from diabetes, was having hypertension also, but the cause of death is not hypertension. So whatever other diseases person is having, you should enumerate it on line 2. So that is the thing. I hope you got it. I hope. So diabetes leads to diabetic nephropathy. Diabetic nephropathy leads to bilateral renal failure. And due to bilateral renal failure, person is dead at this instant. Got my point? So this is example 1. I hope you got it. Coming on one more example for better understanding. Suppose, again, in a ICU, we are working on emergency duty, one more death occurred. Okay. So what is the cause of this death? Currently, the cause of this death is intraperitoneal hemorrhage. Suddenly bleeding took place. Intraperitoneal hemorrhage, person go in shock, hemorrhagic shock, and died. Instead of constant efforts of saving the person, we couldn't save. Okay, so the cause of death is intraperitoneal hemorrhage. But why does bleeding occur? There should be some underlying pathology. No, why bleeding cannot occur as it is? So there should be some underlying pathology. So intraperitoneal hemorrhage is due to ruptured metastatic deposits in the liver. In the liver of this person, the metastatic deposits were ruptured suddenly, and that took so much massive bleeding, and the person goes in shock and died. Okay, so the cause of this is the ruptured metastatic deposit. But why the metastatic deposits were there in the liver? They ruptured, I got it. But why the what is the primary? The primary, why they ruptured? Because there is metastatic deposits in the liver, and here they ruptured, but they were present in the liver, and the primary was in colon. The person was having colon carcinoma. Okay, maybe the person is on treatment or not on treatment, and from colon carcinoma, the metastasis took place in liver. They ruptured, they took the bleeding, they caused the bleeding, and because of bleeding, the person is dead. Apart from that, person have hypertension also, that is on line 2, but that is not the cause of death right now. Okay, so this is how you have to fill the death certificate. I hope you got it. So what you have to fill on the 4 lines, that is important. Okay, what you have to fill on line 1A, the acute condition, the direct condition that is leading to the death. On 1B, the antecedent cause. On 1C, again antecedent cause. And on 2, the other conditions which is not directly related to death right now. Okay, I hope you got it. 1D can be present, can be absent. If applicable, you can write down. Now in the 4 lines, which is the most important line? You tell me which is the most important line. Out of the 4 lines, the most important line is 1C or 1D. If 1D is applicable, go with 1D. If 1D is empty, go with 1C. That is the most important line. And this line is known as absence of death certificate because it is showing the main disease which is causing the death. For example, in this example, again see the 2 example. In this example, diabetes was the main disease. Because of diabetes, person was having diabetic nephropathy. And because of diabetic nephropathy, the person was having renal failure. And that's why the person is dying. So antecedent cause is shown over 1C. That's why 1C is the essence of death certificate. You can see the essence of death certificate. Similarly, in this example also, the main disease was colon carcinoma. This person was having carcinoma colon. That is causing mets in the liver. That got ruptured. That caused bleeding. That caused death. Okay, but the main disease was in carcinoma colon. So here 1D become the line of essence. The line of essence. So line of essence can be 1C or 1D. I hope it's done. Yes or no? Any doubts? Can we go ahead? Is it good to go? Okay. So I'm having a question for you. Read the question, tell me the answer. In WHO recommended death certificate, main underlying cause of death is recorded on which line? I mean, I want to ask the line of essence. The main underlying cause is recorded on which line? 1A, 1B, 1C or line 2? 1D option is not given to confuse you. So what is the correct answer? Absolutely right. The correct answer is C, and Bogala is first to answer. Very good, very good. The correct answer is 1C, line 1C, the essence. If 1D is also given, go with 1D. Okay, 1C or 1D both can be the line of essence. Okay, we are done with measurements of mortality. These were measurements of mortality. We are done with measurements of mortality. Now we will come on measurements of morbidity. Okay, can I come on measurements of morbidity? Let's revise what is morbidity. I already taught you what is morbidity. What is morbidity? Illness, sickness, disease. Any departure from the state of physiological well-being. Any departure. Maybe subjective, maybe objective. Subjective means the person is feeling. Actually, person don't have fever. But when the person is measuring, person don't have fever. But person is feeling like. Okay, that is subjective. And objective means we can measure it. We can measure the disease. So maybe subjective, maybe objective. But departure from health is morbidity. So how to measure morbidity? We are done how to measure with mortality. We know the simplest measure. We know the best measure. We know what measures burden of disease, okay, which is best for comparison, and all the things we know. These are the measurements of mortality. And now we have to measure morbidity. Morbidity have only two measures, incidence and prevalence. So can we start? Are you people with me? So the measures of morbidity are only two, incidence and prevalence. Prevalence is further of two types, point prevalence and period prevalence. One is period. Point prevalence and period prevalence. They are of two types. Okay, but there are two basic criteria that measures morbidity of a disease, incidence and prevalence. How many of you got it? You have to give me 1 minute. I want to drink water. Okay, and I will continue with this. It will take another 15-20 minutes, but we will finish this portion. Okay, give me a minute. Can we continue? Are you people there? Sure. So we will continue with measurements of morbidity. There are two measures of morbidity, incidence and prevalence. We will take them one by one. What is the difference between incidence and prevalence? How to measure the morbidity? For morbidity, you have to say some disease. I want to measure morbidity of TB. Okay, where? In India. Okay, I take all the examples in India only. Okay, I want to measure the morbidity of TB in India. When? The year which is already passed, that is 2024. In entire 2024, what is the morbidity of TB in India in 2024? What is the morbidity? How to measure it? You have two ways to measure. You have two ways. You can measure the incidence of TB. You have to measure the prevalence of TB. What is the difference between the two? The incidence is the new cases in that year. It is the new cases in that year. You are getting my point? New cases. See. This is 2022. This is 2023. This is 2024. 25 is going on. I'm not writing that. Okay. So you can see this is the entire year. 1st January till 31st December. This is 1st January till 31st December. This is 1st January till 31st December. Like that. Okay. Now I want to measure the morbidity of TB in 2024. Can you see where is 2024? This one. I want to measure the morbidity of TB in India. In 2024. Okay. Now there are two possibilities. There can be cases which diagnose TB in 2024 only. Okay, these are the new cases. These are the new cases of TB which diagnosed in this year only, after 1st January, before 31st December. Any of the month, maybe February, March, April, May, June, anywhere. So these are the new cases which are diagnosed in this case. Or the second probability, there can be cases of TB which are diagnosed in the past and they are not yet treated. They are continuing in 2024. Okay, these are the old cases. Okay, but they also have the TB. They are also here. The old cases I am drawing the lines. The new cases I am drawing the dots. So basically I am focusing in 2024. So in 2024, I am having two type of patients of TB over here. I am having some dots. I am having some lines. The dots are the new cases which are diagnosed in this year only. And the lines are the old cases which are diagnosed in the past. They are not yet treated. They are continuing to have TB here. Okay, you are getting my point. So if I take only dots meaning new cases. If I take only new cases, it's incidence. Incidence may we measure only new cases. The denominator is total population. Okay, you can take mid-year population of India. You can take total population at risk. You will say, ma'am, what is at risk? Why you have not written mid-year population? From mid-year population, many of the people have immunized for a disease, for a particular disease. For TB, we have the BCG. The people who have BCG, they have less chances of having TB. So we will eliminate that population. So from mid-year population, if I remove the immune population, so the remaining population is population at risk. So ideally, we should not take mid-year population. We are getting my point. We should say population at risk. But if it's creating confusion in your mind, you can write down mid-year population. For the ease of understanding, it's okay. It is not creating any much difference. You can write down mid-year population. But I have explained you why I have not written mid-year population. Because mid-year population is complete, not population which can have TB. Out of the complete population, we have to eliminate the population which is already immune. The remaining population, that is population at risk, we have to take the denominator ideal. But if it's creating confusion, it's okay, you can take population at mid-year population also. So that is the denominator. In the numerator, we will take only new cases. We will take only new cases which are diagnosed in this year. Okay, not they are coming from the past. Only new cases. That is the incidence. How many of you got it? What is incidence? Any doubt? Any doubt? I will come on the relationship one by one. No? I'll be prepared. I will come on that. Wait. You got the incidence? So out of the total population, okay, out of the population at risk, total population or population at risk, you can see two types of people, the blue and the green. The blue people are the ones who are diagnosed in 2024 only, and the green are the people who are diagnosed in 22, 21, 20. They are still continuing in 2024. You're getting my point? So I will take only blue one. That is the new cases. Okay, new cases we will take here. So you tell me, looking at the formula, and what is the multiplier? I forgot to tell the multiplier. It's 1000. It's 1000. So the new cases are from population only. They are not aliens. From Indian population, mid-year population, population at risk. These are the new cases. I mean, numerator is a part of denominator, and multiplier is 1000. Okay, and its time specifier is also there. So it's the rate. Incidence is the rate. Incidence is the rate because numerator is the part of denominator and multiplier is 1000. And time specifier is also there. That is 1 year. 2024 I consider always. Yes or no? Time specifier is also there, and we calculate incidence in cohort study. I will teach you case control and cohort study also. You will understand it better. But for now, you learn it is calculated in cohort study, not case control study. It is calculated in cohort study. How to calculate it, I will tell you. I will tell you. Wait a while. At that time, you will remember this also. I will remind you this. Okay, so this is incidence. Okay, what are the uses of incidence? It is used to control a disease. If you want to control any disease, you have to see its incidence. How many new cases are arising? Then only you can control it. To control the disease and for research purpose, to understand the etiology and pathogenesis of the disease, you have to see the incidence, the new cases. If you see the new cases, then only you can control it. That is the uses. Okay, now coming on prevalence. In prevalence, we take total cases, old and new both. Old and new both. I told you, no, this is 2024. This is 2024. Okay, 1st January, 31st December. First day of the year, last day of the year. Okay, all the 12 months are over here. Okay, how many cases of TB are there? There are two types of patients. Some who are diagnosed over here only. These are new cases. These are new cases. These are diagnosed here only in 2024. Some are old patient. Old, I mean they are diagnosed in 2023, 22, 21, 20, but they are not yet treated. They are continuing to have the disease. So these are the old. If I take only new, that is incidence. If I take all, not only old, I take old plus new, all, that is prevalence. Prevalence include all the current cases in that particular year. That is old as well as new. If I consider old and new both, that is prevalence. So prevalence means the denominator is same. The denominator is the total population at risk. I mean mid-year population or total population at risk. The numerator include total cases. That is new and old both. It includes new and old both. It is not only new. So what, and the multiplier is 100. Mind it. Multiplier is 100, not 1000. So it's a proportion. It's a proportion. It's not an incidence. It's a proportion. And it is calculated in cross-sectional study. It is calculated in cross-sectional study. Let me tell you. Listen here. Listen. Incidence, prevalence. Okay. Incidence, prevalence. What is the numerator, denominator, and the multiplier? Who will tell me? Denominator, population at risk. Here also population at risk. Numerator only new cases. Here numerator new plus old. That is total current cases. Here new cases, here new plus old. That is current cases. Mind the multiplier. Mind it. People mind it. If I'm saying mind it, you have to mind it. So here multiplier is 1000 and here multiplier is 100. You are getting my point? Yes. So this one is a rate and this one is a proportion. Because here multiplier is 1000, here multiplier is 100. Here numerator is a part of denominator, here also numerator is a part of denominator. I hope you got it. If you are attending my session from the beginning, you are getting it. This one is calculated in cohort study. I will explain later on. This one is calculated in cross-sectional study. I will explain later on when I will explain you the studies. How many of you got it? Everyone give me a thumbs up in the comment box. Each and everyone who is live and understanding, not sleeping, kindly give a thumbs up. in the comment box. Everyone. Got it? Yes. Can we go ahead? Huh? Can we go ahead? Yes. So that is the prevalence. Prevalence is of two types, point and period. You will understand. Okay. And prevalence is used for administrative and planning purpose. Suppose I'm a businessman. I'm not a doctor. I'm a businessman. And I'm having money and I want to open a hospital for the doctors to work. Okay, I'm a businessman. I want to open a hospital in a particular geographical area. I'm having a land in some area and I want to construct the hospital. So I want to construct TB hospital in which only TB patients will get admission. Okay, so I should use what? How many bedded hospital should I consider over here? It depends on incidence or prevalence. I mean, I will give admission to only new cases or all cases. Huh? In a hospital, we give admission only to new cases, or we give admission to new and old. Obviously, we give admission to all patients. Why we will reject the old patient? If an old patient want to get admitted, of course, if it require admission, we will get admitted. So for administrative purpose, for planning purpose, in a hospital, how many bedded hospital, what should be the staff, how many doctors we should appoint, like that. All this planning depends on prevalence. The planning don't depends on incidence. For incidence ka uses, what were the uses of incidence? To control a disease. To control disease, we need incidence. And for planning and administrative purpose, for hospital beds, for doctors, for nurses, for manpower, we need prevalence because we give admission to both. You understand this? Okay. So that is the uses of prevalence. So how to learn that? There is a mnemonic to learn. The mnemonic is incidence contain "and" in the spelling, and money new, and money new cases, and prevalence contain all in the spelling. See the spelling of prevalence. So it includes all cases, old as well as new. So it's a better way to learn, I guess. If you have some confusion, you can learn with the help of the mnemonic. Can we go ahead? Can we go ahead? We are done with incidence and prevalence. Now in the book Park, you know, you must be knowing Park. It's a standard textbook for the community medicine. This diagram is given. This diagram I have not created, but it's a very good diagram I got from there. Now in this diagram, what you can see? Whatever you can see, you just describe in your own language. Please describe. I can see a tap. मुझे एक नल दिख रहा है, tap from which water is flowing, and I can see a bucket. The bucket is having an exit. I can see a bucket or a drum, okay, in which there is an exit. The water is coming, filling in that, and getting exited from there. This is what I can see. Okay, I don't know anything, but I have described the image in my own language. Whatever I can see, I can interpret, I can say it. Okay, so I have seen that. Now, can you say what is incidence and prevalence in this diagram? Incidence is the new water and prevalence is the total water. Okay, so the new water which is entering over here. Can you see the new water? The new water, this is new. The new water which is entering, this is incidence. Okay, after going in the bucket, it is mixing with the old. So the bucket have new plus old both. The bucket have both, na? New plus old. So bucket ka water is prevalence. So the water which is falling from the tap is incidence. And the water in the bucket is prevalence. So what does the prevalence means? The prevalence is the new and old both cases. Okay, I mean they are cases. They have some disease, either new disease or old disease, but they have the disease. How to exit from the disease? Okay, if the person is lucky, person recover. Or if the person is unlucky, person dies, death. So there are two ways to exit. Suppose I'm sick, I'm ill, I'm having some disease. Suppose I'm having TB or any disease, XYZ. Unfortunately, suppose, okay, I'm having some disease. So I want to come out of that disease. There are only two ways. Either I get cured, recover, very good, or I can die. Okay, then only I can exit from the disease. So exit point is two. Either the person recover or the person die. Okay, so fill in the blanks. You can see three fill in the blanks. So what is the new water? Say incidence. What is the total water? New plus old? Say prevalence. And what is the exit of the prevalence? The exit of the prevalence is recovery of death. So you can get these fill in the blanks in this beautiful diagram and you can have a better understanding. The new cases is incidence, the total cases is prevalence, and the exit of the prevalence is recovery of death. How many of you got it, people? Are you getting it? Can we go ahead? You got it? Okay, so this is the diagram. So what we have learned till now, we have learned incidence is the rate, okay, and prevalence is the proportion. Here the multiplier is 1000, here the multiplier is 100. It is calculated in cohort study, it is calculated in cross-section study. What are these studies? I will explain you later on. Okay, got it? So how to calculate? Now you tell me. How to calculate the morbidity of TB in 2024 in India? Can you see India? Beautiful India. Huh? Can you tell me how to calculate the morbidity of TB in 2024 in India? Say, ma'am, I'm having two ways. I can calculate incidence, I can calculate prevalence. Okay, so if you are taking only new cases, okay, it will be incidence. And if you are taking new and old both cases, it will be prevalence. Okay, the denominator of both of them is same. Okay, that is population at risk. Multiplier is different. I hope you got it. We are having one more example, a great example for you. You're getting it? Give me some emojis. Come on, give me some thumbs up. Show some reaction that you are live. Okay, it is not a recorded version. People, you are watching me live. Okay, I can see your reactions. Thank you. Thank you so much. Thank you. Come on. We will solve this. Let's see who got it. Let's see who got it. Chalo, everyone have a look over here. Understand what I'm asking. I'm having 4 questions for you. 4 questions, 4 answers. Everyone on the screen, first you understand my question before jumping on the answer. Don't try to mug up. Don't try to jump. Have a look over here. First understand what I'm asking to you. First understand it. Can you see 2 lines? Can you see 2 vertical lines over here? So this is 1st January. I'm talking about 2024. In entire PSM for the next 4 months, I will be talking about 2024 that is already past. Okay, in 2024, remember the first day of the year, 1st January. Remember the 31st December when we all party, New Year party, 31st December. This is that day. So this is 31st December, you can see, and this is 1st January. This is start of the year, this is end of the year. First you understand what we want to explain with this diagram. Okay, what is dot? Dot is the start of disease. We are talking about TB again. Okay, TB. So this is a case which is diagnosed with TB before 1st January 2024. I mean in 2023 or anywhere before that, the person is diagnosed. The person is continued to have TB in the entire year of 2024 and person still continue in 2025. In 2025, this is the end point. End point can be 2. The person recovered or person died. I don't know. Whether this person recovered or died, I don't know. But this is the end point. So this is the meaning of what. Now, for example, this is case 1. This is the story of case 1. Coming on the story of case 2, this is the start point, which is before 2024. Okay, and but in 2024 only, the person get cured. Either cured or death in January, February only. You can see at the start of the year only. Same see case 3, what happened, the story. Case 4 ka story started here and ended here in this year only. Case 5, case 6. Case 6 started in 2025. Not in 24. Case 7, case 8. You see the story of all 8 cases. When they started, when they continued, and when they ended. The end point can be recovery, can be death. I don't know. Okay, but it can be recovery, it can be death. I know that. So see the start point, see the end point of all 8 cases. There is a story of 8 cases written in front of you. Now, can I ask the question? I'm having 4 questions for you. You understood this diagram? The 4 questions. Now, I will minimize this diagram and ask the 4 questions below. See the 4 questions. Now, looking at this diagram, can you tell me the incidence of TB in this particular 2024 year? Can you tell me the point prevalence on 1st January? Can you tell me the point prevalence on 31st December? And can you tell me the period prevalence from 1st January to 31st December? 4 questions, 4 answers. Answer them one by one. First, answer incidence. What is incidence? Incidence meaning new cases. Only new cases. So tell me the cases which are diagnosed after 1st January and before 31st December. The new cases. See the dots, the new cases. You are getting my point. Case 1 is diagnosed before. 2 is also diagnosed before. But 3 is a new case which is diagnosed in this year. 4 is a new case. 5 is a new case. 6 is diagnosed after this year. I will not take it. 7, again, I will not take it. 8, I will take it. So I will take 3, 4, 5, and 8. 3, 4, 5, and 8. They are diagnosed in this year. The new cases. Okay, the remaining are either before that or after that. They are not new cases in this particular year. You are getting it? Yes, 3, 4, 5, 8. Absolutely right. Many of you are right. I hope you got it. Okay. Now, second question. Second question, tell me the point prevalence on 1st Jan. Where is 1st Jan? 1st Jan, the first day of the year. 1st January. This is 1st Jan. Can you see? This is 1st Jan. On the 1st Jan, tell me all cases. Prevalence. Prevalence माने all cases. Whether old, whether new, कुछ दिमाग नहीं लगाना. All cases. All cases. I can see four cases. Case 1, case 2, case 7. I can see 3 cases. 1, 2, and 7. Which is crossing this line. 2, 1, 2, and 7. Okay, 1, 2, and 7. Now tell me the point prevalence on 31st December. How many cases cross this line? Whether new, whether old, don't think. All cases. All cases. I can see case 1, case 3, case 5 and case 8. So 1, 3, 5, 8. I hope you are getting it. So how many lines are crossing this line? 31st December. And last question, tell me total period prevalence from 1st January till 31st December. Tell me all new as well as old cases. New as well as old cases from this to this. All period prevalence. It is not point prevalence. So all the cases will come except 6. 6 is not coming in this duration. 6 is coming after that. And remaining all are coming. Either they are new or old. So I will say 1, 2, 3, 4, 5, 7 and 8. Not 6. I hope you got it. I hope you got it. So 4 questions and 4 answers. If you didn't got it, you can recap this portion later on and understand it. I hope you got it. Okay. So this is the best example I can give you to understand incidence and prevalence. So we are done with incidence and prevalence. What is incidence? It's the rate because multiplier is 1000. What is prevalence? It's the proportion because multiplier is 100. Here we take only new cases. Here we take new and old both cases. Okay. This one is calculated in cohort study. This one is calculated in cross-section study. Tell me the uses. This one is used for control of a disease. This one is used for administrative and planning purpose of opening a new hospital, how many bedded hospital like that. So that is the incidence and prevalence. Now, the last thing over here is relationship between incidence and prevalence. We understood what is incidence. We understood what is prevalence. Now tell me the relationship between them. Prevalence is equal to incidence into duration. Prevalence is equal to incidence into duration. Please learn this by heart. Please learn this formula. Prevalence is equal to incidence into duration. Please learn this formula. Okay, duration of the disease. Okay, so please learn this formula. If you have understood, how many of you learned this formula? If you have learned this formula, I will ask questions. I will ask 3 questions. 3 questions, 3 answers. But all of them are tricky questions. 3 questions, 3 answers. Who have understood? Everyone have understood. Are you ready? Okay, my first question. Based on which? My first question. There are 3 questions. One by one we will discuss. Please learn this formula. The formula is very simple. Okay, what's the formula? Prevalence is equal to incidence into duration of the disease. This is the formula. I guess everyone knows the formula. It's a very small, little formula. I mean, very easy formula. But 3 questions are tricky. My first question, what is the effect of duration of disease on prevalence? Okay, what is the effect of treatment of a disease on the prevalence? And what is the effect of vaccine for a new disease? We have a new vaccine discovered on the prevalence. You have 3 options. Prevalence in each of them will increase or decrease or constant. You have 3 options. One by one we will take. So my first question, what is the effect of duration of a disease on the prevalence? You see the formula. It's very simple. Who will answer it? Whether the prevalence will increase or decrease or remain same. You have 3 options. Prevalence will increase, prevalence will decrease or remain same with the duration. Look at the formula, na? Say, ma'am, if duration of the disease is more, prevalence will be more. If duration of the disease will be less, prevalence will be less. Because prevalence is directly proportional to duration of the disease. I can see in the formula. Obviously, I can see in the formula. Prevalence is directly proportional to the duration of the disease. Obviously, yes. So since prevalence is directly proportional to duration of the disease, if I increase duration, prevalence will increase. If I decrease duration, prevalence will decrease. Very easy. Okay, this was easy. But please understand the catch over here. So if we are increasing the duration, for example, there is a disease which is TB. TB is having very high duration. You know, the minimum DOTS ka therapy is 6 months. Okay, and disease lasts for months, maybe some years also. So it is having a disease which is long duration. So since the duration of the disease is high, prevalence of TB in the community is also high. If you measure TB in India, how many people have TB in India? You will get a high prevalence. It is not new cases are more. New cases are not much, but the duration of all cases is more. Okay, that's why the prevalence of the disease is more. Got my point? So prevalence of the disease is more because the duration of the disease is more. Since the disease is having high duration, the prevalence is more because prevalence is directly proportional to duration. So that we have seen with high duration, prevalence is high. Now we will see with low duration. Now, which disease have low duration? If the duration is low, prevalence will be low because prevalence is directly proportional to the duration. Which disease have low duration? Low duration can be of 2 types. Either the people recovered or the people died. Okay, we always consider this. We don't consider this. In death also the duration is low. Okay, suppose a disease is a light disease, I mean very minor disease. Suppose runny nose, common cold, we all have it day to day, tonsillitis. Okay, we get cured in in next 3, 4, 5, 6 days. Okay, so duration of disease is less. That's why prevalence is less. Okay, we have common cold for how many days? Maybe 7, 8 days, not more than that. So we have duration less. That is prevalence less. But have you imagined rabies? Rabies is the disease in which person dies very fast. Very fast. Okay, highly important disease. Person dies. Person dies. That is also having less prevalence, because here also the duration is less. So less duration can be of two causes. Either the disease recovered very fast, like the common cold, or the disease is very fatal, like the rabies. Both of them have less duration. This is having less duration because person is recovering very fast. Okay, and this is having less duration because the disease is very fatal. Diseases in both these situations, duration is less. Since the duration is less, prevalence is less. I don't know how many of you got it, but I tried from the depth of my heart. You got my point. So the duration of disease can be less in two situations. You always consider first, you don't consider the second. Okay, so either the disease is recovering very fast or the disease is very fatal. Okay, either the disease is curable, very fast curable, or it is fatal. In both of them, the duration is less. Since the duration is less, prevalence is less. I hope we are done with the duration. Okay, so coming on the next question. Next question is super tricky. The next question is super duper tricky. You tell me, what is the effect of treatment on prevalence? Look at the formula. Apply your common sense. What is the effect on treatment? If I'm treating a disease, whether the prevalence will increase or decrease. If I'm treating a disease, the prevalence will increase or decrease. What is your answer? Whether the prevalence will increase on treatment or whether the prevalence will decrease on treatment. I'm asking you people, kindly answer in the comment box, please. Decrease. Most of you are saying decrease. Sumana, Deep, Bogala, Palak, Anna, Pranitha, life begins. Yes, everyone is saying decrease, but the answer is both. Okay, I will explain how. Everyone is saying decrease, that's the common sense. So that proves you have the common sense. But once you understand the community medicine knowledge also, your answer will change. Okay, now most of you are thinking that on giving the treatment, why the duration will decrease? None of you told me the reason. You will say, ma'am, on giving the treatment, duration of the illness will be less. So suppose I am having TB. Okay, suppose if I take the treatment, I will get cured in 6 months. But if I don't take the treatment, I can have TB for 3-4 years. Okay, so on taking treatment, duration decrease. Since the duration decrease, incidence will decrease. Prevalence will decrease. Treatment don't affect incidence. Incidence any new case, wo to ho gaya na, new case already done. I already have the TB. I'm already a new case. Okay, now if I take treatment, I don't take treatment, new case will not affect it. So it is not affecting incidence. Treatment affects duration of the disease. If I take treatment, my TB will cure fast. If I don't take treatment, duration of the disease will be long. So treatment affects duration. That's what most of the people think. Most of the people think, and this is how you people are right. This is how the one who are saying the prevalence will decrease. Most of you are right partially, not completely. Now, you know there are two types of diseases. How many of you know there are two types of diseases in the world? Huh? There are two types of diseases. Depending we are giving treatment to which disease. There are the disease which are curing, they get cured on treatment. And there are chronic diseases which on giving treatment they don't get cured. Okay, only we are prolonging the life of the person. For example, diabetes and hypertension. Does anyone have diabetic or hypertensive patient at your home? Maybe your parents, grandparents, maybe your relatives, neighbors, anyone. I guess we all have diabetes and hypertension are very common chronic illness we see around us. Our parents, grandparents, relatives, many of them have diabetes and hypertension. Once they have this disease, it's chronic. It's throughout the life till death. They have this disease. It is not curable. Diabetes once happen, it is not curable. Hypertension once happen, thyroid, hypothyroidism once happen, it is not curable. It is throughout, most of the time it is throughout the life. Diabetes, hypertension especially, they are throughout the life. Yes or no? So why we give the treatment? Why shall we give the treatment? You say, ma'am, if they are not cured, why we give treatment? We give treatment for hypertension. I will teach antihypertensive drugs in pharmacology. Why we give hypoglycemic drugs or insulin for treating diabetes? Why we give the treatment? It is not curing the disease, only to prolong the life. Only to prolong the life of the patient. We are prolonging the life and decreasing the complications of the disease. So basically, by giving treatment, I'm increasing the duration of the diseased people on this earth. I do not want these people to get die. Okay, if I don't give them treatment, these disease will exacerbate, they will have complication, and the person will die with the complication of diabetes, complication of hypertension. I do not want that. I just want to prolong their life with the disease only. Okay, they will remain diseased throughout their life, but they don't have complication. On a maintenance therapy, they will survive throughout their life normally only. But I want to give the treatment to prolong the life of the diseased people on this earth. Okay, here I'm giving the treatment to cure them. Here I'm giving the treatment, okay, to prolong the life of diseased person on this earth. You are getting my point? Now take them one by one and tell me what is the effect of treatment on prevalence. So in a curing disease, if I am giving the treatment, basically it is reducing the duration of the disease. For example, if the person is having runny nose, okay, I'm giving antibiotic, person will get cured. I'm reducing the duration. Since the duration is less, prevalence is less, so I'm reducing the prevalence. In chronic disease, in curing disease, we are reducing the prevalence on giving treatment. But if the person is having diabetes, the person is having hypertension, they are not curable. Once they occur, they will be throughout the life. Okay, for a chronic non-curing disease, if we are giving treatment, basically we are increasing the duration of the disease on this earth. On this planet, we are increasing the lifespan, the duration of the diseased people on this earth. We are increasing their lifespan. We do not want them to die. Okay, so basically we are increasing the duration of the diseased people on the earth, and this is how we are increasing the prevalence. So what is the summary? So treatment can increase or decrease the prevalence depending in which disease we are giving the treatment. If we are giving the treatment in curing disease, it will reduce the prevalence. If we are giving the treatment in chronic non-curing disease, it will increase the prevalence. I don't know how many of you got it, but I tried, people, with the help of flowcharts and diagrams. Yes, got it. Curing disease, Amit. Curing disease means on giving treatment, they get cured. And non-curing chronic disease means on giving treatment, they don't get cured. Only we are prolonging the life of such persons by giving maintenance therapy, by reducing the complications. It was a tricky concept, people. Okay, very few students understand this. But how many of you understood? Give me a thumbs up. Give me a thumbs up. Give me an emoji of thumbs up. Or give me a thumbs up in the comment box. The one who understood. No one understood. Everyone. Yes, come on. If you didn't understood, ask me again. Everyone understood the concept. So what is the final summary? On giving treatment, we can increase the prevalence as well as reduce the prevalence, depending which disease we are giving the treatment. If we are giving treatment for a curing disease, it will reduce the prevalence. If we are giving the treatment in a chronic non-curing disease, it will increase the prevalence. That is a summary, and you must have an understanding why I am saying so. My last question. What is the effect of vaccine on the prevalence? What is vaccine or immunization? Are you vaccinated? Are you vaccinated for OPV, IPV, DPT, BCG, flu vaccine? Many vaccines, MMR vaccine. Ask your mommy, ask your mother. Your mother or your parents may have immunized you when you were a kid. I guess everyone is vaccinated or immunized, 100% immunization. Yes or no? I guess. So why we are immunized? What is vaccine? What is immunization? It prevents the diseases which have not yet occurred. Okay, it's a prevention. Vaccine is a prevention. You are getting my point. So it's a prevention, the diseases which have not yet occurred. So by giving vaccine, we are reducing the incidence of a disease. So if I'm vaccinated for BCG, I will not have TB. If I'm vaccinated with OPV, IPV, I will not have polio. If I'm vaccinated for DPT, I will not have diphtheria, tetanus, okay, and pertussis. I will not have these diseases. So new cases will reduce. Okay, duration will not reduce. It don't affect duration. Vaccine don't affect duration. Vaccine affect incidence. If we are giving vaccine to a child, we are reducing the new cases to happen. So it reduces the incidence, so it reduces the prevalence, because prevalence is directly proportional to incidence. I hope you got it. Yes or no? So if we are giving a new vaccine to a children, incidence will reduce. And since incidence will reduce, the prevalence will reduce. Prevalence depends on two things. Prevalence depends on incidence and duration. Okay, so some things affect duration, something affects incidence, and finally it affects the prevalence like that. How many of you got it? Prevalence is directly proportional to both of them. Prevalence is directly proportional to incidence. Prevalence is directly proportional to the duration. I hope you are getting it. So 3 questions, 3 answers. The summary. Who will tell me? Who will tell me the summary? 3 questions, 3 answers based on the formula. Formula is in front of you. Everyone. Formula is in front of you. People say, be interactive. Come on. Chalo, bolo. 3 questions, 3 answers. The formula is in front of you. Tell me the effect of duration of disease on the prevalence. Tell me the effect of treatment on the prevalence. And tell me the effect of vaccine on the prevalence. Duration of illness. The disease with long duration will increase the prevalence. The disease with short duration will decrease the prevalence. Very easy. But short duration diseases of two types. The disease with fast recovery and the disease which are fatal. Both of them are of short duration, and that's why both of them have less prevalence. Okay, that is a summary of duration of disease. Now coming on treatment. Treatment can increase the prevalence as well as reduce the prevalence. Okay, the disease, if we are giving the treatment for curable disease, it will reduce the prevalence. If we are giving the treatment for chronic non-curable disease, it will increase the prevalence. So answer is both. And a vaccine will always reduce the prevalence because vaccine reduces the incidence, and incidence is directly proportional to prevalence. That is the summary. I tried hard. Okay, got it? Got it, everyone? Okay, so this is the summary. You know what is incidence? It is the new cases. Okay, you know what is prevalence? It is total cases, old plus new. And this is the relationship between them. Based on the relation, I told you 3 important questions which are frequently asked in your exam. Very frequent, patent questions. Okay, let me show you some examples over here. Are you people ready? How many of you are ready? Can I throw the first question? The first question is in front of you. Read the question, tell me the answer. Let me read it for you. Following is true about prevalence and incidence. Which of the following statement is true? Both are rate? I don't think so. Huh? Prevalence is the rate, but incidence is not. Is it? Or incidence is rate, prevalence is not. Or both are not rate. What is the correct answer? You people are too slow. Huh? Deep is first to answer. Very correct. So we know incidence is the rate, but prevalence is the proportion. So correct answer is C. You all are right. Now everyone is right. Okay. So incidence is the rate and prevalence is the proportion. You can see incidence is the rate, prevalence is the proportion. Here the multiplier is 1000. Here the multiplier is 100. Okay, got it? In both of them, numerator is a part of denominator. The next question, very tricky question. Very tricky question. A drug which reduces mortality. A drug means treatment. We are giving treatment to a patient for a disease that is reducing the mortality. Okay, I mean increasing the lifespan of the patient, but not curing the disease. The disease is not cured. For example, diabetes, hypertension. We give treatment. We give the drugs. We give the drugs to treat the hypertension and diabetes. They reduce the mortality. Okay, but they don't cure hypertension. They don't cure diabetes. There is no drug yet discovered which cure these diseases. We only decrease their mortality. So what basically we are doing? By giving such treatment. You know the formula. Incidence is equal to prevalence into duration. Now see the core options. What is the effect on incidence and prevalence by giving such a treatment? By giving such a treatment, we are increasing the lifespan of the diseased people on this earth. Because these people are not dying. They are surviving on the treatment for longer as compared if we don't give them treatment. So we are increasing the duration of the disease and we are increasing the prevalence. There is no effect on incidence. Treatment don't affect incidence. Once I have TB, I have TB. On taking treatment, it will not affect my case. I'm a new case. Okay. So incidence is same, but prevalence increases. So correct answer is D. And few of you are right. Not everyone, but yeah, many of you are right. Yes, correct. The correct answer here is D. I hope you got it. It was a tricky question, real tricky. If you want to understand, if you want to mug up, it's okay, you can mug up. But if you want to understand in depth, this was the meaning. I hope you got it. Okay. Now next question is a numerical. You can solve it in your notebook. Chalo. So what is given here? Calculate the prevalence. You have to calculate the prevalence. Incidence is 2 cases per 1000. Okay. Incidence is 2 cases. So incidence is 2 cases per 1000 per year, and duration of the disease is 4 years. So what is the formula? If you know the formula, you can do the calculation. It's very easy. Prevalence is equal to incidence into duration. So 2 into 4, it is 8. 8 cases per 1000 per year, because it is per 1000 per year. So I guess the correct answer is 8 cases per 1000 per year. Per 1000 per year. The correct answer is A. It was a very easy numerical. You don't even have to touch your pen to solve this. Yes or no? Next question. Next question, you have to solve it. Chalo. So in a population of 5,000, so total population is 5,000. Okay, I will say median population or population at risk. Total population is 5,000. Number of new cases is 500, and number of new cases is 500, and old cases is 150. So new cases is 500 and old cases is 150. What is the prevalence? They are asking the prevalence. What is the formula of prevalence? You tell me. So prevalence is the total cases. I mean old plus new. Total current cases. Old plus new. Upon total population at risk. Okay, they have given one population. We will consider that population at risk. But what is the multiplier? Is it 1000 or 100? People, 100. It's 100. Use the correct multiplier. So add the two, 500 plus 150. It will be 650 upon 5000 into 100. You please do the calculations for me. You please do the calculation for me. So this is, I'm not interested in mathematics class. I'm just interested in the concept. If you do the calculation, the correct answer will be 13%. You can do this calculation for me. The same calculation I have told you. Okay, so you can do this rough calculation, and this is how the answer will be there. So we are done with the, what I taught you today. I taught you the measurements of mortality. I told you 6 measures. Yes or no? And measurements of morbidity. Morbidity. I told you 2 measures, incidence and prevalence. And I told you a relationship between them. And here I told you the death certificate, international death certificate. So that was a summary, what I taught you today. Okay, and after that, the next topic we are starting is epidemiological study. Since it is a big topic, so I will start tomorrow only. Okay, so that it will be in continuation. But wait. I want to show you the glimpse what I am going to teach you tomorrow. So tomorrow I will teach you the observational study, experimental study. Here basically I will teach you case control and cohort. Okay, and here basically I will teach you randomized control trial. You can't dare to miss it, and it's a free class. Let me tell you when, time, venue, everything. Okay, wait for just next 2 minutes. After that you can go. Listen, so nobody must have taught you the studies in the way I'm going to teach you. It will be a super unique way. So I'll just show you a glimpse, okay, so that you can attend the tomorrow's class. I will teach you case control and cohort study. Okay, I will teach you RCT. So I will take a hypothesis. What is my hypothesis? My hypothesis is smoking leads to lung cancer. I will prove that tomorrow, in detail tomorrow. Today I am just showing you the glimpse. Smoking leads to lung cancer. Say, ma'am, it's already proven. You are not proving it first time. There are thousands of studies which have proven this. I know. But suppose I am an epidemiologist. I am an epidemiologist, and today, first time, I am going to prove that smoking leads to lung cancer. I will prove that with the help of case control study and cohort study. So how I will prove that? Before I start the case control and cohort study, I will teach you certain terminologies in detail tomorrow. What is the case? Case is the person who has lung cancer, already proven lung cancer. What's the control? Control is a healthy person who don't have lung cancer. So first you understand what is case, what is cancer. Okay, I will use these terminologies tomorrow. Okay, I will use these two terminologies, exposed and not exposed. Exposed is a person who is exposed to smoking, who is exposed to the risk factor. The risk factor here is smoking. The person is a smoker from years. He is smoking constantly. And this person do not smoke yet date. Not smoke yet date. This is not exposed. So I will use the word case, control. What is case? What is control? What is exposed? What is not exposed? You understood these 4 things. What is the case? What is control? Here disease present. Here disease absent. Okay. What is exposed? Not exposed? Here risk factor present. That is smoking. And here risk factor absent. That is smoking. So here disease present, disease absent. Here risk factor present, absent. Now it becomes super duper easy. I will tell you the details tomorrow, but have a glimpse. This is case control study. So from the population, I will take 100 cases, 100 control. Okay, from this 100, I will ask the question, how many of you are smoker, how many of you are not smoker? And from these 100 control, I will ask the question, how many of you are smoker, how many of you are not smoker? From 100 cases and 100 control, I will ask the same question. I will divide them in 4 parts. So some of them are smoker, some of them are not smoker. Some of them are smoker, some of them are not smoker. And based on that, I will do the analytics tomorrow. I will teach you how to calculate all the analytics here. Similarly, in control, from the population, I will take the exposed and not exposed. Here, I have taken 100 cases and 100 control. Here, I have taken 100 smoker and 100 not smoker. See the starting point. Here I have taken 100 cases and 100 smoker, and then see which smoke, which don't smoke, which smoke, which don't smoke. Here I have taken 100 smoker, 100 not smoker, and then following them down the line for 10 years, I will see which have lung cancer, which do not have lung cancer, which have lung cancer, which do not have lung cancer. It's opposite. So this is how I'm going to teach you tomorrow, and randomized control trial is super duper interesting. You can't afford missing tomorrow's session. Okay, this was the first session today, demo session. Today, we have the first one. We have 7 more. Note down the dates. If you want to take the snapshot, please take the snapshot of this. We are having 8 demo sessions, 2 of each subject of the third Prof, 2 of community medicine, 2 of forensic medicine, 2 of, but then we have one break day over here. Then we have 2 of ENT and 2 of ophthalmology. These all are free sessions. The first is done today. The second is tomorrow. Okay, tomorrow's session is also free session, but that is not on YouTube. That is on app. So that is on MedLive by Dr. Priyanka. You have to download this app, install this app, MedLive by Dr. Priyanka app, and it's absolutely free, like YouTube only. Now you may be thinking, ma'am, why not you are taking on YouTube? It's free only, no? You can take it on YouTube also if it's free like YouTube only. Because on the app I'm having many features which is not available on the YouTube. I'm having a feature of poll. Here I'm launching the poll now. So in the poll, I mean in the MCQ, I cannot launch the poll. I mean, I have to see in the comment who's the first, who's the second, who's the third. But there I'm having a feature to launch the poll. Once you click the one of the four correct answer, automatically a leaderboard is generated. You will come to know, you will compete among yourself who is first, who is second, who is third. We are having many important features on our app, and you will have a very engaging lecture, maybe more engaging than today also. Tomorrow you will have a much better experience. Okay, so as compared to YouTube, on the app we are having many much features, and the session is absolutely free. So tomorrow I'm going to teach you case control, cohort, and experimental epidemiology. It's a very important topic. You can't afford to miss it. So you have to download the app. After downloading, installing the app, there are many courses. You have to go in this course. That is third year free demo course. It's a course available on the app. Don't go in the premium course. Go in the free demo course. Third year free demo course, and you will get tomorrow's session over there. The time is same. It's 6 p.m. So time is same in the evening, 6 p.m. Epidemiology part 2. We are going to continue there. I request all of you and invite all of you to come there. The link to download the app is available in the comment section. It is pinned, already pinned. Who don't know from where to download it, please go in the comment section. There is a link given. Click on the link. Just install the app. Nothing you have to do. Install it, and after that you can attend the session tomorrow. Okay, that's it. That's it. One more thing, last thing, the people who were waiting for the demo, there were many students, hundreds of students told me they want to attend at least one demo. So this demo is over, and today midnight 12, the offer is over. The pre-booking offer will be over. So those all students who want to grab pre-booking offer, or who want to grab the existing using offer, only few hours left. At 12 midnight, the offer will be over. After that, normal prices will be there. If you want to have inquire any other query regarding the course, you can note down this number. On this number, calling is not available. WhatsApp is available. So please WhatsApp your query over there. The team will definitely guide you, or you will get a call back from the team. Thank you so much. I wish I could meet you again tomorrow at 6 p.m. Epidemiology episode 2 on app. MedLive by Dr. Priyanka app. It's a free session like YouTube only, but with more features. Okay. Okay then. Bye-bye. See you tomorrow on the app. And a day after tomorrow, we will meet again on the YouTube. A day after tomorrow with the FMT. Tomorrow is Sunday. Monday again we will. The time is wrong here. The time is 6 p.m. only. All the sessions are on 6 p.m. Okay. In forensic medicine, again, we will meet on YouTube. That is postmortem. The first session of all 4 subjects is on YouTube. The second session of all 4 subjects is on the app. And these all 8 sessions are free. I hope you got the concept. Okay. Any other query, you can WhatsApp. Thank you so much. Bye-bye. Good night. And thank you for giving your precious time. I hope this session was worth watching. Each and every minute was worth. Okay. I didn't waste it even a single second, single minute of yours. And I think the session was useful. Okay, chalo. Bye-bye. Good night. Best of luck. And see you tomorrow. Bye-bye. I'm ending the session. Hello everyone. Very good evening to all of you. Am I clearly visible, audible? I have to wait for a few seconds so that you can reply in the comment section. If I'm clearly visible, audible, I will start the class ahead. A very good evening to all of you. I welcome you all for today's session. I am Dr. Priyanka Sachdev here, and today we are going to take second demo session of third Prof Buster 1.0. Right. The subject is community medicine. One by one we will take demo of all 4 subjects, but you have to reply. So the students who are live, Deepak, Bogala, Palak, Pooja, am I clearly visible, audible? Everything is good to go. Can we start? Can we start? Please, if I'm clearly visible, audible, give me a thumbs up in the comment box so that I can start ahead. There's little bit latency I can see. I guess it's good to go. I got the replies. Yes, yes, yes. Thank you so much for replying. Thank you so much for replying. Yes, yes, yes. So welcome you all for today's session. Very, very good evening to all of you. And today we are going to conduct the second demo session of third Prof Buster 1.0. As I assume that most of the students who are attending this session are third Prof students, right? Yes. So before coming on today's topic, I will continue with epidemiology, community medicine, complete epidemiology in one shot. We are going to finish it today, right? I will continue it. But before that, I will just tell you why third Prof is very important Prof. Yesterday also I told you, but it will hardly take 1 minute. Okay, why this Prof is very important? As today many students are new students, so I have to repeat this 1 minute, right? As you know, most of you know that in final year, you have 9 to 10 subjects. Yes or no? You have 9 to 10 subjects. So if you are starting third Prof early and finishing it early along with this my course, that is third Prof Buster 1.0, here I commit you to finish the entire syllabus of the third Prof, that is 4 subjects. I'm counting all 4 subjects, that is community medicine, FMT, that every university have these 2 subjects, and ENT and Ophthal also we are conducting in this batch. Okay, so all 4 subjects I will complete in 4 months in the live sessions, and recordings of the live sessions will be available for 1 year. For ENT and Ophthal, it will be available for 2 years in the combo plan, right? I guess most of you knows that. Okay, so if you are starting it early and finishing it with me in the next 4 months, so in the next 4 months, your third Prof is free. Okay, you are going to get distinction in your university exam if you are a Prof student, and you are going to prepare these 4 subjects for your NEET, PG, INI, CT. Okay, I mean your competitive exam. So these 4 subjects will be done from my side. Okay, so you will get time to start final year subjects after 4 months. Your entire year is free. Just before the exams, you have to revise these subjects. That's it. Okay. So that's why this Prof is very important. Please complete these 4 subjects with me in 4 months. Just 4 months. Okay. With attending your postings, college, everything. The classes will be in the evening. But be attentive in the class, be regular in the class. Once you finish this with MedLive, you finish this with MedLive in the 4 months, you will get time to start these subjects early by your own. So it will give you a few months, maybe I can say 3 to 4 months, okay, so that you can cover some of these subjects of the final year early. I'm not going to teach you these subjects this year, maybe from the next year I will continue, but you will get the time for the self-study or whatever source you follow. So I'm giving you time to start your final year, in advance. Otherwise, if you study by your own, these subjects are not going to finish in the 4 months with excellence. Okay, got it. So that's why we have already launched this course, Third Prof Buster 1.0, in which I am going to teach you all these 4 subjects. There is no other faculty. Many students have the query that who are the faculty? I am the only faculty. I will teach you all these 4 subjects with 100% proficiency. I will teach you the clinical subjects, that is ENT and Opthal with 3D models. Believe me, you attend my demos, okay, you will realize how teaching with 3D models will be easy, and you can understand the 3D structure, and it will fit in your mind. Okay, all the surgeries, everything I will teach you with the 3D models. And these 2 subjects, okay, that is community medicine and FMT, I will teach you with many images, animations, flowcharts and tables. You know my way of teaching. There will be no paragraph in my class. Okay, so that these 2 dry subjects which lack images, it will convert into colorful subjects. I will fill life in them. Okay, chalo. So I will take daily live class 2 to 3 hours. The class timing will be 6 p.m. onwards so that you can attend it live. I request you to attend it live so that it will bring discipline, and you will complete the course in 4 months only along with me. I will complete in 4 months. If you are attending it live, you will also complete in 4 months. But if you think that we will take the subscription and we will watch the recording later on, then that discipline will never come. And again, you will stretch the course. Okay, so I request you to attend it live. I will come on the queries. Wait. Okay. I will complete the entire syllabus in 4 months with 1 year recording available. Starting date was yesterday. Yesterday we started, 11th October. And we will finish it, take my words, we will finish it on 22 February. 4 months, 10 days will be the duration. Okay. And this is the complete calendar. You can see the color coding. We are going to cover all these subjects. In this combo course, I am providing you daily live interactive sessions, teaching with 3D models in the clinical subject. That will be the highlight. Don't forget to attend my ENT and Opthal demos. Okay, if you have not yet subscribed. And recordings will be available for 1 year. I'm providing you 3 types of notes in this course. Okay, digital notes, printable notes, annotated notes. This is a new finding. This is a new feature which was not available in the second Prof. Okay, if you are an existing user. So last time many students found trouble that they couldn't take the printout of the notes. So this time we are giving 100% printout. Each and every word of my lecture will be available in the form of the PDF within 24 hours or 48 hours after the lecture. And you can take printout of that before exam. Just revise that. Watch the sessions, revise the sessions at 2x and just take the printout. Okay. And daily quiz. I will provide you daily quiz of 20-30 questions to analyze how much you have understood in the class. Okay. And question bank will be available and library will be available. Practical library. Okay. This I already taught you for these 2 subjects. I will teach you colorful images, animations, table flowcharts. ENT Opthal I will teach with 3D models. I will take total 87 live sessions. You can see the distribution. Total 87 live session. 87 times I will come live to teach you these 4 subjects. And out of these 87 sessions, 8 of them are absolutely free. 2 of each subject. You can see. So total 8 demos are free. 2 of each subject. You can see the subject. You can see the topic. Today is the second demo. Second demo of the PSM. Tomorrow, don't forget to join me for FMT. A day after tomorrow. Tomorrow and a day after tomorrow. After that, we have ENT and Opthal also. Okay. So if you have any other query, you can text on the support number regarding the course. Okay, now you can ask the query regarding the subject. So let's start epidemiology. How many of you are ready? Can we start it? Can we start it? Yes or no? So let's start it. Let me see. Just a second. Okay. Yes. So, Palak, it's up to you. If you want to make the notes, it's very good. I always encourage students to make the notes in the class if you can accommodate with my speed. But if you can't, after 48 hours, within 48 hours of the session, the printable notes will be available. Each and every word, whatever I am teaching you, line to line, it will be available. Because, in this session, whatever I am teaching you, in the last time also, I do multiple modification to give you the best content. So once the session is done, these notes are finalized. Now my team will convert it into the PDF and provide you a compact PDF so that you can take the printout along with all the images and everything. But it will take 24 to 48 hours. So after the session, within 24 to 48 hours, you will get printable notes. Digital notes are already available on the app, but you can't print them. You can't print them. They may align with the lecture, they cannot align with the lecture. But this is full and final. Whatever I am teaching you, that will be the printable notes. That is the difference between digital notes and printable notes. So let's start it. Okay, so let's rock it. Let's start it. Epidemiology. So let me start with epidemiology. I have already started yesterday. What I taught you yesterday, these all topics I already taught you yesterday. You were present in my yesterday's class? Yes? No? Who was present in my yesterday class? Raise your hand, give me a thumbs up. You were present. I taught you all these topics. Half of the epidemiology is over. I taught you the definition of epidemiology. You remember? This is the definition of epidemiology yesterday I taught you. This session is available on YouTube. It will be uploaded on the app today. Don't worry, everything will be uploaded on the app. Okay? Team is working day and night on that. Okay, so this is epidemiology definition. Epidemiology is the study of what? Study of health related events in a specific population, not in complete population. From the complete population, we take a specific population in which we study health related events. Okay, that is epidemiology. And not only this, we apply this study to control the disease. So that is the definition of epidemiology we have seen yesterday. After that, I told you the 3 tools of measurement, that is weight, ratio, proportion. Okay, in all of them, there is a numerator, denominator. Here, numerator is a part of denominator. Here, numerator is a part of denominator. Here, numerator and denominator are 2 separate entities. They are not related to each other. Here, multiplier is 1000 or more than 1000. Here, multiplier is 100, always in percentage. Here, there is no multiplier. No multiplier. So yesterday, please watch my session. If you are missing it, you are doing a big mistake. After this session, you can watch this on the YouTube. After that, I told you 6 measurement of mortality. You remember this table? Please watch the session if you have missed it. 6 measurements of mortality. After that, I told you international test certificate, then 2 measurements of morbidity. That is incidence and prevalence. So that was yesterday's session. We have taken a quick review of the yesterday's session. You know my way of teaching. We always revise the things first and then move on the new things. So let's start. Let's start today's session. This was just an overview of the course and we have revised yesterday's session. And now we are starting with today's session. Are you people ready? Can we start? We shall start. We shall start today's session. So this is the beginning point of today's session. Okay. So today I am going to continue epidemiology with the most significant portion of epidemiology. That is epidemiological studies. I'm going to teach you epidemiological studies. Many students find this topic difficult, but today, take my words, at the end, you will become an expert in all these studies and you can solve any numerical based on that. So be ready with your notebooks and pen. Today, we will solve many numericals together. I will tell you the approach for the numericals also. So these all studies, I will teach you 3 types of studies. Descriptive studies, that is a big portion. Analytic study, in which I will give you the detail of case control as well as cohort study. Experimental, we won't be able to take it today, but in the next session, which is not a demo session, but a regular session, after Diwali it is. So we will continue with the experimental epidemiology and the further sessions ahead. Okay, so today we are going to complete this and this portion, but it is a big portion. Okay, so let's start it. You can see the epidemiological studies. Okay, we divide the epidemiological studies into 2 portions. Observational studies and experimental studies. Observational studies, okay, the epidemiologist just observe it. And experimental, we will do the experiments. Okay, observation is further divided into 2 portions, descriptive and analytic. These 2 portions we are going to complete today. I will teach you descriptive study as well as I will teach you analytic. From the analytic, out of the 4, 2 are important. So we will see the details of the 2. And these 2 we will see in short, not in much detail. So these 2 portions we are going to complete it. Okay, forget it. You will say, ma'am, what all these means? Many students have just entered the 3rd Prof and they are not aware of these terminologies even. They don't know what all these studies are. Now, if you are starting from the scratch, if you are a new student, if you don't know anything about it, 2 questions should come in your mind. These two questions. I guess everyone is hitting with these two questions. Ma'am, why we are conducting this study? Number one, who conduct this study? Ma'am, who conduct? Can I conduct? Can you conduct? Who can conduct the study? All these studies, who will conduct? Number one. And number two, why? Why we are conducting this study? What is the purpose, ma'am? You are taking today's session, you will teach us this study, 4 types of this, 3 type of this, and 4 type of all these studies. Why such a mess? What is the reason we should conduct such a study? So 2 questions come in mind as a student. Ki, ma'am, who conduct these studies? And why we are conducting this study? So we will answer them one by one. Let's take the first question. Who conduct this study? Who conduct? So an epidemiologist conduct the study. Epidemiologist is the person who have done the masters in community medicine, okay, MD in community medicine. The person is epidemiologist, and that person is a researcher. Okay, it's a detective of epidemiology. It's a detective of the community. Okay, like the Sherlock Holmes. It is a detective. So you can see epidemiologists are like Sherlock Holmes. They are the detectives of the community. Okay, yesterday also I taught you. You may be thinking, ma'am, what is the difference between an epidemiologist and a clinician? You said that all these studies are conducted by epidemiologists. But who is an epidemiologist, ma'am? Please explain. So what is the difference between clinician and epidemiologist? So clinician is the doctor. It's a person who saves one life at a time. Yes or no? Okay, so clinicians are the doctors who save one life at a time. But epidemiologists are also doctors. They are also persons, they are also doctors who save entire community before even they fall sick. Okay, they predict the epidemics, endemics, and they prevent it. Okay, it's a preventive medicine I'm teaching you. PSM, preventive medicine. I'm not teaching you internal medicine. I'm teaching you preventive, how to prevent it. So please, so they save the communities before even the community falls sick. That is epidemiologist. Or as you can say, clinician fights the disease inside the ward. Inside a ward, fighting with the disease. Epidemiologists fight with the disease before disease enters the ward. Before disease enters the ward, epidemiologist is fighting with the disease. It's a silent warrior. It's a silent warrior. We can't see such heroes in the community. They are fighting with the disease even before the disease are coming in the community. Okay, so such a role, a big role in the community, the epidemiologist have. This is an epidemiologist, and an epidemiologist is going to conduct all these studies. So I got my answer of the first question. Who conducts the study? So answer is epidemiologist. Yes. Now coming on the second question. Why we are conducting this study? Why this epidemiologist is conducting all these studies? Why? Okay. So answer is to confirm a hypothesis. Okay, to confirm a hypothesis. We are having a hypothesis, and to confirm that hypothesis, we are going to conduct this study. Okay, to confirm the hypothesis. You will say, ma'am, what is the hypothesis? So epidemiologist or researcher, we all are educated people. Okay, sometimes we may have a, I must say, educated guess. Our guesses are not random because we are medicals. So our guesses are educated guesses. So it's a guess. I want to confirm that guess. Suppose I say you smoking leads to lung cancer. You will believe me? Of course you will believe me. Say, ma'am, yes, I know smoking leads to lung cancer. Why you will believe me? Because it is proven 1,000 times. It is published everywhere. It is proven 1,000 times by many epidemiologists, by many scientists. You will believe me. Okay. This was a guess, suppose. Okay. When it was not proven, one day one person may have a guess. The very long years ago, long era ago, one of the epidemiologists may have a guess. Okay, what is the guess of this epidemiologist? Smoking leads to lung cancer. The first time it hit in his mind, and he tried to prove that with the help of epidemiological studies, and now it is proven. That's why we are believing it. Suppose my next guess, let's say, eating mangoes leads to blindness. You will say, no, ma'am, I'm a mango lover. I eat mango too much. I'm not blind. I don't think you are right. Why you are giving such a guess? Huh? Eating mangoes don't lead to blindness. So if I say anything random, any of my guess, you will not believe. For believing, I have to conduct the epidemiological studies, the 3 studies I told you. So if I'm doing all 3 studies and the results are in my favor, okay, the favor of my hypothesis, okay, then you will believe me. It will be published everywhere, and then everyone in the world will believe that. So if we have any guess to confirm that guess is known as hypothesis. Hypothesis is a guess. It's a guess. To confirm that, we have to conduct the epidemiological study. Okay, so that is hypothesis. Learn the definition of hypothesis. Simple words, it's the educated guess. And to confirm that guess, to confirm that hypothesis, we are going to conduct epidemiological study. Now, these all are hypotheses one day, but it is already proven. That's why you will believe all of them. For example, smoking leads to lung cancer. We all know that. High salt intake increases the risk of hypertension, increased BP. We all know that if we eat more salt, we can have hypertension. HPV, you know HPV virus causes, it's a risk factor for cervical cancer. You already know that. Asbestos leads to mesothelioma of the pleura. You already know that. Why you already know that? Because it is already proven. It is written in your books, various books, pathology books, various books. It is already published everywhere. No? So that's why you are believing it. But one day when it was not published, one of the person may have a guess that this causes this. That is the hypothesis. One day they all were hypotheses, but today they are not hypotheses. They are already proven. I'm just giving you the examples. I'm starting from the scratch so you can understand the studies. Okay. Now they are proven. Okay. Various epidemiologists have already proven them. All these hypotheses. Now they are no more hypotheses because they are already confirmed. And they are not hypotheses now. I will call them facts. Once the hypothesis is confirmed, it is no more hypothesis. It is known as fact. Now these are facts. You know the facts. But one day when they were not proven, they were the hypothesis. You are getting my point? So all the hypotheses, whenever there is any hypothesis in the community medicine, there are two components in the hypothesis. What are the two components in the hypothesis? You are getting everything. By the way, whatever I am teaching you, if you have any doubt in that, you just write down your doubt in the comment box. Maybe in the middle of the teaching, I'm in a flow, I will not be able to address the doubt. But once I will finish the topic, I will address your doubts. Okay, got it? So don't think that I'm not looking at the chat box and not addressing your doubt. In the end, it will be done. Okay, I do not want to break the flow again and again. Chalo. So let's continue. Just a second. Just I can see the comments. Chalo. So hypothesis, all these hypotheses, one day they were the hypothesis, today they are the facts. But imagine they are still hypotheses, they are not yet proven. Just imagine that. So they have two components. What are the two components? Let's take one of the hypotheses in detail. Okay, the first component is causes, risk factor or exposure. The meaning is the same. So whatever is marked, they are the risk factors. They are known as causes, risk factor or exposure, like smoking here, like high salt intake here, like HPV virus, asbestos, UV radiation here. These are causes or risk factor or exposure. The meaning is same. Please imbibe in your mind. Whether I say a cause, whether I say a risk factor, or whether I say exposure, the meaning is same. People, meaning is same. You're getting my point? And the second component is this. So smoking leads to what? Smoking leads to lung cancer. Salt intake leads to what? It leads to hypertension. HPV leads to what? It leads to cervical cancer. So these are the disease. Either call them disease or call them effect. So meaning is same. Meaning is same. So what are the two components? Causes, risk factor, exposure. This is the first component. Okay, and effect or disease. This is the second component. The meaning of these two is same. They are synonym. The meaning of these three is same. They are synonym. Fit in your mind forever. Whether I say this or this, I mean same. I mean first component. And whether I say this or this, I mean the second component. So let me combine the first component and second component together. So this is the hypothesis. You can see the red one is the causes and the blue one is the effect or disease. You are getting my point? So in every hypothesis, see all the hypotheses, I have given ample of examples. You can see all the hypotheses. In every hypothesis, we have a risk factor and we have a disease. Okay, we have a risk factor in all the hypotheses and we have a disease in all hypotheses. For example, just now I taught you, my hypothesis is eating mangoes leading to blindness. You will say, Ma'am, are you crazy? It's just a supposition. It is not yet proven and I'm just kidding. It's not the fact. Okay, I'm just explaining you, leading to blindness. So in this example, what is the first component? What is the second component? In this example, this is the cause or risk factor or exposure. Okay, eating mangoes leading to blindness. Blindness is known as disease or effect. So appreciate the two components. I'm just explaining you the two components. Appreciate the two colors. Okay, red and blue. So all the hypotheses have two components. Okay, the first component leads to second. Appreciate the arrow in between. The risk factor leading to disease, you can say. Okay, so these are the two components. Now I can now take this page again and again. I will select one of them for my entire session, the next 2 hours. I will take one of the hypotheses and I will teach you all type of studies in that hypothesis only. Okay, suppose My favorite hypothesis is this one, so I will select this one. You can select any of them. So my hypothesis for ahead, not till now you got the overview. Now I will not show you the slide again and again. What is the hypothesis? You got it? Hypothesis is a guess. Okay, we are guessing. Okay, but no one will believe my guess. Okay, I have to confirm it. For confirming, I have to conduct epidemiological studies. But in a hypothesis, there are two components. One is the risk factor, other is the disease. Risk factor leads to disease. Till now we understood that. Now for the sake of understanding further, okay, for all type of studies, we will take one of the hypotheses and we will continue our studies on that. So my favorite is this one. I always take this one. Okay, smoking leads to lung cancer. So here smoking is cause, risk factor, exposure, whatever you say, and lung cancer is the effect or disease, whatever you say, the meaning is the same. So smoking leads to lung cancer. This is my hypothesis. You will say, ma'am, it's not a hypothesis, it's already proven, it's published, it is proven, experimented by several scientists, epidemiologists long ago. It is not a hypothesis, ma'am, it's a fact. I know that. Just imagine first time it's a hypothesis and I am the epidemiologist, the great epidemiologist, Dr. Priyanka. I'm going to prove that with the help of epidemiological studies. You just imagine. I know it's a fact. It's already proven. Okay. But I do not want to take the credit. I'm just explaining you. Suppose I am the epidemiologist and first time I'm going to prove that. Okay. So you think it's very weird. Eating mangoes leads to blindness. Okay. First time you heard, you are thinking what a weird hypothesis, ma'am. No, it's not a fact. But maybe I'm right. I can prove that. Okay. So first time when one of the person may have thought that smoking leads to lung cancer. It may be that weird only. It may be that weird because it is the first time person may have heard that smoking leads to lung cancer. Nobody is believing. So person have proven that by conducting various epidemiological studies. Okay, so this is my hypothesis. Now I will conduct all these epidemiological studies to prove my hypothesis. My suppository hypothesis is this one. Okay, so I will conduct all these studies one by one. So the studies have 3 parts. Out of the 3 parts, 2 parts we will complete today only. They are big studies. So what are the 3 parts of the study? You can see the first part is descriptive study. We have to go step by step. So first, if I'm an epidemiologist, I want to prove this. First, I have to conduct descriptive study. We will start with this. Okay. Then I will conduct analytic study. Second portion. If this is approved, if the results are in my favor, then only I'm allowed to go with the analytic study. If the analytic study results are in my favor, then allowed to conduct the last portion of the study, that is experimental study. So learn them in a sequence. First descriptive study, then analytic study, then experimental study. Please learn them in a sequence. You are getting my point. Descriptive study, analytic study, experimental study. Okay, so these are the 3 studies we will conduct one by one to prove any hypothesis. Okay, learn them in a sequence. And who allows? There is an ethical committee everywhere. There is an ethical committee. So if I'm going to conduct, this is my hypothesis. First, I have to frame a hypothesis and I will submit my hypothesis to the ethical committee and ask them the permission to grant me the permission so that I can conduct these studies. If I got the permission, I will conduct this one. I will submit my report. Okay, based on my report, they will give me the permission to conduct the second study. So again, I will submit my report of this study. And if results are in my favor, then I will be allowed or given the permission to conduct the last study. And if I'm successful in this also, my hypothesis is no more hypothesis. My hypothesis converted into the fact. Got my point? So these are the 3 steps, the 3 type of studies. Okay. Descriptive studies, analytic studies, and experimental. By the way, descriptive and analytic studies are observational studies. These are the 2 types of observational. You can learn that. Okay. So the first is descriptive study, in which we formulate the hypothesis. Mind my words carefully. Mind my words carefully. In this study, we formulate the hypothesis. What we are doing? We are formulating the hypothesis. We are formulating the hypothesis. The first study. Descriptive is for formulation of the hypothesis. We just make a hypothesis. We will formulate. I mean, my hypothesis is very rough. You say, ma'am, you already have a hypothesis. That's why you are conducting the study, no? But currently, my hypothesis is very rough. I mean, smoking leads to lung cancer. But how much smoke leads to lung cancer in how many years? Like smoking of 2 packets. Smoking of 2 packets of, there are various types of smoking. BD, cigar, various aspects. So smoking of 2 packets of BD leads to lung cancer in 10 years. So that will be a firm hypothesis with some guidelines, with some figures, with some, things in that. This is a very rough hypothesis based on which I can start the study. But here I will make a good hypothesis, complete hypothesis. Okay, then I will conduct the second portion, analytic study, in which I will test my hypothesis. So analytic studies are for testing the hypothesis. Descriptive studies for formulation. Learn the word formulation of the hypothesis. Analytic studies are for testing. Learn the word testing. This is for formulation. This is for testing the hypothesis. And finally, the third, experimental studies. Experimental studies are for confirming the hypothesis. You have to learn these three black boxes. Learn the sequence, first, second, third. Learn the three types of studies and learn their purpose. People, are you there? Learn the purpose. So, descriptive study is for formulation and it is the first study. Learn it. You have to learn it. We will formulate a hypothesis. Now, hypothesis is complete. It was incomplete initially. Now it is complete. We have formulated it complete. How many BDs, how many cigar, how many years, like that. Okay. Analytic is for testing. It is the second stage. It is for testing. Now we will test it. But testing is not sufficient. We have to confirm it. So we do confirm it by doing experiments. So we do experiment on the volunteers, on some patients, on animals. Okay, we have to take the permission of ethical committee. If I'm an epidemiologist yet, I'm not an epidemiologist by the way, I'm a pathologist. But if I'm an epidemiologist also, I cannot conduct these studies as it is. I have to take the permission from the ethical committee. Okay, if they grant me permission for all these steps, then only we can conduct these studies. Got my point? So there are three types of studies. What are the three types of studies? We are having descriptive study, analytic study, and experimental study. So what we have learned, descriptive is first. Here we formulate the hypothesis. Okay, analytic is second. Here we test the hypothesis. And experimental is third and the last. Here we will confirm the hypothesis. You get many MCQs on these 3 points. People do learn that. You have learned it. Give me a thumbs up in the comment box if you have done so. So this was the introductory portion. Now I will start the 3 portions one by one. So today's session, okay, in the next 1.5 hours or 2 hours, I will complete the first portion, that is descriptive study, and I will complete the second portion, that is analytic. Experimental will not be able to complete it today because it take another 1 hour. Session will be too long. So in the next session of PSM, okay, we will continue with the experimental. Okay, so my lecture consists of studies consist of 3 portions. 2 of them we will complete it today. Okay, so before moving on the next portion, starting the studies one by one, I'm having few MCQs for you. Yes, I'm having few MCQs. I would like to launch the poll. Okay, and from the poll you have to see the correct answer. Can I launch the poll? You can see the question over here, and just a second. Will try to launch the poll. You have to click the correct answer in the poll itself. I guess it will be visible on your screen in the next few seconds. Yes, I guess it's visible at my end. Can you? Yes, most of you are right till now. Very good, very good. Most of you are right till now. Very correct. Yes, you are having 15 seconds by the way. Time is very less. Yes, the correct answer is A, and I guess 80% of the people are right, but some got confused. So hypothesis is not tested by. The question is not. The hypothesis is not tested by. So correct answer is descriptive. Descriptive may we don't test the hypothesis. We create the hypothesis, formulate the hypothesis. Okay. In analytic, we test it, and these are the types of analytic only. Here, if you have seen analytic studies, you can see, and case control and cohort are the types of analytic. So in all of them, we are testing it. But in descriptive, we are formulating it. You are getting my point? So correct answer here is A, and you all are right. One more question I'm having. I'm sorry, I have to see the answers before I launch the poll. I have to click the correct answer. No? So that's why. I guess next question is in front of you. Read the question, tell me the correct answer. Okay, you are having 15 seconds, mind it. So difference between descriptive and analytic study. Can you read out the options? Descriptive and analytic study. What is the difference between them? Descriptive is used to test. No. Descriptive is for hypothesis formulation, not testing. Analytic is used for formulate. No. They are reverse. Analytic is for testing and descriptive is for formulating. Okay, very few students are correct. Why? Most of you are saying A. A is not correct answer. I'm asking the correct answer. Descriptive is the first phase. Yes, descriptive is the first phase. This is correct. Okay. Analytic studies observe distribution. Analytic may we don't observe. Analytic may we test. We test the distribution. Distribution of the disease is tested in descriptive, not analytic. So correct among them is C. I hope most of you got it. Huh? Got it? Okay, so correct answer is C. Correct answer is C. Okay, yes, the correct answer here is C. So current polls are done. We are having very frequent polls. After every topic, we are having polls. Don't worry. So can we continue? Are you people there? Chalo, let's start the studies. Let's start it one by one. We will start them. So let's start with the first study. By the way, again, I'm reminding you for all these three studies, 1, 2, 3. Today, I will teach you 2. For all these studies, my hypothesis will be same. Again and again, we will not revise the same thing. Smoking leads to lung cancer. I'm going to prove that. It's already proven, but suppose I'm the first person who is going to prove that. So here, smoking will be cause of risk factor or exposure, and lung cancer is the effect of disease. Okay, so this is the hypothesis we are going to prove with these all studies. So with this introduction, I would like to start my first portion of the session, that is descriptive epidemiology. So I'm starting with descriptive epidemiology, the first portion of my session. Can I start the first portion of my session? I'm starting with descriptive studies, descriptive epidemiology, in which the hypothesis is formulated. We will formulate the hypothesis. Okay, can I start? Chalo. So it is, everyone knows it is the first phase of epidemiological study. In the epidemiological study, total 3 phases are there. 1, 2, and 3. So descriptive is the first phase. I guess everyone knows. Here we will formulate the hypothesis. I told you multiple times. We are not testing it. We are not confirming it. We are just formulating it. We are formulating the hypothesis, number 2. And here, how we will formulate? In terms of 3 things. In terms of 3 things. Time, place, and person. So descriptive study have 4 steps. Okay, basically we describe the disease in terms of time, place, person. What do you mean by the word descriptive? Descriptive माने क्या होता है? What do you mean by descriptive? Describing anything. Okay, so describe your hypothesis. Whatever is your hypothesis. What is my hypothesis? Smoking leads to lung cancer. This is my hypothesis. Describe your hypothesis in terms of time. Describe your hypothesis in terms of place. Okay, and describe your hypothesis in terms of person. So you have to describe your hypothesis in terms of time, place, and person. You're getting my point. That is descriptive. Just describe it. Don't do anything. Don't do any intervention. The person who smoke, ask him, yeah, continue smoking. Very good, very good. The person who is not smoking, ask it, yes, don't smoke. Very good, very good. You don't have to intervene. You don't have to give any advice. You don't have to fall in ethical trap. No. The person smoking, let him smoke. The person not smoking, let him not smoke. Him or her, I mean. Okay. But you don't intervene. You don't intervene. We are not. We will intervene here. Here we will intervene. We will do the experiments. We will intervene. Here we are just describing it. Observing and describing. That's it. Okay. So that is the descriptive epidemiology. So say the 3 points of descriptive epidemiology. Say, ma'am, it is the first phase out of the 3 phases. Here we formulate the hypothesis. Okay. Do not test it. Do not confirm it. Just formulate and describe the disease in terms of time, place, person. So these are the 3 lines written over here, which it is already visible here. Okay. You have to write down in statements. Okay. So descriptive epidemiology. Now, what are the steps? I am an epidemiologist. Consider me. Imagine. Actually, I am not. But imagine I am an epidemiologist. Okay. So I want to prove smoking leads to lung cancer. Imagine. So I will conduct descriptive study. Ethical committee have given me the permission. Yes, you go ahead and you do the studies. So I am performing my first study. Descriptive study. I am performing my first study, in which there are 4 steps. Okay. So first of all, I have to define a population. In which population I am going to conduct my study? I should have a population. The population is a geographical area in which a group of persons is residing. This is the population. The population can be a village, it can be a city, it can be a country, it can be anything. Okay. Now it's my choice how big study I want to conduct. I can take India as a population, but it will be a big study. It will take years to go. So I should be financially strong to conduct that study. All studies demand finances. Okay. And I should have time to conduct such a study. Otherwise, I can take a city of the India. If I'm not able to take the complete India, I can take any of the city of the India. I can take any population. I can take a village also. But you know, larger is the sample size. Larger is the population size. More reliable is the study. Because you are doing your study on a big sample. If you are doing your study on a very small sample, so study is not very much reliable. So that is the importance of selecting your population. So based on the time I can afford, based on the efforts I can afford, based on the finances I can afford, I will select my population based on my reach. I cannot take the population some foreign where I cannot visit. So how I will do the study there? Huh? I should visit my population. I should be able to do so. So I will select my population. Okay, so first step, selecting your population, in which you will conduct your all studies: epidemiological study, descriptive study, analytic study, experimental study. So select your population. Step number 1, select your population. So your population base you have to select and describe your population, not only in terms of number. So this population is how many thousands, how many hundred, how many thousand, how many, lakhs, million, billion, whatever, depending on your sample size. Okay, so describe in terms of number. Obviously, number is the first thing you should say. Ki my population is a Delhi population, my population is Mumbai population, or Hyderabad population, whatever is population. Describe the number. So my total population for study at this moment is this. Now it is a dynamic figure. It will keep on increasing and decreasing. But the moment you are starting your study, you should say the number. But describe in terms of age, gender, occupation, cultural characters. So out of the total population, how many are businessmen, how many are servicemen? Out of the total population, how many are Hindus, Muslims, and Christians, like that. So based on the culture, based on the how many are males, how many are females, age group, how many are 0 to 5, how many are 5 to 10, how many are 10 to 15, like that. Okay, so based on the gender, based on the age, based on the religion, caste, culture, occupation, how many are married, how many are unmarried, and based on the number, obviously. So describe your population based on all these criteria. So that is step number 1. You are ready with your population. You have described your population in terms of numbers, in terms of gender, occupation, marital status, gender, like that. Okay, age group. You have described your population in all aspects, all various aspects. Now coming on step number 2. In step number 2, you have to describe the disease. What disease is under study? What is my hypothesis? My hypothesis is smoking leads to lung cancer. This is the hypothesis we are going to take in the entire session. Smoking leads to lung cancer. So what is the disease over here? The disease is lung cancer. Okay, so this is my population. I will go home to home. I will send people, or I myself go. I'm an epidemiologist, or I will hire some people under me, and I will allot them the area, this colony, this colony, this colony, this colony. So various people which are allotted by me, I will train them. They will go colony by colony, section by section, and they will ask, is there is any patient who is lung cancer at your home? Is there is any patient who is lung cancer at your home? Like that. So we will collect the data in my entire population, how many lung cancer patients are there. But to whom you will call the lung cancer? Lung cancer kise bologe? Who have the lung cancer? So you should have an operational definition of the disease. Okay. So lung cancer proven on X-ray or CT scan or MRI or biopsy proven lung cancer. To whom you will call the lung cancer? So you should have a fixed definition, an operational definition of the disease. To whom you will cause a lung cancer? It should be biopsy proven, then only you will believe, or you will believe on X-ray only, or you will take at least, CT scan or something. So you should have your definition fixed in your mind that if any person proven lung cancer by biopsy, then I will include that in my study. If any person is having lung cancer but biopsy is not yet performed, or it is not biopsy proven, so I will not include that patient. Okay, like that, whatever. So you can take your operational definition of the disease. That is step number 2. Okay, so biggest is step number 3. It will take half an hour to explain all these points. Biggest step, the most important step of descriptive study is step number 3. You are getting my point? So first of all, start from the beginning. What you people are saying? Okay, all these queries we will address later. Currently, if you have any query of this topic, kindly ask that topic. Okay, other queries regarding notes, regarding app, regarding glitches, regarding all blah, blah, blah. Please WhatsApp on the support number. Don't waste the time of actual classes. The actual classes is for topics. Okay, otherwise support number. Okay, chalo, come back. Steps in the descriptive study. Again, I am an epidemiologist. Suppose, imagine. Okay, and I'm having a hypothesis to prove. My hypothesis is smoking leads to lung cancer. I have taken this hypothesis to the ethical committee, requesting them to allot me permission, to grant me permission to conduct the study. And luckily, they have given me the permission. So I started with the first study. The first study is the descriptive study, in which I have to conduct 4 steps. Then I will submit my report, okay, to the ethical committee and ask them permission for the second study. That is analytic study that I will do later. But let me conduct these 4 steps. So my hypothesis is smoking leads to lung cancer. So first of all, I should decide my population. on which I will conduct the study. Number one. Okay, I should decide my population on which I will conduct the study. Number two, I should define a operational definition of the disease. To whom I will cause lung cancer. It should be biopsy proven, X-ray proven, CT proven, or to whom, or just patient coughing is having lung cancer. I should have a definition, no? To whom I'm including in my study. That is a very important criteria. You should have the patients who really have lung cancer in your study so that your results are reliable. Okay, so this step is very important. You have to decide the disease, operational definition of the disease. You are getting my point. Now coming on point 3. Step number 3, I mean, of the descriptive study, the biggest step, describe. Descriptive study में describe. Descriptive माने describe करो, means you describe. Describe your hypothesis in terms of time, place and person. One by one we will take it. So you see this. So 3 questions you have to ask. For this population, for this disease, you have to ask 3 questions. What are the 3 questions? When my disease? What is my hypothesis? Again, write your hypothesis. Take any hypothesis, not only this one. You can take any one of them. Smoking leads to lung cancer is my hypothesis. Okay, so when my disease occur? When my disease occur? It is seasonal. Lung cancer occurs in rainy season like that, in summers and winters. No, it's not seasonal. Is it cyclic? Is it having short-term fluctuation, long-term fluctuation? I mean, have you ever heard lung carcinoma ka epidemic aaya hai? There is an epidemic of lung carcinoma. I have never heard. So don't have short-term fluctuation. So first describe your disease in terms of time. When the disease occur in that particular population. Okay, you have to observe for years. When it is coming. Then where it is occurring in terms of place. In terms of time, where it is occurring. So in your entire population, is there any particular colony, any particular area in which there is clustering of lung cancer patients? Then you think why patients are more here and less anywhere else. In terms of place, you describe your disease. Okay, and who is getting it more? Is it males or females? Who is having more lung cancer? Males have more lung cancer. Why? Because they smoke more. Nowadays, females are also smoking. Nowadays, the ratio is almost equal. Females are also equally smoking. Or is it married or unmarried? Is it Hindu, Muslim, Christian? Like that. So in every aspect, married, unmarried, or are there other aspects or age group? Lung cancer don't occur in children. Okay, it occurs after 20 years, 25 years. So why it don't occur in children? The highest peak is in the middle-aged group. Why? So who is getting it more? Okay, so 3 questions. When, where, who? When the disease is occurring, where the disease is occurring, who is getting it? When, where, who? Answer these 3 questions. I mean to say, describe your hypothesis in terms of time, in terms of place, in terms of person. So whatever way you are understanding, please understand this. You have to describe your hypothesis in 3 aspects. In terms of time, that will give the answer of when. In terms of place, that will give the answer of where. And in terms of person, that will give the answer of who. Everybody getting it? Kindly keep giving thumbs up in between in the chat box. I can see the chat box is still, so that it will be moving. I will feel better that you people are understanding. Otherwise, I feel I'm doing a recording. Okay, so are you people live? You are understanding the topic? Students are there. Keep on giving thumbs up after every topic, after every concept, if you are getting it. Okay, chalo. So we will describe the hypothesis in terms of time, place, and person. Okay, so we will describe the disease in terms of time, in terms of place, that is a map. Okay, and in terms of person. We have to describe. That is descriptive study. It's a big study, descriptive study in terms of time, place, person. Now please learn this flow chart. I have given you ample of flowcharts in the entire syllabus of community medicine. I will change. After 4 months now, you will feel community medicine is one of the most interesting and colorful subjects in all the 19 subjects. I will insert so many images in the subject. Okay, so that you will have a better retention. So describe the disease in terms of time, place, person. Okay, time is the biggest thing. Many subdivisions. Place and person is simple. Okay, so descriptive study, 3 aspects. Time, place, person. Place, we will describe just place. Person, we will describe just person. But time, under time, we have 3 choices. Is the disease showing short-term fluctuation? Short-term fluctuation means epidemic. Disease is showing epidemic, disease under study. My disease under study is lung cancer right now. It can be any disease. So that particular disease under hypothesis, under study, is it showing epidemic, short-term fluctuation, or is it showing long-term fluctuation? That is known as secular trend. Learn the synonym. Long-term fluctuation is known as secular trend. Okay. Short-term fluctuation is known as epidemic. Okay. Or is it showing periodic fluctuation, that is seasonal or cyclic? In some particular season, the disease is occurring, or in some cyclic manner, it is coming. So your disease understanding under hypothesis, under study, What is my disease under study right now? Lung cancer. Is it showing short-term fluctuation, long-term fluctuation, or periodic fluctuation? It may be one of them. It cannot be all or multiple. It is one of them. Okay. So disease vary from hypothesis to hypothesis. So you have to decide. First you understand all three. Then you tell me that lung cancer shows short-term or long-term or periodic fluctuation. First you understand in detail. The short-term fluctuation is again of three types. Okay. Point source, continuous source. Point source, continuous source, or propagated. It is again of three types. Okay. Long-term don't have any type. And periodic again is of two types, seasonal and cyclic. Again it is of two types. So time, understanding the time aspect of the hypothesis is difficult. So first you understand the time aspect of the hypothesis have three choices. Either the disease shows short-term fluctuation, or the disease show long-term fluctuation, or the disease show periodic fluctuation. Disease under study. My disease under study is lung cancer. My disease under study can be polio, can be hepatitis, can be COVID. I can have any hypothesis. Currently, before this hypothesis, I was having a hypothesis eating mango leads to blindness. So in that case, blindness will be the disease. Okay, HPV leads to cervix cancer. In that case, cervix cancer will be the disease. Okay, eating salt leads to hypertension. In that case, hypertension will be the disease. Your disease vary from hypothesis to hypothesis. What is your hypothesis based on which you will decide your disease? So your disease is showing short-term fluctuation or long-term fluctuation or periodic. In the short term, there are three choices. In the long term, there is no choice. And in the periodic, there are two choices. First, you learn this flowchart, people. Step number one, learn it. Make it on your copy. Learn it. Okay, let's start with time. Let's start with time. Okay, time. So you can see I'm starting with time. I'm starting with time. Okay, in the time, there are three options. As I told you, short-term fluctuation known as epidemic. Long-term fluctuation known as secular trend. And periodic fluctuation, which is of two types, seasonal and cyclic. Okay, one by one we will take them. So under time, I'm taking short-term fluctuation first. Short-term, let's start short-term fluctuation. Short-term fluctuation, what is short-term fluctuation? Any disease, you know, some diseases are constantly present in the community. Okay, constantly present in the community. Some diseases like conjunctivitis. Conjunctivitis constantly present in the community to some people. Okay, if you see my city, the complete country, India, some people already have conjunctivitis. They get cured, another have. They get cured, another have. But sometimes there is sudden increase in occurrence of the disease. Okay, sudden increase. What is the sudden increase? It is more than 2 standard deviation. I will teach you biostatistics. I will teach you what is standard deviation later on. But for now, you learn. If there is sudden increase which is more than 2 standard deviation, I will call it an epidemic. Have you heard? Conjunctivitis का epidemic आया है. Everyone is having conjunctivitis. Many people have conjunctivitis in a localized area. Yes, it happens. Huh? Or polio का epidemic there is. Or hepatitis का epidemic is there. Yes, they happen. Okay, these all are communicable disease and epidemic occurs in them very frequently. But cancers don't have epidemic. Epidemic don't occur in chronic diseases. Epidemic can occur in acute infectious diseases. I will teach you communicable, non-communicable disease in a master chart pattern. I will teach you all. Give me 4 months time. Okay, but here I guess you are understanding what I mean. Okay, so sudden increase in the frequency of a disease is known as epidemic. That is short-term fluctuation. Lung cancer don't have it. Okay, lung cancer don't show epidemic. It don't happen the complete colony have lung cancer. We have never heard that. It's a non-communicable chronic disease. It's cancer. It's a non-communicable disease, chronic disease. They don't have epidemics. But many other diseases like COVID don't have epidemic. It is having pandemic. Okay, epidemic converted to pandemic. There was an epidemic in China and that converted to pandemic. We all know recently. Yes or no? Few years back. So yes, it's like that. So short-term fluctuation is epidemic. Learn the definition of epidemic. What is the definition of epidemic? It is sudden occurrence of a disease in a given area, in a given geographical area. Suppose this is my area. Sudden occurrence of disease in that area under a short period of time. All the people, most of the people have the disease. And if you say a biostatistical definition, occurrence of number of cases which is clearly in excess of the normal expectancy, that is more than 2 standard deviation. So that is known as epidemic. Okay, so this is short term. Short term is of 3 types. Short term is of 3 types. I told you, no, short term is of 3 types. What I'm teaching you people, start from the beginning. Descriptive study. Describe your hypothesis. Descriptive means describe your hypothesis in terms of time, place, and person. Time is of 3 types. Okay, short term fluctuation, long term fluctuation, periodic. I'm starting short term. Short-term fluctuations are known as epidemic. I assume you know the definition of epidemic. Please learn it. Definition of epidemic. Now, short-term is of 3 types. What are the 3 types? First, what are the three types of the short-term fluctuation? These are the three types. You can read it. Single exposure or point exposure. Single or point exposure. C. Second is continuous or multiple exposure. Continuous or multiple exposure. And third is propagated. You can see it here, propagated. So we will describe all three with the help of examples. You get multiple MCQs based on example. Believe me, I will show you. Okay. So one by one, I will take them. Yes. Short term I'm teaching you. I'm teaching you time, not place, not person. Under the time, I'm teaching you short term. Under the short term, we will start them one by one. So let's start with the first one. Single or point source. Under the short term, under the time, under the short term, I'm teaching you single or point source. So what is single or point source? I will draw the three graph. Here, x-axis, y-axis, x-axis, y-axis, x-axis. You have to draw three graphs with me. And in the end, we will do the comparison of the three graphs. And you have to quote the examples under each so that you will have a better understanding. So start with the single source or point source. Okay, what do you mean by single source or point source? So here the exposure is very brief, maybe few seconds or few minutes. Exposure is not continuous. It's very brief. For example, let's take a graph I will explain. But first you understand the example. Have you heard about Bhopal gas tragedy? How many of you have heard? Bhopal gas tragedy, have you heard? Huh? I'm from Madhya Pradesh. I'm very close to Bhopal. I reside in Indore. Okay. So Bhopal gas tragedy took place in 1984. Before you and me all born. I'm also born after 1984. So in 1984, there was a factory, or you can say pesticide plant in Bhopal. This is the city Bhopal. There was a pesticide plant. Can you see this? This is a pesticide plant in Bhopal. Okay. I don't know the name of that plant. And there was a chemical used, methyl isocyanide, in this factory, in this pesticide plant to make the pesticides, and that is poisonous. But by mistake, the gas of methyl isocyanide leaked out for few minutes only. By mistake, the gas of methyl isocyanide leaked out and spread the entire city, and the people have inhaled that. That was a Bhopal gas tragedy. The biggest tragedy took place in 1984. Okay, and all the people who have inhaled that, they all have disease together. They all have disease together. So see the graph. So here exposure is only for minutes for all of them. For all the people of the entire city, the exposure is very brief. It is fraction of seconds or minutes or maybe few hours. It's not continuous. After that, it was fixed. Obviously, it was fixed. Okay, gas was not leaking, but the already leaked gas that was inhaled simultaneously by the entire city. Okay, so the graph is like this. Now, say the properties. I will tell you all examples. Say the properties of the graph. The curve rise and fall rapidly. Appreciate. Rapid rise, rapid fall. Say the two words. Say the two words with me. Rapid rise, rapid fall. Okay, because exposure is brief. Okay, so all the people in the city, they fall sick together, and after that they remain sick for a duration and they become well together. Either they die together or well together. So the entire epidemic is in one incubation period. It is in one incubation period. The entire city Bhopal get diseased. Whatever disease, methyl isocyanide leads to many cancers, many diseases, acute diseases. I don't know the details, but all of them have that together, simultaneous. That is the word to be picked here. So here exposure is brief. Exposure is point. It is single exposure. The gas was not for hours, for days, for months. The gas only for minutes, methyl isocyanide gas. So exposure is brief. It is a single or point exposure. It is brief. The exposure is brief. Okay. So disease agent. What was the disease agent in Bhopal gas tragedy? That is methyl isocyanide gas. That enters in all the persons together at the same time in one incubation period. Mark the word, one incubation period. I hope you are getting it. Yes. So in one incubation period, the entire city falls sick. Complete Bhopal falls sick in one incubation period. Incubation period was the only one. Everyone inhaled the gas. The entire city Bhopal, they inhaled the gas simultaneously. They all become sick simultaneously, and they all die or recover simultaneously. You know, from the exit yesterday, I told you the exit of the sick people is only two, either death or recovering. If you have watched my yesterday's session, so either they are dying or recovering, I don't know, but this is the end point. Okay, so in one incubation period, then death. So this is known as explosive. So the complete event is explosive. Suddenly, the complete city, you know, thousands of people fall sick together. It's an explosive. It is an epidemic. And the best thing here you have to learn, I mean, most important thing, curve rises rapidly, falls rapidly. Rapid rise, rapid fall. Appreciate, you should be able to draw that. See the slope, rapid rise, and see the slope, rapid fall. Appreciate the word rapid, okay, and appreciate the word explosive, okay, and there is no secondary waves because the people who are falling sick, they are only falling sick. After that, other people are not falling sick here. No, there is no secondary waves. Secondary waves will be there in the other epidemic, but here we don't have secondary waves. Okay, later on, other people are not falling sick. At this point, the people who are falling sick, who are inhaling, they are only falling sick. Later on, other people are not falling. We don't have secondary waves here. No secondary wave. And there is one incubation period. So learn the 4 properties of this graph. What are the 4 properties? Don't learn it, people. In my class, there is no mugging. See the graph, tell me the features. See, ma'am, this is a graph of single source or point source epidemic. Single source or point source epidemic. Okay, so here exposure is brief. Okay, number 1, exposure is brief. In the graph, I can see rapid rise, rapid fall. I can see 1 incubation period. Okay, I can't see secondary waves. Okay, and it is explosive. So now these 4 or 5 features, people, you should be able to write all these features of the graph and you should be able to draw the graph. Now take 4 examples of the single point source. Take 4 examples. Okay, what is food poisoning? People, have you heard what is food poisoning? Food poisoning means suppose there is a party going on. In this party, you know, suppose I am also in this party, we all are enjoying the food, okay, taking a common food, but one of the food is contaminated that we all have consumed and we all have vomiting and diarrhea together. So all the people who are there in the party, they are consuming the food together. You can see together. So exposure is brief. Now the food is over. Food is over. Food is not forever. It is over. It is consumed. Okay. So exposure was brief, like the Bhopal gas tragedy. The exposure was brief. Food is no more. So exposure is brief. Okay. All the people here who have consumed the food, they have diarrhea and vomiting together. Okay. They remain sick and after that they recover together. So 1 incubation period, no secondary wave, explosive. So food poisoning can be the one of the example. Okay. Second example, Bhopal gas tragedy, 1984. I have already explained. Okay. So there was a pesticide plant in Bhopal, 1984. Methyl isocyanate gas was leaked for a fraction of minutes and the entire city have inhaled the gas together. The complete Bhopal inhaled the gas together. They all sick together, they all die together or recover together. 1 incubation period, no secondary waves, explosive. Exposure is brief. Okay, single point. Same properties. Okay, the third is Minamata disease of Japan. Have you heard about that? I don't know the year, you can Google it out. Okay, Minamata disease of Japan. So in Japan, there was a chemical factory. This chemical factory, can you see this chemical factory? This chemical factory have discarded their waste in the water. Discarded their poisonous waste in the water. Okay, in the water, in the river, in the lakes, they have discarded their waste. In the sea, I'm sorry, they have discarded their waste, but that waste was poisonous. So all the aquatic life, you know, fishes and all the aquatic life, because of that poisonous waste, they are become contaminated, they are dead, they are contaminated, and these fishes are consumed by humans. Okay, in Japan, these fishes or aquatic life is consumed by humans. So they all fall sick together, they all remain sick together, they recover together. So again, the complete Japan, a big portion of Japan becomes sick together like the Bhopal because they consumed the fishes which were contaminated by the mercury. The waste was mercury. The poisonous waste was mercury. The factory, chemical factory, have discarded mercury, poisonous mercury waste in the water, and aquatic life was suffered. Okay, and that aquatic life was consumed by the human. That was Minamata disease in Japan. Okay, you have to focus on the graph. You don't have to focus on the stories. You have to learn the examples. I'm just making it easy to learn. I guess everyone have watched on the Amazon Prime Chernobyl tragedy. If you have not watched, it's a very good series. You must have watched. So Chernobyl tragedy. It's a very good series. Okay, and so what happened in Chernobyl? It's in Ukraine. I guess I don't remember the year again, but it's in Ukraine. So in Ukraine there was a radioactive plant. From this radioactive plant, the radiations were leaked. It's not a chemical like Bhopal. It is not methyl isocyanate gas. It's the radiations. You know, harmful radiations are leaked. You are getting my point, huh? So radiations made, it was strontium, iodine, cesium, various radiations were leaked. And the entire geographical area, the Ukraine, were exposed to those radiations. You know, radiations are carcinogenic. In a CT scan room, apart from patient, no one else is allowed. If the technician or doctor works, they wear the lead apron, I guess you know. So radiations are harmful, they are oncogenic. You know, many people have cancers later on, and that was shown in that series, what I'm talking about. So that is the Chernobyl tragedy that happens in Ukraine. Again, all the people were, the radiation exposure was only for a few minutes. After that, it was fixed, obviously, it was fixed. But the exposure is brief. All the people in that geographical area, Ukraine, they were exposed together and they died together. They died together. So like that. So again, the graph is same. I hope you got it. I hope you got it. Everyone give me a thumbs up. People, everyone give me a thumbs up. So we are done with the single or point source. Can I come on the second continuous source? Huh? Tell me the graph. Tell me 4 examples. Okay, you don't have to describe the graph again and again. I have shown you the graph 4 times in all 4 examples just for your understanding. You have to describe the graph once. You should be able to draw the graph. So in the graph, I will draw x-axis, I will draw y-axis, I will draw the exposure, and I will draw rapid rise, rapid fall. Rapid rise, rapid fall, 1 incubation period, no secondary wave, brief exposure. Done, 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 done. And I will say 4 examples. What are the 4 examples? Food poisoning, okay. Bhopal gas tragedy, Chernobyl tragedy in Ukraine, and Minamata disease in Japan. So you can quote these 4 examples based on this graph. Got it? So can I come on the second one, people? You are not giving the thumbs up. Are you people live or not? Huh? Have you got it? So be interactive in between, no? Chalo. So we will go on the second one. Still, people, still, I'm teaching you time. Not place, not person. In the time, still, I'm teaching you short term. Not long term, not periodic. In the short term, I've already explained the first point. Now I'm explaining you the second one. So I've already explained point exposure, and now I'm explaining you the continuous exposure. Okay, so it is opposite. Here the exposure was brief. Here the exposure will be continuous. Okay, here exposure is not for fraction of minutes. It's always there. Okay, so continuous exposure. Continuous exposure. This is the graph. You can see the graph. Here rapid rise. Rise is rapid, like a point exposure only, but gradual fall. Fall is not rapid. So there is rapid rise, but gradual fall. Rise is same, but fall in contrast to point exposure. In point exposure, it was rapid fall, rapid rise, rapid fall. If you remember, here rapid rise, gradual fall. Okay, because I will take the example, then I will be able to show you the features. Okay, for example, there are 2 examples. Imagine there is a contaminated well in a village. You know, in the village, people drink water from the hand pumps, from the wells. There is a contaminated well. Okay, well contain the Vibrio cholerae bacteria. Vibrio cholerae bacteria, I taught you in microbiology, yes. So this cholera, the water is contaminated. Okay, and it's there continuously, it's already contaminated. So people are coming, drinking water, having cholera. This person is going, another is coming, another is drinking water, having cholera. He is going, another is coming. So source is continuous. It's not for brief exposure. The source is continuous there. You are getting my point, huh? So that's why rapid rise. Many people in the village have cholera, but gradual fall. Okay, and there is multiple incubation period. The incubation period will be multiple. It's not single incubation period. Multiple incubation period. And mind it, here we will have secondary waves. Secondary waves are also present in contrast to the point. So say the features, people, quickly. So what is continuous source or multiple source? Huh? Exposure from a common source. Okay, for a prolonged time. Okay, like the well water present forever. For many months, for many years, the well water is present. Different people are coming, consuming it, drinking it, having cholera. Those people suffered, another people are coming. They are drinking, they have cholera, another people are coming. So source is prolonged, it's continuous. Exposure is not at the same time to all the people. One person is coming, drinking water, he has cholera. He is gone, he is going. Another is coming. So exposure is at different time. In contrast to point where the complete Bhopal, complete Chernobyl, complete Japan was having single point exposure. Here exposure is not at the same. It is not explosive. That was explosive. So all the 3 points are different. There in point source, the exposure was brief. Here the exposure is prolonged. In point exposure, all the person have exposed to same time. That's why it was explosive. This one is not explosive. It is in different time frame. Okay. Regarding graph, there is rapid rise but gradual fall. Rapid rise but gradual fall. And secondary waves are present and more than 1 incubation period. So everything is opposite. Okay. Rapid rise, gradual fall, multiple incubation period, and secondary waves are present. You are getting it? Okay, G. So these are the features of this graph. Now there are 2 examples. There we have 4 examples. Here we have 2 examples. One I have already explained you. Contaminated well in a village, leading to the outbreak of cholera. Because the water in the well is contaminated with Vibrio cholerae. Different people are coming, drinking, going. Okay. The second example is the prostitute. Okay, a prostitute, a sex worker. Suppose the sex worker is having some STD, okay, some sexually transmitted disease. And suppose it is gonorrhea or HIV or any sexually transmitted disease. Okay, so the sex worker, different clients are coming to the sex worker different time, having the sexual exposure, and they are having the diseases different time. Okay, so suppose this is a prostitute having one of the STD. So different clients are coming at different time frame, and they all have the gonorrhea or whatever STD she is having. She is transmitting to different clients one by one. So the source is continuous, again, like the water well. The source is there. Different people are coming and consuming it, or like that. Okay, so this is continuous exposure. So tell me the graph here, tell me the graph here. Tell me 4 examples here, tell me 2 examples here. In the end, we will revise. Okay, can I come on the third one? So you have to tell me graph here with 4 examples, graph here with 2 examples. Don't only draw the graph, say the properties of the graph also. The third and the last is propagated. What is the third and the last? It is propagated. Okay, what do you mean by propagated? This was single source, single exposure. This is continuous exposure. This is propagated. The best example is COVID. 2019, I guess everyone remember that deadly year. Yes or no? When we faced the COVID pandemic. So, suppose this was the person having COVID. This person transmitted to 4. And the next 4 transmitted to next 4. The next 4 transmitted to next 4. You are getting it? Now, some of them are immune. They already have the vaccine, or they already have the disease previously. They are immune. So they are not getting the infection. But the non-immune person are getting the infection and continuing the chain. I guess you can understand the meaning of the propagated. So person to person transmission. Here, source is not fixed. Every new case becomes the source for the other. You are getting my point? Suppose this is the first source. This person is transmitting the disease to the 3. These 3 are transmitting to 3, like that. But some of them are immune. They are breaking the chain. And the non-immune susceptible person are continuing the chain. It's a chain reaction. So where is the source? Source is not only this one. This is the source for these 3. Now, these 3 are the source for the next one. Now, these are the sources for the next one. So every new case becomes the source for other. That is the meaning of propagation. It is not like Bhopal gas tragedy in which single source was there. It is not like prostitute or well water, contaminated well water, where single source but continuous prolonged exposure is there. Here source is shifting. It is changing like a chain reaction. That is the meaning of the propagated. It is person to person transmission. Every new case becomes the source of the other. You have to learn this line. It is the biggest line over here. Every new case becomes the source of the other. So source keep on shifting. Getting my point? So what is the graph here? COVID example. Example is COVID. So there is gradual rise, gradual fall, gradual rise, gradual fall. In contrast to other two, rapid rise, rapid fall, rapid rise, gradual fall, but gradual rise, gradual fall. In the end, I will show you 3 graphs together. Don't worry. So there is gradual rise, gradual falls, gradual fall. Secondary waves are present and more than 1 incubation period. Secondary waves are present over here also, and more than 1 incubation period. Here also more than 1 incubation period. Okay, that's okay. But the most important thing here, the spread depends on the herd immunity. You know what is herd immunity? I told you, some persons are immune. The immune person break the chain. They don't transmit the disease. Suppose this is the index case. This person is transmitting to disease to all around him. Okay, but some persons are red and some are blue. The red one are immune. They don't transmit to other, but the blue one will continue the chain. Okay, so here herd immunity. Herd immunity is the immunity of the community. How many are vaccinated? How many are immune? Okay, here immune person is very less. Only 1 person is immune. So here transmission rate is more. Here red is many. Immunity is more. Okay. I'm sorry. Here no herd immunity is there. That's why transmission is fast. Here herd immunity is there. The green persons are the immune. Okay, so here transmission is slow. So here the person to person transmission depends on herd immunity. Introduction of the herd immunity. I will teach you in detail what is herd immunity in my next session, in which I am going to teach you the epidemiology of infectious disease. I guess my next PSM lecture is after Diwali. I guess the next lecture is on 23rd. We are having a Diwali break in between, 5 days break. And after that, the next PSM session, my third session, which will be on the app only, and in which we are going to continue. Okay, anyways. So everyone got it? So we are done. So here example, the best example is epidemic of polio, hepatitis A, epidemic of COVID. Okay, so we are done with the 3 type of short-term fluctuation. These all are epidemics. They are short-term fluctuation. The 3 type of short-term. Now I will explain you long-term fluctuation, periodic fluctuation. But before that, we finish short-term. What are the 3 type of short-term fluctuation? People say, what are the 3 type of short-term fluctuation? Say, ma'am, point exposure, continuous exposure, and propagated. Okay. Point is also known as single exposure. Continuous is also known as prolonged or multiple exposure, and this one is propagated. Say the features of the graph. Say the features of the graph. Can you state the features of the graph? Say, ma'am, rapid rise, rapid fall, rapid rise, rapid fall, rapid rise, but gradual fall, rapid rise, but gradual fall, gradual rise, gradual fall. Here, gradual rise and gradual fall. And yes, you can compare them. See, I'm going from the screen. You can compare them. Compare the three type of graph. See the rapid rise, rapid fall in the first, rapid rise, gradual fall in the second, and gradual rise, gradual fall in the third one. I hope you got the three type of the graphs. Okay. Now here it is completely one incubation period. One incubation period. Here multiple incubation period, multiple incubation period. Talk about the incubation period. Here no secondary waves. Here we have the secondary wave. Here we have the secondary waves. So that is the properties of the graph. Now state the examples. How many examples you can learn? Here I know 4 examples. Here I know 2 examples, and here we can quote multiple examples in which epidemic occur. Okay, so here the 4 examples I can remember: Bhopal gas tragedy, Chernobyl tragedy, Minamata disease of Japan, food poisoning. Here I can remember the well, the contaminated water in a well which is continuously present in a village, and the prostitute, the sex worker which is having one of the STD. And here all the COVID, hepatitis, polio. Now we can say the propagated one, person to person transmission, depends on the herd immunity. So these are the properties you have to say. You should be able to draw these, and you should know the pinpoint where you have to make the difference. Here you have to draw like this, like this. Here you have to draw like this, but like this. Here you have to draw like gradual rise, gradual fall. You should be able to draw. People practice. Got it? Give me a thumbs up, everyone. Can we go ahead? So we are done with the short-term fluctuations. Still, I'm teaching you time. I'm not moved on place and person. Okay, so still I'm teaching you time. In the time, I'm done with short-term fluctuation. I taught you the 3 type of short-term fluctuation. I taught you the graph of all 3, the features of the graph of all 3, and examples of all 3. Now I'm coming on long-term fluctuation, which is known as secular trend. The long-term fluctuations are known as secular trend, long-term fluctuation. Okay. So here, disease changes over a long period of time. It don't change frequently. The trend of the disease changes in years. Either it increases with time or decreases with time. For example, chronic heart disease, lung cancer, diabetes mellitus, they are showing upward trends in the last 10 years. In the last 10 years, we found these diseases are increasing. They are showing increasing trend in the last 10 years. Okay. And TB, typhoid, diphtheria, polio, in the last 10 years, they are showing decreasing trends. Okay. So if we see the trend over years, these are the diseases, they don't have epidemic. Okay. They show fluctuation over years. Okay. My current hypothesis is smoking leads to lung cancer. So my disease is lung cancer. So with time, it's on increasing trend. In the last 10 years, we found abundant increase in the cases of the lung cancer. Whatever is the reason, but we found it. Okay. So we are done with short-term fluctuation, the 3 times. We are done with long-term fluctuation. Long-term fluctuation can be on increasing trend, can be on decreasing trend over the years, maybe 5 years, last 5 years, last 10 years, last 20 years, like that. We see the trend. Learn the word trend. Trend का मतलब क्या होता है? We see the trend in the last few timeline. Okay. So last few years we see the trend. Now coming on periodic fluctuation, the last one. So time will be over. Okay. So periodic fluctuations are of 2 types: seasonal and cyclic. Seasonal and cyclic. Some diseases, these are periodic, come over a period of time. So some come season to season, and some come every 2-3 years, like cyclic. Seasonal diseases, you can see these are the seasonal diseases. This is the graph of the seasonal disease. For example, measles occurs in spring season. Respiratory tract infection occurs in winters. Now the winters are started. Okay, the winters have just arrived, and many people have respiratory tract infections in the winters. Okay, diarrhea occurs in summers. You may have seen in summers, many people have diarrhea. Okay, so these are seasonal diseases. Season to season they come. Okay, and these are cyclic. In the cyclic diseases, you see measles. The epidemic of measles comes every 3 years. The epidemic of rubella comes every 6 years. The epidemic of influenza comes every 10 to 15 years, like that. So these are cyclic. So we are done with time. People, we are done with time. Time, place, person, descriptive study. Time, place, person. We are done with time. I taught you short-term fluctuation. The 3 types of the short-term, you know the 3 graphs. I taught you long-term fluctuation. You know trend is either increasing or decreasing. I taught you periodic fluctuation, and you know the graph of these also. You know the properties, you know the examples. You have to learn the examples basically. Okay, so time is done. So let's come on the place. Okay, now for my hypothesis, tell me regarding time. What is my hypothesis? Smoking leads to lung cancer. So for lung cancer, is it showing short-term fluctuation? If it is short-term, which one? Is it showing long-term fluctuation? If it is long-term, it is increasing trend or decreasing trend? Or is it showing periodic fluctuation? Is it seasonal or cyclic? So you tell me for my hypothesis right now. For lung cancer. For lung cancer, it's not short-term. It's not periodic. My hypothesis, lung cancer is showing long-term fluctuation. In the long-term fluctuation in the last 10 years, the trend is on increasing side. So that is for my disease. I taught you completely. From my hypothesis, relevant is this one. Okay, so this is smoking leads to lung cancer, and lung cancer show long-term fluctuation. Okay, and the trend is on increasing side. So we are done with time. Time was the biggest one. Now come on the place. Place. We have to describe our hypothesis. We have to describe the disease and the hypothesis. What is my hypothesis? Smoking leads to lung cancer. So lung cancer is my disease. I have to describe in terms of time, in terms of place, in terms of person. Time is done, not place. For the place, we have to draw spot map. Spot map. Whatever is your population. What is your population, by the way? You are studying the hypothesis smoking leads to lung cancer. So what is your hypothesis? Your hypothesis is Delhi, Mumbai, Hyderabad, Indore, complete India, US. What is your population? Whatever is your population, I'm not concerned about that. Draw the map. Draw the map. Map of that population. It is known as spot map. Draw the map. Whatever is your area. Is it Delhi map, Mumbai map, Indore map, whatever map. So draw the map of your population under study. Okay, in which you are testing, in which you are formulating your hypothesis, performing the studies. This is the map of that particular geographical area. Now, spot the cases. Go home to home. Distribute your people. I'm having people hired under me. I'm an epidemiologist, and my people will go place to place. I will allot them colonies. They will go colony to colony because complete city is not covered by one people. No, it will take time. So I will allot 10 people, 20 people. I will allot them the areas. They will go home to home and ask, do anyone have lung cancer at your home? Do anyone have lung cancer in your home? And like that. And whatever is my operational definition of the disease, if it is fitting that, they will make a cross. So I got these all crosses are the lung cancer in my population under study. For example, my population under study is Delhi. So this is the map of Delhi. For example, this is Delhi map. So I got the cases like this. You can count how many cases are there in the entire Delhi in my population. But I found one thing very vague, very unique, very weird. I found that there is clustering of cases over here. Clustering of cases. Now I'm thinking, why there is clustering of cases here but not anywhere else? So it may it may ignite my thought process. So why lung cancer is more in this area? So maybe people smoke more in this area. Maybe it is the area where gangsters live, or I don't know which people smoke more, or maybe corporate area. Corporate में smoking is more nowadays, or I don't know which one. So maybe I can correlate somewhere. Why lung cancer is more in this area? If my hypothesis is correct that smoking leads to lung cancer, so lung cancer is more in this area. So smoking maybe there in more area. Maybe there are more BD and cigar stores in this area. People are purchasing and smoking. Maybe the college students are there. I don't know, but I can correlate like that. I can think why smoking is more in this area, why lung cancer is more only in this area, not this area. So that is the relevance of the spot maps. Spot maps display geographically that where are your cases, and it ignites your thinking that why cases are clustering in one area, not another. The best example I can quote here is John Snow. John Snow is a great scientist. He's a great epidemiologist, a great scientist. What he have done, this is the map of London. He was doing an investigation and he have drawn a spot map of, this is not entire London. This is Golden Square district of the London, some area in the London. So Golden Square district London ka map you can see, and he found there is clustering of case over here, not anywhere here. Cholera cases. He found the clustering of the cholera cases only in this area, not anywhere here. Then it ignited the thinking of the John Snow. John Snow thought ki why cholera is occurring only here, not anywhere else in the London, only in the Golden Street Bridge, only here the cholera cases are clustering. Why? Then he found out there should be something common in all these people which is not present in other these people. He found out what is common. So the water source is common. They all are getting water from a common river. Okay, these people, this area of the London, the Golden Square area is getting the water from a common water pump, and that is contaminated. At that time, I mean in 1854, it is not 1954, it is more than 200 years. Okay, so it is 1854. At that time, Vibrio cholerae discovery was not done. Vibrio cholerae is the bacteria, no? Vibrio cholerae discovery was done 50 years after this. So before the bacteria was diagnosed, it was discovered. John Snow told that there is some organism which is contaminating this water and that is causing a common disease in a group of people. That was the game at that time. You got my point? That was the shot. So with the help of the spot map, John Snow have proven that there is a common source of water in all these people. And I mean, the water is contaminated with some organism. Which organism, I don't know. But later on, it was discovered it was Vibrio cholerae. That is causing clustering of cases. That is the importance of spot map. So we have to describe our disease in terms of spot map. That is place. So we are done with time. Time, we have three options. Place में we have to draw spot map and we have to notice the clustering. If there is clustering, we should think why there is clustering. We should be reasonable why there is clustering. So that is the importance of the place. We are done with time. We are done with place. Now we are coming with person. Okay. Now in your population, this is your population under study. So my population is Delhi population. Suppose I'm proving my hypothesis that smoking leads to lung cancer in Delhi population. So I must describe in my population which age group lung cancer is common. My hypothesis is the same. Smoking leads to lung cancer. So lung cancer is common in which age group? In children, in young, in middle age, in old. So it is common in 30 to 40 years. Okay. In gender, which gender? Male or female? So it is more common in male as compared to female. Ethnicity. Okay. Marital status. It is common in married or unmarried. It is common in business or service. If it is business, which business? It is common in which social class? It is common in poor people, middle class people, or high class people, like that. So based on various aspects, we have to describe our population. That is person distribution. Okay. So we are done with time, place, person. Describe your disease or describe. Descriptive may describe your disease. Describe your hypothesis in terms of time, in terms of place, and in terms of person. In terms of time, just think your disease is showing short-term fluctuation, long-term fluctuation, or periodic fluctuation. In terms of place, draw the spot map of your disease and see the clustering and be reasonable for the clustering. Why clustering is there? You should be reasonable for that. It should fit in your hypothesis. Okay. And in terms of person, describe your disease, in which age group it is common, in which gender it is common, in which marital status it is common, in which occupation, in which religion, in which caste it is common, like that. So you have to describe time, place, person. And here we finish the third step of descriptive study. There were 4 steps now. First we describe the population. What is my population? Delhi population. Then I describe the disease. What is my disease? Lung cancer. Then I describe my disease in terms of time. In terms of time, my disease is showing long-term fluctuation. Okay, and that is to increase in trend. In terms of place, I have drawn the spot map of Delhi and I have found the clustering. And I have found where there is clustering, there is more smoking. And I have proven again that smoking leads to lung cancer. In terms of person, I found it is more common in male as compared to female. It is more common in the young people as compared to old people, like that. Okay. So I have described my disease in terms of time, place, person. Now, finally, I will formulate my hypothesis. See, ma'am, you already have a hypothesis that smoking leads to lung cancer, but it's incomplete. I will formulate the complete hypothesis. Correct and complete hypothesis. Last step. For example, this is rough hypothesis. Smoking leads to lung cancer. This is the rough hypothesis. My complete hypothesis can be like this. Like smoking of 30 to 40 cigarettes per day. Suppose someone is smoking 30 to 40 cigarettes per day causes lung cancer in 10% of the smoker over the 20 years. Suppose there is a person who smoke 30 to 40. By the way, I don't smoke. Okay, I'm just doing the expressions, but I don't smoke. Okay, so if a person smoked 30 to 40 cigarettes in one day, so over the next 20 years, 10% of these persons will have lung cancer. So that is a hypothesis, the complete hypothesis. Based on the rough hypothesis, I created a complete hypothesis. That is my last step. So we are done with descriptive analysis. Descriptive studies are done. My first portion of the lecture is done. Now I will come on my second portion and last portion of my lecture, that is analytic. It is also big, like descriptive only, but it is more interesting. So I will come on the analytic study now. Okay, experimental we will do in the next lecture. Okay, I do not want to rush. Okay, so descriptive is done. Okay, learn the 4 steps of the descriptive study. You get a long question in your university exam on this. What are the 4 steps? Step number 1, define your population, then define your disease, then define your hypothesis in terms of time, place, person, and then formulate your hypothesis. On each of them, you have to draw something, write something. I'm sure you can write more than 10 pages on that now, and you can draw many graphs and diagrams. Yes or no? So we are done. Finally, we have formulated the hypothesis. I'm having some MCQs for you based on the descriptive study, and then we will move on the second portion, that is analytic study. First, you tell me how many of you understood. Everyone give me a thumbs up. Show me some energy. And then you tell me how many of you are ready for the MCQ solving. I will launch the polls. One by one, I will launch the polls. Are you people ready? Can I launch the polls? Let's start it. Thumbs up, people. Come on. Show some energy. Chal. So I will try to launch the poll. You will be having 15 seconds. Okay. Okay. You see the question over here. Just a second. Where I can see the poll. Just a second. You can see the question over here. You are having 15 seconds. 15 seconds are sufficient, I guess, to give the answer. Read the question, tell me the answer. The poll is there in front of you. True about point source epidemic. Tell me which of the following statement is true about point source epidemic. It occurs in more than one incubation period. Is it true? It occurs in one incubation period. Is it true? More than one? Key one. The exposure is continuous. Or epidemic curve falls very slowly, gradually. So most of you are correct. I guess 77% of you are correct. I can see the names also. Congratulations to all of you. The correct answer among them is B. So I told you now about the point source. The graph is rapid rise, rapid fall, and one incubation period. It is not more than one. It is one incubation period. The source is not continuous. Bhopal gas tragedy. It is single point source. And there is rapid rise, rapid fall. So correct answer among them is B. You all are right. The next question is in front of you. You can see the question. Meanwhile, I'm launching the poll. You can see the question meanwhile. You can see the question. Bhopal gas tragedy is an example of. Is it an example of point source, propagated source, continuous, epidemic, or modern epidemic? What is the correct answer? I guess everyone is correct over here. Yes? I guess most of you are not correct. Bhopal gas tragedy, come on, people. Why? Is it some problem here? Most of you, okay, 60% are correct. It was an easy question. Bhopal gas tragedy is an example of point source, no? In which there is leakage of the gas methyl isocyanide and the complete city get exposed in one brief period. The epidemic was explosive. So correct answer is A. Many of you have marked B, 40% people. I don't know why. It is not propagated at this point. Propagated में COVID, hepatitis, polio epidemic will come. Person to person transmission depending on the herd immunity. So correct answer over here is A, not B. Okay. The next question is in front of you. You can see the next question. Please see the next question. I'm launching the book. You can see all of the following are true about point epidemic except, don't miss the word except. Which of the following is false for point epidemic? So you have to tell me the correct answer. Most of you are correct. Yes, good. So epidemic curve rises and falls sharply. Yes, it's correct. Clustering of cases within a short incubation period, one incubation period. Yes. Person to person transmission? No. Person to person transmission occurs in propagated, not in point. And all cases develop in one incubation period. Yes. So C is incorrect among them. Okay. Okay. So C is incorrect among them. So correct answer is C. So coming on the next question, you can see the next question. Okay. And I'm launching the poll. See the next question. I'm also looking for this better feature for the poll. On the app, whatever suggestions you are giving, I will improvise on the app so that you have a better experience of giving poll. But meanwhile, you can see true regarding point source epidemic. Which of the following is true? Secondary waves there? No. There is rapid rise in the wave, which flatten later on. No, there is no flattening. Rapid rise, rapid fall. All cases occurs in one incubation period. Right. It is propagative. No, it's not propagative. So correct answer among them is C, and most of you are correct. Okay, the correct answer is C, and most of you are correct. One more last question I'm having. Okay, read the last question. Okay, read the last question, and here is the poll. You can see the last question. A well of contaminated water resulting in epidemic of acute diarrhea. This is a typical example of what? Is it common source single exposure, common source continuous exposure, or slow epidemic or propagated epidemic? So most of you are correct. I told you well and the prostitute. Both were example of common source but continuous exposure. They are continuously present there. Okay, different clients, different people are coming and getting infected. So I guess Again, 50% of the people are correct. The correct answer is B. Are you getting confused? What is the problem? The time to answer is less. There is some technical glitch. Why you people are wrong? You didn't got it. Poll is appearing before the question. We will sort it out. Okay, give me some time. Okay, my tech team will whatever is your suggestions. So can we go ahead? Give me a thumbs up. Can I start the second portion of this session? Yes. Are you people there? Give me a thumbs up, everyone. Can we go ahead? Let's start the analytic epidemiology. We are done with descriptive epidemiology, and now I will start the second portion, that is analytic epidemiology. Descriptive epidemiology, done. You know the 4 steps. You know the 4 steps. Among them, the most important step is describing the hypothesis in terms of time, place, and person. Okay, and now I'm starting with analytic epidemiology. Okay, in analytic epidemiology, there are 4 types of studies: case control, cohort, cross-section, and ecological. But cross-section and ecological are not important. So I will focus on these 2 studies in detail one by one. Okay, so we will study the analytic study. What we do here in descriptive study, which is already done, we formulate the hypothesis. In analytic study, we test the hypothesis. We are testing the hypothesis now. We have already formulated the hypothesis, the complete correct hypothesis, I told you. Now, and now we will test that hypothesis. My hypothesis is still same. Smoking leads to lung cancer. Okay, people, can I start analytic? Give me a thumbs up, people, everyone who is live, alive, awakened, not sleeping, interested. Please give me a thumbs up in the comment box. Can we start? So let's start the second portion, the second type of study, analytic study, in which I will teach you these 2 in detail, and here we will test the hypothesis. Okay, so this is the second type of study in which we will test the hypothesis. Okay, got it. Okay, we will test. You already know these 2 things. You can see it here. This is the second study in which we are testing the hypothesis. So let's start it. So here, out of the 4, I will teach you 2. The other 2 are not important. I will give you a brief points among them, but these 2 are very important. We will see their detail. So we will see case control study. We will see cohort study one by one. Let's start with the case control study. Can I start with case control? The first one is case control, and then I will come on cohort. These are the 2 types of analytic study. We are done with descriptive, and now I'm teaching you analytic, in which we will test the hypothesis. This is second study. Third, I will teach you in the next session. Okay, here first I'm teaching you case control, then I will teach you cohort. So I'm starting with case control. It's very interesting and it's tricky. I'm not saying difficult, but it's tricky. I will make it fun for you. A super duper easy, a cakewalk. But please concentrate. Concentrate. If you are feeling less energy or drowsy, have a cup of strong coffee. But please concentrate here. Okay. So let's start the case control study. Okay. Case control study made, there are 2 things. One is case, one is control. So who is case, who is control? It is super easy, people. Please understand. Who's case? Case is the people who have the disease, and control are the people who are healthy. They don't have the disease. What is my hypothesis? Don't ever dare to forget my hypothesis. What is my hypothesis? Smoking leads to lung cancer. So what is my disease? My disease under study is lung cancer. So the one who have lung cancer are cases. The one who do not have lung cancer are control. The control can have any other disease. Maybe my control is having hypertension, my control is having TB, my control is having any other disease, but my control do not have lung cancer. So I will say it's a control. So disease under study present. If it is present, it's a case. If it is absent, it's a control. So we will compare the cases with the control. Okay. So who's the case? Who's control? The person who have lung cancer, proven lung cancer. My disease under study is lung cancer. Smoking leads to lung cancer. Take one hypothesis for understanding it. You can't understand the study without having any hypothesis. My hypothesis for entire session is smoking leads to lung cancer. My disease under study is lung cancer. So the people who have proven lung cancer are my cases. Lung cancer present, disease present. Okay. And the people who do not have lung cancer, disease absent, are my control. They may have some other disease, but not the lung cancer. So who is case? Who is control? Very simple. Disease present is case. Disease absent is control. Learn one golden rule. What is my golden rule? The golden rule is disease. Disease present and disease absent. If disease is present, it's a case. If the disease is absent, it's a control. Okay, disease can be anything. For my hypothesis, disease is lung cancer. Okay, learn this golden rule. If you have understood it, if you have understood who is the case, who is the control, if you have understood it, who is the case, who is the control. Now learn 2 more terminologies. You want to understand case control study and cohort study. Okay, who is exposed, who is not exposed. Again, tell me what is my hypothesis? My hypothesis is smoking leads to lung cancer. Okay, the person who smoking is exposure. I told you, we can say it's exposure, it's a risk factor. Okay, exposure, risk factor, meaning is same. So if exposure present, I mean the person who smoke, exposure present is known as exposed. And exposure absent, I mean the person who do not smoke, who have never smoked till date, okay, they are known as non-exposed. So what is the summary till now? What is the summary till now? See the summary. My hypothesis is smoking leads to lung cancer. Okay, see, this is my hypothesis. Please understand, people, it's tricky. Smoking is risk factor and lung cancer is disease. Okay, till now it's clear. Smoking is risk factor. It is risk factor which is leading to a disease, that is lung cancer. Now risk factor present, risk factor absent. Okay, disease present, disease absent. You are getting it? Make it super simple. So the smoking, I mean risk factor present, it is known as exposed. The person who smoke, I will call them, they are exposed. The person who have never smoked in life, like me, I have never smoked in life, so I'm non-exposed. Okay, non-exposed. Okay, exposed, non-exposed. Risk factor present, risk factor absent. Now the definition: risk factor present, money exposed. Risk factor absent, money non-exposed. Risk factor can be anything. In my case, it's smoking. Okay, suppose HPV leads to cervix cancer, so their HPV is a risk factor. Okay, now disease present, call it a case. Okay, and disease absent, call it a control. In my example, the disease is lung cancer. The person who have lung cancer, they are cases for me. The person who do not have lung cancer, maybe some other disease they have, they are controls. So please be super, conceptual. You have to learn this thing. If you are clear with these four things, then only I can proceed. Everyone is clear? Give me a thumbs up, everyone. Everyone give me a thumbs up. So what is case, what is control, you know? Disease present, disease absent. What is exposed, what is non-exposed, you know? Exposure present, exposure absent. If you are clear with these four terminologies, let me tell you the design of case control study. Let me tell you the design of case control study. What is my population under study? For example, my population under study is Delhi. I told you, I can select any place. So I have selected Delhi. Okay, my population is Delhi population. So I'm an investigator. I mean, I am epidemiologist who is investigating on this hypothesis that I want to prove smoking leads to lung cancer. Okay, so my population is Delhi population. This is my Delhi population, from which I will find out 100 cases and 100 control. So starting point is case control. That's why it is known as case control study. This is the starting point. Find out 100 cases, find out 100 control. So I am finding 100 cases and I am finding 100 control. You can see 100 cases, the people who have lung cancer, and 100 control, the people who do not have lung cancer. This is my starting point. Okay, finding 100 cases. 100 is an arbitrary number. You can find 1000, you can find 10,000, you can find 1 lakh, depending on your population size. The more is the number, more reliable will be the study. But finding 1 lakh cases of lung cancer will be difficult. Finding 1 lakh healthy people will be easy. Okay, so for how you will find 1 lakh cases, so make it 100 for understanding, but you can take any number depending how much is your sample size and how big you want to conduct the study. Okay, suppose I do not want to conduct it very big. I'm just taking 100 cases and 100 control. 100 lung cancer patient, I can go to some oncology hospital, okay, the cancer hospital where cancer patients are treated. I will request them that I'm an epidemiologist, I'm an investigator, I'm doing work on some hypothesis of lung cancer patient for their benefit. So kindly give me the records of lung cancer patient. They will give me the records. I will find their address. I will call them. I will ask them, can you participate in my study? Please, I'm an investigator. I'm doing some study for the benefit of the community. If you participate, you will be benefiting the community. Okay, if you are a volunteer, I will give them address of my office and call them. Okay, so suppose this type, I found 100 cases, I found 100 control. Taking their permission of the volunteers is very essential. Without their consent, you cannot participate them in this study. So all of them, the consent form is given in the language they understand, English, Hindi, Marathi, whatever. So you make them understand that what study you are going to do in the study, what exactly is their role, and you take their sign if they are willing to participate in the study. So taking consent is very important. So I found out 100 cases. They all have lung cancer. Okay, they are poor patient. I mean, not poor financially, but pity patient, you can say. They already have the disease, they have the lung cancer, and they are ready to participate in my study. And these are the controls. They don't have any disease, or they have any other disease but not lung cancer. They're also ready to participate in my study. So finally I have found 100 cases, 100 controls. Suppose this is my office. I'm having a chair in my office. There is my chair and I'm sitting in my office. Okay, suppose So this is my office. I'm sitting. I will call 100 cases, 100 control. I will ask the 100 cases to stand on this side. I will ask the 100 controls to stand on this side. They all are volunteers. They have given the consent to participate in the study. Okay, so 100 cases are standing this side in my office. 100 controls are standing this side in my office. Okay, now what I will do, if you can see it here. It's very easy. 100 cases, 100 control. Now in my office, I will call them one by one. I will start calling cases first. One by one, I will call them. I will ask them one question. Only one question. Do you smoke? Yes or no? In the last 10 years, you have smoked? Yes or no? If they say yes, I will consider them exposed. And if they say no, I will consider them non-exposed. So cases, among the 100 cases, some may be exposed, I don't know the number, and some may be non-exposed. The one who are exposed, they all together known as A. The one who are not exposed, together they are known as C. And they all have lung cancer. They all have lung cancer. So they all have lung cancer. Imagine a person who's having lung cancer. I'm calling it in my chamber, in my office, and asking, do you smoke? So these will say, yes, ma'am, I smoke, but I was not knowing at that time when I smoked that I will have lung cancer in the future. I wish I could have known before, so I will not have smoked, but I already have the lung cancer. Okay, so these are the pity people. Okay, these are double pity people. They will say, I have not touched the cigar till date. Still, I have the lung cancer. They already have the lung cancer, but they have not touched the cigar. They don't have smoke yet date, but they are very pity people. They still have the lung cancer, because lung cancer can have other factors also apart from smoking, other risk factors. You're getting my point. So these are the pity people who have not smoked, still they have lung cancer. They all are cases. They all have lung cancer. Some of them smoked and then they have lung cancer. Some of them do not smoke and they have lung cancer. You're getting my point, huh? Now, I will call the controls. I will start calling control one by one. Again, I will ask the same leading question. Do you smoke? Do you smoke? Yes or no? So among the controls, some smoke, some do not smoke. Again, I will divide them into two groups. The one who smoke, I will call them B. The one who do not smoke, I will call them D. So totally from the population, I took 100 cases, 100 control. I mean 100 people who have lung cancer, 100 people who do not have lung cancer. Here also I divide them into two groups, the one who smoke, the one who do not smoke. Here also I divide them into two groups, the one who smoke, the one who do not smoke. So totally I divide them in four groups. Okay, these are the people, see my hand. These are the people who have lung cancer and they smoke. These are the people who have lung cancer but they don't smoke. These are the people who do not have lung cancer but they smoke. These are the people who do not have lung cancer and they do not smoke. You are getting my point? What I have said? I have said four statements. I tried my best. I'm trying hard. People respond. Got it? This is the design. This is the design. Okay. So we are relying on the person's conversation. Now this person, these are the 100 cases. I will call them one by one. I will ask a leading question. Do you smoke? Now they can lie. Suppose the person is smoker, person say, no, I don't smoke. So I don't have anything to check in the past. You are getting my point? So I am relying on the recall of the patient. Recall. This is known as recall. The study is based on the recall. Patient is saying yes, I will say yes. Patient is saying no, I don't have any proof to go and check whether the person was smoking in the past or not smoking. So there can be always a bias. Okay. In case of cases, we don't have bias. Cases exactly remember whether they smoke or whether they don't smoke. But control, these are casual people. They don't know the severity of lung cancer. They are healthy people. They can lie. Suppose there is a smoker person, no, I don't smoke. Or suppose not smoker, maze mein bol raha hai ki yes, I smoke. So the study can have some flaws over here because it is based on the recall. We don't have any proof to check it. So this is known as recall bias. All the biases I will tell you in the next session, but this bias is known as recall bias. Okay, so what is the date today? Today is 12th October 2025, I guess. Yes. So today is 12th October 2025. So in 2025 October, today on 12th, I have started my study. I'm an investigator sitting in my office, 100 cases in front of me, 100 control in front of me. They all have given the consent. I'm calling them one by one, maintaining a register or doing computer entry. Do you smoke? Yes. Do you smoke? No. Do you smoke? Yes. Do you smoke? No. So I have divided them in four groups and asked them, give your address, email, phone number and go back. Study is over in one day. Today only the study. I started in the morning till evening, till night I have conducted the study. What I have to do? I have called 100 cases, I have called 100 control and interrogate them one by one, leading question. Only one question. Do you smoke in the last 10 years? Yes, no, yes, no, yes, no. That's it. Go away. Okay, the study is over. It's a short study, inexpensive study, fast study, rapid study. And what is my consumption? I consumed only one day. I require one register, one computer. That's it. That is my investment. So it is a study which do not require much investment. Okay, it's a cheap study, it's a fast study. Okay, but not very reliable. Cohort will be opposite. Cohort will be long. It requires 5-10 years, not in one day. It is expensive. Okay, but more reliable, like that. Okay, so here the study is done. Now when the people will go, I divided them in 4 groups. Now I will do the analysis. How many of you got the design? How many of you got the design? Have you got the design? So what basically we are doing? We are calling 100 cases, that is 100 people with lung cancer, 100 control who do not have lung cancer. And we are taking history. You smoke, you smoke, you smoke. Yes, no, yes, no, yes, no. And we are comparing them. Okay, so this is what we are doing. So suppose I'm doing the study in 2025. Today, October, 12th October. Hana? There are 100 cases, there are 100 control. These are my 100 cases, 100 control. And I am taking the history in the past. In the last 10 years, do you smoke, yes or no? So suppose out of the 100 cases, 70 say yes, I smoke. And 30 say I don't smoke. So this is my A, this is my C. Okay. And out of the 100 control who do not have lung cancer, only 10 say I smoke and 90 say I do not smoke. So this is my B and D. I told you, we are dividing them in 4 groups. Among the cases, we divide A and C. Among the control, we divide B and D. People, you are getting it. It's complicated, but I am making super simple with the help of flowcharts and images. It is nowhere given in the world apart from my PPT. No book, no Google, no ChatGPT, no AI will give you this type of presentation. The simplest one I'm giving you. Okay, it's a compilation of one. Okay, so this is the design of the case control study, and this is what we are doing. So my point is that we are going in the past. I'm conducting the study in 2025, but I'm interrogating in 2015. Last 10 years. I'm asking them, last 10 years mein smoke kiya ki nahi? Since 2015 till 25, have you smoked? So I'm going in the past. I'm starting the study today. Today I'm sitting in the center, calling cases one by one, calling control one by one, and interrogating them regarding the past. So in the last 10 years, so this study is backward study. So from present, see the direction of the inquiry. From present, I'm doing inquiry of the past. So this study is known as retrograde study because I'm inquiring. I'm doing interrogation or inquiry regarding the past 10 years. You can see the same over here. In 2025, I'm doing the study, but I'm inquiring from 2015. So since last 10 years, you smoke or don't smoke. So this study, look at the arrows. Look at the arrows. It's a backward study or retrograde study. So case control study is backward or retrograde because we inquire or interrogate the past, taking history from the past, last 10 years, last 20 years, like that. Okay, so I hope you got it. So that's why it is known as retrospective study. That's why it is known as backward looking study. You got these names. Now first, what is the start point? What is the start point? From the population I'm picking what? In this study, what I have picked? This is my population, no? Any population, suppose Delhi population. Okay, I'm picking what? I'm picking 100 cases and 100 control. Yes or no? So in my hypothesis, smoking leads to lung cancer. So I'm starting with lung cancer. And then I'm interrogating regarding study. So first I am looking at the effect and then I'm looking at the cause. I'm starting with the effect. Then I'm interrogating or inquiring regarding the cause. Okay, so this is known as effect to cause because my start point is lung cancer. And then I'm interrogating regarding the cause, that is smoking. I'm asking them for the past. So this is effect to cause, or this is known as outcome to exposure, or this is known as disease to risk factor. These are synonyms, I guess you can understand. Okay, so this is case control study. Learn the synonyms. So I told you the design. You should be able to draw the design without images. Images are for your understanding, people. Okay, you should make this design in your exam. You should be able to explain what I'm explaining you. You should be able to learn the synonyms. In your exam, you should be able to identify the study. Now, suppose there is a long question coming, write a note on retrospective study. You should be able to identify they are talking about case control study. You write a short note on backward looking study. You should be able to identify they are talking about case control study. Okay, so this is case control study. Now, we have divided them in 4 groups now. A, C, B, D. Okay, we will make 4 by 4 table. Now, please understand how to make this 4 by 4 table. People, that is a gist of the session. It's the most difficult portion of this table, of the session, how to make this table. Okay, you have to make this table. We will fill this empty table. Okay, then I will show you how to, it is a filled version. So on the top and on the, this is my top, this is my right side. Yes. So on the top and on the right side. Okay, on the top, make a rule. Ek rule bana lo, golden rule. We take disease. Disease present, disease absent. On the top, disease present, disease absent. Can you see? Disease present, disease absent. Top पे हमेशा disease है. Always take disease on the top. And first present then absent. Don't do first absent then present. No, it's like this. And on the right side, on your right side or like left side, whatever you say. So on this side, I mean, okay, you have to take risk factor. Risk factor again present, risk factor absent. Like this. This is 4 by 4 table. Please, people, disease at the top, mane top, and risk factor on the right side, mane right side. Like this. If I'm standing like this, it's my right side, but if I write in a copy, it will be left side. Okay, so you can call left side. So top and left side. It's a rule. First present, then absent. Okay, now write down ABCD. If you don't flip it here, always write disease at the top and risk factor on the left side. If you're not flipping it, first present, then absent, first present, then absent. Then write down this is A, this is B, this is C, this is D. If you flip it something here, if you are taking disease this side, risk factor on the top, or first absent, then present, everything will flip. All the formulas will flip. I will give you multiple formulas now for numericals, but these formulas are applicable if you are making the table like this. If you are flipping it, formulas are non-applicable. People, mind my words. Take my words in consideration. If I'm taking and I'm saying something to mind, you have to mind it. Okay. Disease at the top. It's a rule. You can't change it. Okay. And risk factor on the left side. You can change it. First present, then absent. First present, then absent. Then write A, B, C, D. Okay. Now tell me the story of the 4 type of people. Who will tell me the story of the 4 type of people? People. Who is A? Who is A? A is the people who smoke. A are the people who smoke, risk factor present, who smoke and who have lung cancer. Imagine a person who smoke and who has lung cancer. Okay, the person smoke, the person have a lung cancer. Okay, as you saw, social you reap. Okay, so these are the people. Who are B? Who are B? B are the people who smoke, but they don't have lung cancer yet. Okay, if they quit, they can, they don't have lung cancer in future, but maybe in future they also have the lung cancer. We don't know the future of anyone. But they smoke, but they don't have lung cancer. Risk factor present, but disease is absent. So they smoke, but they don't have the lung cancer. That is the story of B. Okay, so they will be very proud. Yes, we smoke, but we don't have lung cancer. But maybe in future you will have. These are the pity one, very pity. Okay, they smoke and they also have the lung cancer. But as you saw, socially, you shouldn't smoke now. You know if it is you, you know. Okay, anyways, who are C? Who are C? I think among the 4, these are the most pitiest for me. They don't smoke. They have never smoked in life. Still they have lung cancer. Very pity. Even pittier than the A one. इन पे मुझे ज़्यादा दया आती है. They don't smoke. Still they have the lung cancer. Bichare. They are very pity. Yes or no? And who are D? They don't smoke. They don't have lung cancer. Happy people. They don't smoke. They don't have lung cancer. So learn the story of the 4 type of people and learn to make this table. Okay. And you can write down the total. A plus C. Total who have the lung cancer and B plus D. B plus D. Okay, A plus C, B plus D. Total who are healthy. Because what is my starting point? 100 cases and 100 control. So A plus C is 100. These are cases. These are my 100 cases and these are my 100 control. This is my start point. So this is the table. You should learn the table. 4 by 4. Instead of risk factor, you can write down exposure. Risk factor, I have write down risk factor. Risk factor and exposure is same. So on the top, write down disease. On the left side, write down risk factor, exposure, meaning is same, and write down ABCD. And learn the story of all 4 type of people. Give me a thumbs up, people. You are understanding? I will not say the names. Say fast. Yes, you got it? How to make this 4 into 4 table? So this table is known as 4 into 4 table. This is how you have to create it if you got it. Everyone got it? Now we will come on the analysis. How to do the analysis? The table is ready. Study design is done. Till now we have done the study design. I am teaching you the first study yet. Case control study. I have to teach you cohort also. So case control study ka design is done. Table is done. And finally we will do the analysis. So the study will be over. In the analysis, I will calculate 2 things. Formula of 2 things. From this 4 by 4 table, if you have learned, I will teach you 2 formulas. You have to learn 2 formulas. What 2 formulas? Exposure rate and odd ratio. I will teach you exposure rate, how to calculate exposure rate and odd ratio. Very easy. First come on the exposure rate. What the exposure rate will tell us? Whether, what is my hypothesis? Don't ever dare to forget the hypothesis. Without hypothesis, you can't understand anything. What is hypothesis? Smoking leads to lung cancer. Yes or no? Smoking leads to lung cancer. This is my hypothesis. So, suppose, what is association? What do you mean by the term association? Hindi meaning. You know Hindi? Chalo. English, Hindi, what a dictionary meaning of association. We have association with each other. Yes, we have the association. What is association? The meaning, dictionary. Forget the science. tell me, forget community medicine. Tell me a dictionary meaning of the word association. You can do a search. What do you mean by association? Association means it is not by chance. Association means opposite of by chance. If two things are associated, they are not by chance. Okay, there are two things in the world. Either the two things together by chance, or the two things are associated, that's why they are together. Suppose A and B are together. A and B always come together. So maybe they are by chance coming together, by chance, as a, or maybe they are associated with each other. So association is the opposite word of the word by chance. Please understand. So opposite of by chance. Opposite of by chance is association. Okay, so what is my hypothesis? Smoking leads to lung cancer. Yes or no? So maybe by chance I feel so that smoking leads to lung cancer. The two things are not associated. Smoking has nothing to do with lung cancer. Maybe. Okay. Maybe smoking have nothing to do with lung cancer. No association. They are by chance. I have told the two things together. So here exposure rate will tell the association. Exposure rate will tell us whether the two things in the hypothesis, that is exposure and disease, they are associated or not. With this formula, we will calculate association hai ki nahi hai, whether association present or absent. I will tell you the formula, but based on the formula, we will come on a conclusion whether the two things are associated or not. What two things? Risk factor and disease, whether they are associated or whether they are by chance. We will take a decision. If they are associated, suppose, okay, I'm lucky, my hypothesis is right. Okay, if they are not associated, if here we got a negative result, I will halt the study. The study is over, my hypothesis is wrong. Okay, by chance they are together. Okay, so my hypothesis will be wrong. But if I'm lucky, my hypothesis is right. The second thing, odd ratio, I will calculate. That will tell us the strength of association. By association to hai, but what is the strength of association? What is the correlation between smoking and lung cancer? If the person smoke more, chances of lung cancer are more. If this person smoke less, chances of lung cancer is less. Is that the thing? So what is the strength of association? First you decide association is there or not. If it is there, then you decide the strength of association. If association is not there, the study is over. You don't have to conduct the study further. You are getting my point. So we will calculate two things. What are the two things? I'm teaching you case control, people. Case control design you already know. I guess you already know the design. What is the start point? And what are the four groups you have divided? Based on these four groups, you have made this 4x4 table. You know how to make this 4x4 table. Now design is done. 4x4 table is done. Let's come on the analysis. In the analysis, I will teach you two types of formula. Based on this formula, you will decide whether association is present or not between the risk factor and between the disease. And once the association is proven, if it is present, if it is absent, stop the study. If it is present, then decide the strength of association. That will be based on the odd ratio. People, give me a thumbs up. Come on, react, interact. I'm doing efforts to explain you. Show some interest. Huh? So that is the analysis. So let's start with exposure rate. That will tell us only association, present ki absent. Okay, so how to calculate the exposure rate? How to calculate the exposure rate? See, this is how we calculate the exposure rate. Everyone here, see, we will calculate the exposure rate in cases and exposure rate in control. Exposure rate in cases and control. See the formula, it's very easy. It's very easy. See, there is a numerator and denominator. See, there is a numerator and denominator. The 4x4 table is in front of you. Now, this table should fit in your mind. You can't reverse this table. Disease at the top and exposure on the left side. Please, and total at the bottom. Please learn this table. This is my starting point. You don't forget. These are 100 cases, these are 100 control. Yes or no? So this table fit in your mind. Now try to create the formula instead of learning. Exposure rate in cases, exposure rate in control. Exposure rate in cases and control. What is the numerator and what is the denominator? First say denominator. I always focus on denominator first. So who are cases? That will be my denominator. And who are control? That will be my denominator. Who are cases? Cases mean disease present. Cases mean the people who have the disease. So disease present in A plus C. So here denominator is A plus C. Okay, and control mean disease absent. Disease absent. So here disease is absent. So it's B plus T. Okay. So among the total cases, how many smoke? These are the total cases, but A plus C. These are the total cases. You can see disease present. Total cases. How many of them smoke? Only A smoke. C don't smoke. So A upon A plus C. And among the control, these are my total control. B plus T. You can see total control. They don't have lung cancer. But among them, how many smoke? So smoking is present only in B. So B upon B plus T. If you have understood, very good. If you didn't understood, double good. Learn the formulas. Doesn't matter. If you are understanding, you can recreate. If you are not understanding, don't mug up. I mean, just learn these formulas. Okay, so what are the two formulas? Exposure rate among cases, exposure rate among control. So it is A upon A plus C and B upon B plus D. Multiplier is always 100. We talk in terms of percentage. Okay, we talk in terms of percentage. For example, there are 100 cases and 100 control in my study. In my study, there are 100 cases and 100 control. Among the 100 cases, 70 smoke, 30 don't smoke. I have given you this example previously. And among the 100 control, only 10 smoke, 90 don't smoke. Now put these values over here. Can you please put it for me? So here it will be 70 upon 70 plus 30, that is 100. Here it will be 10 upon 10 plus 90, that is again 100. So 100 cancel 100, 100 cancel 100. Here answer is 70%. Here answer is 10%. You are getting my point? So exposure rate in cases is 70% and exposure rate in control is just 10%. You are getting my point? So if exposure rate in cases is more than exposure rate in control, the association is not by chance. The association is real. Got my point? So do this calculation. Okay, again start from the beginning. I am an epidemiologist. I want to prove smoking leads to lung cancer. I have conducted step 1, descriptive study. I have submitted my report to ethical committee. They allowed me to go to the analytic study. Now in the analytic, I am having two options. Case control, cohort. Case control is rapid and inexpensive. Cohort is time consuming and expensive. But I am not having much finances. Okay, so I will go with case control. So this is how I conducted the case control study. And this is the design. You can see this is the design. This is the design. I have conducted the study in just one day, today, 12th October. I have created this 4x4 table and based on which I have done my calculations. So this is my calculation. So if exposure rate in cases is more than control, okay, you can see clearly. Exposure rate in cases is more than control. I am allowed to conduct my study further because there is an association between smoking and lung cancer. It is not by chance. But if exposure rate in control is more than cases, I will stop my study here because it is by chance. Okay, exposure rate in control is more means smoking is protecting lung cancer. Okay, the people who don't smoke, they have more lung cancer. So if that is happening in my study, I have to stop my study over here. You are getting my point? Yes or no? So that is the exposure rate. So here we calculate the exposure rate. Tell me the formula. What is the formula of exposure rate in cases? What is the formula of exposure rate in control? Exposure rate in case, exposure rate in control. It is A upon A plus C and B upon B plus D. Am I right? Absolutely right. Okay. And if this is more than this, okay, then there is association. It is not by chance. There is association. Now say the strength of association. Association is there. That is proven. How we prove the association? If exposure rate of cases is greater than exposure rate of control, it proves association. There is association. It is not by chance. There is association. Now we will calculate odd ratio to see the strength of association. So association to hai boss. Lekin what is the strength of association? To calculate that, we will do the odd ratio. Odd ratio is for strength of association. Okay. So how we calculate the odd ratio? Odd ratio is cross product. Odd ratio is cross product. It's AD upon BC in this table. It is AD. The summary is that it's AD upon BC. Can you see? This is AD upon BC. It's a cross product. It comes like this. It is A upon B whole upon C upon D. If you do this, but don't go on these, learn the cross product. It's AD upon BC. Okay, calculate. What are my values? This is 70, this is 30, this is 10, and this is 90. Can you do it for me, please? Can you do the calculations? These were my figures, arbitrary figures I have taken. So 70 into 90. Okay, A into D. 70 into 90 upon B into C. I mean 30 into 10. 30 into 10. So what will be the answer? 7 nines are, what will be the answer? 63 upon 3. It will be almost 21%. Am I right? Am I right? So there is 21 times high chances of having lung cancer. So strength of association is very high. It is whatever is the answer, it's more than 1. I mean to say, I am not interested in calculation, but you can do the calculation, it's more than 1. So odd ratio have 3 options. Answer is equal to 1. So there is no association. There is no association. Smoking leads to lung cancer. There is no association with smoking and lung cancer. They are by chance. Okay, if answer is 1. If answer is more than 1, it's a positive association. Okay, it's a positive. For example, my answer is 21. Okay, so smoking leads to 21 times higher risk of leading cancer. So that is positive. And if answer is less than 1, you know, if BC value is greater than AD, so answer will be less than 1. Answer will be less than 1. If answer will be less than 1, it is negative association. You know what is negative association? Negative association is protective. I mean, it is not the fact, but smoking protects lung cancer. If it was proven, na, I also smoke. If it was the case, we all smoke. Okay, we promote smoking. Everyone should smoke because smoking protects lung cancer. But unfortunately, this is not the fact. It is already proven 100 times, million times, and we found positive association every time. But I wish if we have found negative association, we also. You are getting my point. So negative association means it is protective in nature. So there are 3 options. So based on the odd ratio, we are calculating the strength of association. And what is the formula of odd ratio? The formula of odd ratio is AD upon BC. You can see it's AD upon BC. So learn the formula. So what is the summary, people? What is the summary of analysis of case control? We are done with case control. Make a table of 4 into 4. You should be able to draw this table. Disease at the top, exposure on the left. And this is A. This is not B. ऐसा लिखना है A, B, C, D like this, and this is the total. Okay, tell me the formula of exposure rate. Tell me the formula of exposure rate in cases, and tell me the formula of exposure rate in control. Okay, and tell me the formula of odd ratio. Tell me these 3 formulas. Who will tell? The table is in front of you. Exposure rate in cases, exposure rate in control, and odd ratio. What is the numerator, denominator, numerator, denominator, numerator, denominator? Learn the formulas, people. If you understood, very good. Did you understand? Learn the formula. So here, what are the total cases? Total cases is A plus B. Okay, and total control is B plus D. So this is B plus D. Among the total cases, A plus C, A is smoke. So A upon A plus C. Among the total control, B plus D, B is smoke. Okay, so it is B upon B plus D. Okay, so if A upon A plus D ka answer is greater than B upon B plus D, there is association. Now, tell the strength of association. For strength of association, do cross product. It's AD upon BC. AD upon BC. Now, there are 3 options. There are 3 options. Okay. Odd ratio greater than 1. Odd ratio is equal to 1. Odd ratio less than 1. If odd ratio is equal to 1, there is no association. If it is greater than 1, answer. Whatever answer. I mean, AD value is more than BC. Then it will be greater than 1. So, there is positive association. And if BC value more than AD, so answer will be less than 1. Then it is negative association, I am protected. So first you decide association hai ki nahi hai, based on this answer and this answer. If this is greater than this, there is association. Then you find the strength of association based on the odd ratio, you can find it out. People say you got it, you didn't got it. I tried very hard. Please learn these formulas. Can you see the formula of exposure rate in cases, exposure rate in control, and exposure rate in case should be more than control. Find out the formula of odd ratio AD upon BC, and that will tell you the strength of association. Everyone give me a thumbs up. People respond. Come on. Say, can we go ahead? We are done with case control study. Okay, I'm having some MCQs for you. Will you be able to solve that? I'm not launching poll. You can write down your answer in the comment box. Please write down your answer in the comment box. First, give me a thumbs up. You got it? Okay, read the question. Write down the answer in the comment box. If the odd ratio is equal to 1, what does it indicate? What does it indicate regarding the association? The association is perfect, association is low, association is high, or association doesn't exist. What does it indicate? If the odd ratio is equal to 1. I told you 3 choices, no? Odd ratio greater than 1, is equal to 1, and less than 1. So I'm asking the question regarding is equal to 1. No one have answered. Please be fast. If odd ratio is equal to 1, what does it indicate? Association is perfect, low, high, or D? I mean, does not exist. Here, if odd ratio is 1, association don't exist. Here, association is high, I mean positive. And here, association is low, I mean negative. Okay, so here the correct answer is D, and all of you are right. Very good. Association does not exist. Okay, the next question, cross product ratio is calculated from. Cross product ratio is the other name of odd ratio. I told you, because we are doing cross product AD upon BC. So it is done in which study? It is done in case control study. I am teaching you case control study. So the correct answer here is case control study. I am only telling you the answer. Okay, so identify the pattern of the study. Look at the arrows and identify the pattern. So we are starting. This is the start point of the disease. Always look at the start point. The start point of the disease over here. We are starting here. You can see here. We are taking 100 cases of disease, 100 cases of control. And we are reviewing or seeing the records, taking the history in the past and dividing them into 2, dividing them into the 2. So I am going from present to past. So is it a prospective cohort study, retrospective cohort, or is it case control, or is it nested? Or is it nested? Which study is that? You tell me. So it's a case control study because it is going from present to past. And see the starting point, 100 cases, 100 control. So pattern of study identification are some difficult question, but I tried my best. Okay, so correct answer is case control study. It is a numerical for you. Can you solve it for me? One numerical only. Take out your notebooks and pen. We will try it together. Okay. Now, whenever such numerical come now, before you read the numerical, make this table. This 4 into 4 table is your tool for solving the numericals of epidemiological study. You make this 4 into 4 table and try to figure it out the value of A, B, C, D from this numerical. If you found out the values, you have to apply the formula. I'm not interested in mathematics, people. This is not a mathematics class. I'm not interested in that. I just want you to find out the values of ABCD. If you find out the values of ABCD, whatever is asked, you can calculate it. They are asking odd ratio. So you can definitely do AD into BC. AD into BC, and that is calculative part. But finding out the value of ABCD is tricky. So you have to find out the value of ABCD with me. Read the question and tell me. Yes, we will try together. Chalo, there is an investigation going on. The effect of smoking on renal cancer. The effect of smoking not on lung cancer. The effect of smoking on renal cancer, kidney cancer. Okay, it is observed that 30 out of 50 patient were smoker. 30 out of 50 patient money disease present. So out of 50, total patients are 50. Okay, so total patients are 50, disease present, total patients are 50, out of them 30 are smoker. So 30, exposure present in 30. So A is 30. So C value is not given to you, but obviously, if total is 50 and smokers are 30, so obviously non-smokers are 20. It is common sense. They are not giving you the value of a C, but you can find it out very easily. Similarly, okay, 10 out of 50 control. 10 out of 50 control. So total control are 50. Total control, disease absent, they are 50. Out of which 10 are smoker. 10 are smoker. So exposure is present only in 10. So B is 10. So out of the 50, if B is 10, obviously D is 40. I hope you got the values of ABCD. So they do not give you always all 4 values. They will give you 2 values out of the 4. And the remaining out of the total, you have to subtract that and find out the remaining 2. Now calculation is very easy, I guess. Now calculation is very easy. You have to just do the cross product. 30 into 40 upon 10 into 20. Whatever is the answer. Whatever is the answer, I'm not interested in that. Okay, the answer will be 6, but I'm not interested. Give me a thumbs up if you got it. How I interpreted the question, that is important. So you have given the total cases and total control. And out of the total, how many smoke? That is given. But how many do not smoke? You have to subtract and find out the values of these. So this is how we, reading it with proper grammar, proper English and understanding it and fitting the value of ABCD is a little bit tricky. But if you solve such, there are abundant of MCQs on my app, on every platform based on this topic. So please do the practice. Okay. Once you will solve 4 or 5 MCQs based on this pattern, you will realize that they always give you the total and one of the value, either smoker or non-smoker. The remaining second value, you have to subtract and find it out. That is the only trick. Okay. And you should be able to make this table. People don't know how to make this table. People try to solve the MCQ without making this table. That is the biggest mistake students do. So don't try, don't dare. Make this table, a rough table, and then whatever they can ask you, the exposure rate, they can ask you the odd ratio. Whatever they are asking, you know the formula. Okay, apply the formula. If you know the value of ABCD, the things are very simple. Things are very simple. You should know the formula. Apply the value of ABCD in the formula and do the mathematics like that. Got it? So we are done. So can I come on the cohort study quickly, people? We will finish this topic. So let's come on cohort study. Let's come on cohort study. Okay, ji? Cohort study. Karne shuru. Chalo. Ready? Cohort. Case control mein we take 100 cases. We take 100 control. Cohort mein we will take cohort. Who's cohort? Any similarity in the people is cohort. Similarity in the people is having cohort. For example, my birthday is in March. Yes, I'm not telling you the exact date, but it is in March. Okay. So who all are born in March? Anyone among you? Maybe anyone among you, the students who are attending, you are born in March. So we are birth cohort. Me and you and others, who all? So we are birth cohort. We all born in the same month. Okay. My wedding anniversary comes in February. Okay. So anyone else among married, I'm not sure you are married or not, but if you're married, wedding anniversary, many people get married in February. Okay. So February, we are married couple cohort. We all get married in the same month, like that. Cohort is any similarity we are having. Okay, so any similarity people are having, that is known as cohort. That is the definition of cohort I'm telling you. Birth cohort, marriage cohort, like any similarity people are having. So that is known as cohort. So we are conducting cohort study. Now see the design, people. Again, my population. My population is Delhi. Again, my Delhi population. But see my start point. See my start point. I'm starting with 100 smoker and 100 non-smoker. In contrast to case control study, where my starting point was 100 cases and 100 control. See, 100 case, 100 control. That was my starting point. First, I take case and control, and then I go to exposure. Exposure, not exposure, exposure, not exposure, by taking their history. Okay, by interrogating them, by investigating them, okay, by inquiring them. I go in the past, from present to past. But here, see my start point. Cohort study. See my start point. I'm starting reverse. I'm starting with 100 exposure and 100 not exposure. Exposure means smoker. It's very easy nowadays to find smokers. It will be difficult here to find non-smokers, I feel, nowadays. Okay. So anyone among you, if a smoker, although you are a medico, you know everything, but anyone, you and among your friends, relatives, anyone who's a smoker, you should tell all the story to them and help them to quit it. It is addictive. Okay, but many institutes, many things are available nowadays. Medicines are available to quit it faster. You can help such people. Okay, because it is a fact, smoking leads to lung cancer. Looking the people smoking in front of you and your loved one, your dear one, you cannot leave them like that. So you can help it out. Anyways, that was out of this topic. Come back. So this is my population. From my population, I found 100 smokers. Very easy to find. 100 non-smokers. That is my start point. My start point is not cases and control. Okay, it is reverse. Just opposite of case control. It's cohort study. Suppose I'm an investigator. I'm sitting in my office today, 12th October. Okay, and I called 100 smokers. Do you smoke? Yes, yes. Very good, very good. Keep smoking, but do you want to participate in a study? I'm doing a study. I'm an investigator. I'm Dr. Priyanka, and I'm doing a study for benefit of the community. Please participate in that. And person is understanding and giving the consent. And they all are present in my office. They're standing this side. Okay, and I found 100 non-smoker. The same thing I've told them, the same story. They're also ready to participate in my study. They're standing this side. So this side, I'm having 100 smokers. This side, I'm having 100 non-smokers. And I'm sitting at the center. Okay, what I will do? Nothing. I will call them one by one, take their address, current address, temporary address, permanent address, mobile number, email ID, whatever way of contacting them. All ways of contacting them, let them go. No question, no interrogation, no history, nothing. Go, 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 go. Okay, so I'm having 100 smokers, I'm having 100 non-smokers, I'm standing at the center, 100 smokers this side, 100 non-smokers this side. Call them one by one, maintain a register, write their address, mobile number, alternate mobile number, other address, email, so that you can trace them all the way. Either fill them in a register or enter in a computer, whatever is their choice. Okay, just go away, go away. Now what? No interrogation, no history, no inquiry, no. You call them every month. Lung cancer hua kya? Do you have lung cancer? Do you have lung cancer? Do you have? Everyone. So all these 100 cases you call every month and ask them, do you have cancer? Some of them have cancer. Yes, no. Yes, no. And some of them don't have. Some of them have cancer. Some of them don't have cancer. Same, you call them every month. Okay, ask them, do you have cancer? Do you have cancer? Do you have cancer? And some of them have, some of them don't have. Okay, if now sometime they will not pick their call. Every time madam call and madam say, do you have cancer? It's a weird question. No. So they stop, they block your number. They will not pick their call. So you have the address, you visit their address, you email them. So here you are doing the follow-up and you are doing this for the next 5 years minimum or 10 years. It's a big study. It's a time-consuming study. It is not one day. In contrast to case control, we conducted the entire study in one day. Here I require minimum 10 years, 5 or 10 years. So today I take their address and let them go. Address and mobile number, email ID, let them go, nothing. I'm just following them either on call or on email. If nothing was, I personally visit their home. Okay, and ask them the same question. He kindly reply, do you have lung cancer? They just say yes, that's it. So again, I divide them in 4 groups. Among the smokers, down the 10 years. Among the smokers, down the 10 years, some have lung cancer, some do not have lung cancer. Among the non-smokers, down the 10 years, some have lung cancer, some do not have lung cancer. Again, I divide them into 4 parts, 2 among here, 2 among here. So I'm following them to the future. So today I'm starting the study in 2025, October 2025. I will follow them for the next 10 years, and 2035 I will have the results. So I will complete my study in 2035. So I'm starting in present and ending in future. So it's a forward looking study. It's a prospective study in contrast to case control, which was backward looking and retrospective study. I'm trying very hard now. You are getting it, people. My efforts will be, all worth if you are getting it. If you are not getting it, I'm lacking somewhere. So kindly let me know that you are getting my point. You got the difference between case control and cohort. The starting point is different. In case control, we are starting with 100 cases and 100 smoker, and by taking their history, We are coming on exposure, non-exposure, exposure, non-exposure. In contrast to that, in cohort study, we are starting with 100 smoker and 100 non-smoker. And by following them in the future for down the line 10 years, 5, 10 years, we are seeing which have the disease, which do not have the disease, which have the disease, which do not have the disease. So this study, the case control was from present to past. That is retrospective and backward study. Okay, see, I'm drawing population this side, that's why. And this study is forward. Okay, this study is forward looking study or prospective study, because from present we are going to future. See, that's why I have drawn the population this side. So there is an intention behind everything. Why I have drawn the design like this, why I have drawn the design like this. Everyone got it? Everyone? Only 2-3 people. Kindly everyone reply. So this was a design. So what we are doing basically in cohort, case control is done. In cohort, we are taking 100 smoker and 100 non-smoker, and we are following them. We are following them and comparing them in future. In future, we are going following and comparing them. Got it? So what is the study? In 2025, I'm starting the cohort study. I'm starting with 100 smoker, 100 non-smoker. I'm an investigator at the center sitting, 100 smoker this side, 100 non-smoker this side. Today, 2025 October. Okay, now I will take their address and let them go. I will follow up. I will follow up either on call or on email or personal visit, whatever applicable. Okay, and I will find out after 10 years, that is in 2035, how many of them have cancer, how many do not have cancer, how many have cancer, how many do not have cancer. The one who smoke among the 100, after 10 years, 80 of them have cancer, only 20 do not have. Okay, among the 100 smoker. And see, among the 100 non-smoker, only 10 of them have cancer and 90 do not have. See the ratios. Okay, these are the real figures. You can appreciate them. Among the smokers, down the 10 years, how many have the cancer? And among the non-smoker, down the 10 years, how many have the cancer? Okay, so what are the synonyms of the study? This is known as prospective study. So we are going from present to future. That's why prospective, forward looking. Here, what is the starting point? The starting point is exposure, and the end point is the disease. So it is cause to effect, exposure to outcome, risk factor to disease. I hope you got it. So these are or it is follow-up study, because here we are doing follow-up. We are not interrogating and taking the history. So here recall bias is not there. हमें कुछ पूछ recall नहीं है. In contrast to case control, in case control we have to interrogate them. Do you smoke? Do you don't smoke? So sometimes I don't remember. People are very casual. They just answer in case control. I don't remember. Here you have to take the recall. So your recall bias is the biggest problem. Okay, people say and people lie. You know, patients always lie. Do you watch the series? Yes. So recall bias is always there in case control study. But in cohort, there is no recall. No, you don't have to ask them. You have to ask them, do you have lung cancer? Yes or no? And you will personally visit and see whether they have lung cancer or not. So there is no recall bias. Okay, but the biggest problem in cohort study is loss and follow-up. People get irritated. They block you. They block your email. They block your numbers, everything. They don't allow you to visit like that. They change their address like that. Okay, so loss and follow-up, that is attrition. That is the biggest bias we have. So biggest bias in case control. Listen, biggest bias in case control. There are two problems in case control. One is recall. Okay, our study is based on recall. So patient जो बोल रहा है हमें मानना है, whether patient is lying or not remembering, recall bias. And number two, it's recall bias, only recall bias. And here we don't have recall bias. We are not recalling. We are personally visiting and seeing whether the patient have lung cancer or do not have lung cancer. So recall bias is not there. But here the problem is that it's expensive. Following a person for 10 years needs money. I have to call, so recharge my phone. I have to do the email, and I have to visit personally. Maybe they are residing in different cities, different countries. I have to visit personally to see whether they have. So following the 100 people for 10 years requires money, and it is expensive. It is time consuming. Okay, it is time consuming study. It is requiring 10 years, and the most important problem here is ethical problem. What do you mean by ethical? In case control, we don't have ethical problem. Here we have ethical problem. This person is smoking. Maybe this is my relative. Okay, maybe my known person, and I know the person is going, there are high chances the person is going to have lung cancer, but I cannot interrupt it. It is an observational study. I cannot interrupt. I cannot ask or advise the person to quit smoking. Even I know there are high chances the person can have. So ethical, or even if I don't know the person, it is not my relative, he is not my relative, based on the humanity. He's a human, I'm a human. Okay, so based on the humanity, I can have soft feelings that this person looking a good person, good family, maybe this person will have lung cancer in the future and person can die. No, I should advise to leave it. No, that is not allowed. Okay, so doing a study, being an epidemiologist, you cannot interrupt the study. The one who smoke, let them smoke. The one who do not smoke, let them do not smoke. You are just an observer. You are observing it and analyzing it. you are not experimenting something. Okay, so it is not allowed. So ethical problems may arise inside you. Now, have you watched a series, or there is a movie on Herceptin? It's a good movie, you should watch it. So all these ethical problems, the investigator is become having soft corner with some of the persons which are involved in the study and interrupting the study, like that. All these things are shown in that movie. So it is not allowed, it should not be done. So ethical problem should come here, but here ethical problem is not there. The person who already have lung cancer, I cannot help the person who already have the lung cancer, the person is already healthy. Okay, now I have to just interrogate, you have smoked or not smoked. So here ethical problem is not there. Ethical problem is the part of cohort study. I hope you are getting it. Okay, bias, I will explain you in the next session, all type of bias. Here I have explained you two bias. The biggest bias in case control is recall bias, and the biggest bias in cohort is loss in follow-up and ethical bias. Okay, apart from that, it is expensive and time consuming. So I will tell you pros and cons both, don't worry. So I hope you got it. Now here also we will make the same table, 4 into 4 table. Okay, again the same concept, disease at the top and exposure on the left side. Again same ABCD. I guess you know the story of ABCD. It's same table. Only thing, instead of taking total here, we are taking total this side, because the start of the study is 100 smoker, 100 non-smoker. These all exposure present, these are 100 smokers, and these all are 100 non-smokers. You can see these all are 100 non-smokers. The start point of the study should be the total. Okay, so remaining table is the, you want to make it with me, we will make it. Again the same table we will revise. Chalo, at the top, disease present, disease absent. At the left hand side, exposure present, exposure absent. Never forget, disease at the top, exposure on the left side. First present, then absent. Then write down ABCD. What is it ABCD? This is A, this is B, this is C, this is D. You know the story of all four, I guess. Shall I repeat, or you know? A are the person who smoke, they have lung cancer. B are the person who smoke, but they don't have lung cancer. C are the person who don't smoke, but they have lung cancer. D are the person who don't smoke and they don't have lung cancer. I hope you are getting it. Okay, so these are the 4%, same table, same table. Only thing, total I am writing here A plus B and C plus D. So this is the 4 into 4 table. Now we will do the analysis. Before coming on the analytic portion, there are 3 types of cohort. Let me explain you what are the 3 types of cohort. Prospective cohort, retrospective cohort, and a combination of prospective and retrospective. Whatever cohort I told you here, na, this is prospective cohort. Now I will explain you the 3 types, but if you are getting confused now, it's okay, you learn the most common. Most common cohort is prospective only. This cohort is prospective. Okay, whatever I have shown you. But there is retrospective cohort also. You will say, retrospective to case control hota hai, no? Case control studies are retrospective. Can cohort be retrospective? Yes, cohort be retrospective. What is the biggest problem in this study? This is more reliable, but people do not conduct cohort. Why? Say, ma'am, time kiski paas hai? Who have the time? I'm very busy. I do not have 5 years or 10 years. I want to conduct study in one day. Okay, the biggest problem in cohort is time consumption. Here, I will call 100 smokers today, 100 non-smokers today. But I have to follow them for minimum 5-10 years. I don't have 5-10 years, ma'am. So that is the biggest problem. So my wish is that I conduct cohort. But I wish to conduct in one day. Is it possible? Say, ma'am, in one day cohort, how you conduct? You have to do follow-up. You have to see which have cancer, which do not have cancer in future. For the 5 years, 10 years, among the smoker who have cancer, among the non-smoker who have the cancer, at least for 5 years minimum, ma'am. How you conduct in one day? So that leads the concept of retrospective cohort. So retrospective or a combination of the both. Okay. So this is prospective cohort. Okay. Let me explain the 3 again. So there are 3 types of cohort. Most common cohort, conventional cohort is prospective, which I have taught you, but it needs time, 5-10 years. Retrospective can be done in one day. Okay. So what you will do here, these are the 3 types of cohort. See here. See, I will try only once because it is not very important. If you understood, good. If you didn't understood, leave it. We will come on the analysis. Okay. See, this is present. Today, October 2025. This is present. Okay. This is past. This is future. Okay. You can see this is past. This is future. So what is case control study? In case control, not cohort. Case control study, we start today. And we take history of the past. Anna, we start with 100 cases and 100 smoker, and we interrogate them. We interrogate or inquire them. Do you smoke? Do you smoke in the past 10 years? Past 10? They say yes, they say no. So look at the arrow. Arrow is important. We are going in the past, from present to past. That's why case control are always retrospective. There is no type in case control. Case control are always retrospective because we are inquiring regarding the past. But cohort can be of 3 types. prospective cohort, retrospective cohort, and a combination of the three. Now focus here. You already know this portion. Case control are always retrospective. We start the study today and we interrogate regarding the past. We inquire regarding their past 10 years. Okay. But cohort may, conventionally, we start today. We start today with 100 smokers and 100 non-smokers, and we follow them for the 10 years. Look at the arrow. We follow them for the future 10 years and see which have cancer, which do not have cancer. But it requires 10 years. No? It requires 10 years of my life. My life 10 years are important. Okay. So it is prospective cohort, forward looking. Conventional cohort is this, but I do not have time. Look at the arrows. They are going backward. Look at the arrows. They are going forward. You're getting my point. This is backward looking study, retrospective study, case control study. This is forward looking study. Okay. Prospective study, cohort study, conventional cohort. But can cohort be retrospective? Yes, cohort can also be retrospective. Listen, let's take an example. I want to take cohort only, but I want to do it in one day. So my hypothesis I will change a little bit. With this hypothesis, I cannot explain you this one. Suppose tire, car tire or vehicle tire. Have you seen tires? These are the tire. Tire where rubber is used. Tires are made up of rubber. You know, the workers which make tire now, they have skin cancers because they are exposed to this rubber. It is also an hypothesis. So rubber of the tire leads to skin cancer. This is my hypothesis. I want to prove it. Okay. The rubber of the tire leads to skin cancer. This is my hypothesis. So ideally, I should take 100 tire workers over here and 100 other workers, not tire workers, some other workers over here. And I should follow them for the next 10 years and see who have the cancer, skin cancer, who do not have the skin cancer, among the exposed, among the not exposed. Or else I should go to a tire company. You know, some big tire company. There are many big tire companies. So I should go to some tire company and tell my story that I am a Dr. Priyanka, epidemiologist, and tell them, request them to give the records of the people who work in their company, industry, or whatever factory since last 10 years, and still they are continuing. Since last 10 years, they are already exposed to the tire. So they will give the records. Okay. So since last 10 years, I have taken the records from here. I have taken the records. Now today, I will directly interrogate them. Do you have skin cancer? Yes, no, yes, no, yes, no. So study can be conducted in one. So, but look at the arrows. Arrows are coming forward only. Arrows are coming forward only. So in cohort, arrows are always forward. Whether it's a prospective cohort or whether a retrospective cohort or a combination of the two, I can take the records from the tire company. Okay, last 5-year record. And for the next 5 year, I will follow them. So it's a combination of the both. Again, the arrows are this side. Okay, so instead of 10 years, I have to give only 5 years over here. So it will save my time. I hope I tried, people. How many of you understood it? Anyone? Even one? Anyone who understood it? Okay. So cohort is always forward. Look at the arrow. It is always forward looking. Okay. Whether you are starting from the records or whether you are actually recording. Okay. Whether you are actually recording. So it is always forward looking. Okay, and case control is always backward looking. Look at the arrows. People respond now. If I'm asking something, kindly respond. So these are the 3 types. I hope you got the 3 types of the cohort. So cohort can be of 3 types. I hope you got it. These are the examples quoted. Now the last thing, the analysis in the cohort. Okay, the analysis in the cohort. Okay, again the 2 things. What are the 2 things? First, I have to tell whether association is present or absent. What is my hypothesis? Again, the same hypothesis I'm coming. Smoking leads to lung cancer. Okay, whether these 2 things are together by chance or whether they are actually associated. So first, instead of exposure rate, here we find the incidence rate. We find exposure rate in case control and we calculate incidence rate in cohort. So instead of exposure rate in case control, we calculate incidence rate in cohort. Okay, to find out the association. This will tell us whether association is present or absent between the 2 things. That is between the risk factor and disease, whether they are together by chance or whether they are actually associated. So we will calculate this from here. Okay, now if association is present, I want to know the strength of association. For strength of association in case control study, we have odd ratio. But here we have 2 things. Here we have relative risk, which is equivalent to odd ratio, and attributable risk. So we have 2 things. Both of them tell us the strength of association. So first you tell the association, then you tell the strength of association. For association, there we have exposure rate, here we have incidence rate. I will tell the formulas. And for strength of association, if they are associated, you have to tell the strength of association. Whether you tell me the 2 things are by chance together or they are actually associated. If they are actually associated, you have to tell me the strength of association. For strength of association, in case control study, there is odd ratio. And here it is relative risk and attributable risk. So finally, 3 formulas I will tell you. One for the incidence rate, ओके इंसिडेंस रेट में दो फॉर्मूला आएंगे, वन फॉर एक्सपोज्ड, वन फॉर नॉट एक्सपोज्ड, वन फॉर रिलेटिव रिस्क एंड वन फॉर एट्रिब्यूटेबल रिस्क. So you have to learn the formulas. Okay, so let's come on the incidence rate. One by one we will say the three. Incidence rate, first incidence rate, that tells only association present or not present. So take the table, 4 by 4 table. Okay, now tell me two formulas. You can see the two. Incidence rate among smokers, incidence rate among non-smokers. Okay, numerator denominator, numerator denominator, very easy. Numerator denominator, numerator denominator. So incidence rate we are calculating. Okay, incidence rate among smokers. You tell me who are smokers. Who are smokers? That will be your denominator. And who are non-smokers? That will be your denominator. Who are smoker? In which the exposure is present? Smoker. So A plus B. So here denominator is A plus B. And who are non-smoker? In which exposure is absent? C plus D. So denominator is here C plus D. Got it? So here denominator is C plus D. So smoker is the denominator here. Non-smoker is the denominator here. Now among the smokers, who have the disease? Only A have the disease. So A upon A plus B. Okay, and among the non-smokers, who have the disease? Only C have the disease. So C upon C plus D. This is how we derive it. Derivation nobody is going to ask you. People, frankly, derivation nobody is going to ask you. If you are learning, it's good. If you are not learning, it's also good. So A upon A plus B and C upon C plus D. If you are learning the formulas, it's well and fine. But you should not reverse the ABCD. You should learn this 4 into 4. Okay, so this is the incidence rate. Now you calculate, here will be your answer. You calculate, here will be your answer. If incidence rate among smoker is more than incidence rate among non-smoker, then there is association. You should continue your study. Association is there, the two things are not bad chance. The answer of this should be more than this, like in exposure rate also. Now, if there is association, the second thing is strength of association, how strongly they are connected. So there we have two formulas. What are the two formulas? Relative risk and attributable risk, RR and AR. Okay, relative risk and attributable risk. Let me tell you. So first coming on relative risk. So relative risk of formula is in front of you. Okay, incidence rate among exposed upon incidence rate among non-exposed. You are getting my point. A upon A plus B whole upon C upon C plus D. Incidence rate among exposed upon incidence rate among non-exposed. So A upon A plus B whole upon C upon C plus D. You are getting my point? The same thing. You can see it here. So incidence rate among exposed upon incidence rate among non-exposed. This is the formula of relative risk. That is, incidence rate among exposed is A upon A plus B and incidence rate among non-exposed is C upon C plus D. You get numerical forms. You just calculate ABCD ka value, then put it here. I guess you know in mathematics how to solve this equation. Okay, I guess everyone knows. But if you know the values of ABCD now from your numerical, it's very easy to solve. You have to learn this formula. So this is a relative risk. Okay, again, it is equivalent to odd ratio. It is equivalent to odd ratio. Okay, of case control. So again, the same three things. If relative risk is 1, there is no association. If relative risk is more than 1, there is positive association. And if relative risk is less than 1, there is negative association. I mean, it is protected. I mean, smoking protects lung cancer, but this is not the fact. I hope you are getting it. So it is equivalent to odd ratio, relative risk. So this is relative risk. Relative risk and odd ratio are same. Okay, this is done in case control. And this one is done in cohort. Okay, you should know the formula of them. I will revise all the formula in the end, don't worry. And last thing is attributable risk. Attributable risk. What is attributable risk? I will tell you. Attributable risk of formula is incidence rate among exposed minus incidence rate among non-exposed whole upon incidence rate among exposed into 100. It multiplier is 100 in all of them, by the way. That is, this is the formula. This is the formula. Incidence rate among exposed minus non-exposed whole upon exposed. That is, incidence rate among exposed, you can see this one. Incidence rate among non-exposed, you can see this one. And whole upon incidence rate among exposed. Calculation में whatever it is coming, that is not my concern. Calculation part, yours. Okay. Teaching part is not. Okay. So this is how we calculate. So this is attributable risk. So learn the formula. Now you may be thinking, ma'am, what is the difference between relative risk and attributable risk? With both of them, you are telling the strength of association. Okay. What is the difference? Okay. I mean, how should I explain? Listen. So this tells the strength of association between the cause and effect. I mean, if relative risk answer is 5. Okay, I mean, relative risk answer is 5. So it means the person who smoke, they have 5 times more chance of getting lung cancer as compared to non-smoker. So this is the meaning of that. If relative risk answer is 5. So the person who smoke is at 5 times more chances of having lung cancer as compared to non-smoker. That is the meaning. And if attributable risk is 90%, 80%, it will come in percentage. For example, so it means Smoking contribute to 90% of the lung cancer. Lung cancer is not solely due to smoking. Lung cancer can be due to other factors also, like air pollution, like other things. Okay, some diseases like that. Okay, chronic diseases. So other causes are also there, but smoking is contributing how much? So smoking, if you remove smoking, 90% of the lung cancer will be removed from the world. So that is the attribution and a contribution of the lung smoking in the lung cancer. So that is the difference. Both of them are showing strength of association. I hope you got it. I hope. So people, everyone on the screen. Everyone on the screen. Come back. Case control, 4x4 table. Cohort, 4x4 table. The table is same. People, there is no difference in table. A, B, C, D are same. A, B, C, D, A, B, C, D. Disease at the top, exposure at the left side. Only thing here we are totaling this like this, and here we are doing totaling like this, because starting point here is cases and control, and starting point here is smoker and non-smoker. I hope you are getting it. So total is different. Total here we are taking at the bottom, and total here taking at the right side like this. Otherwise ABCD is same. Okay, disease at the top in both of them, and exposure at the right side at both of them. You're getting it? Now tell me the analysis of both of them. Who will tell the analysis? I mean, here for analysis we calculate exposure rate. Exposure rate among cases and control. And for strength of association, we calculate odd ratio. You have to tell me the formulas. Okay. And this is for association. This is for strength of association. Here, okay. For association, we calculate incidence rate, not exposure rate. There we calculate exposure rate. Here we calculate incidence rate. Incidence rate among exposed, incidence rate among non-exposed. Okay. This will tell the association. If the answer of this is greater than this, there is association. If the answer of this is greater than this, there is association. For strength of association, here we calculate two things: relative risk and attributable risk. So here you have to tell me 3 formulas. Here you have to tell me 4 formulas. That is analysis. People, got it? I'm trying very hard. Got it? Chalo. We'll fill these 4 formulas. You will try with me? Please try now. I'm also tired. Come on, help me. Be interactive. Chalo. Numerator, denominator in all of them. Let's try it together. Together is superpower. Chalo, let's try it together. Can we try? Can we try? So here exposure rate among cases. So write down the cases in the denominator and control in the denominator. What are the cases? Cases is A plus C. Okay, so here A plus C. And control is B plus D. So here B plus D. Among the cases, how many are exposed? A. Among the control, how many are exposed? I'm sorry. Among the control, how many are exposed? Yes, B. So here A upon A plus C, B upon B plus D. Am I right? And odd ratio is cross product ratio. AD upon BC. AD upon BC. This is how I learn. I never mug up the formula. I make this 2x2 table, 4x4 table in a second. It's fitted in my mind and just calculate the formula. Okay. I first focus on the denominator. Here, who are exposed and who are not exposed? That will be your denominator. Who is exposed? Exposed is A plus B. Okay. And who is not exposed? C plus D. Now, among the exposed, who have the disease? A. And among the non-exposed, who have the disease? C. Okay. So these are the formulas. Okay. And now here, if this is greater than this, there is association. And here, if it is this is greater than this, there is association. Focus on formulas. This is A upon A plus C, B upon B plus D. This is A upon A plus B and C upon C plus D. Formulas are very confusing, people. If you try to mug up, you can forget. Better to understand and derive on the spot. Now it's your choice. Okay, got it? Now here, relative risk is incidence among exposed upon incidence among non-exposed. I mean this upon this. This upon this. That will be relative risk. And attributable risk is incidence among exposed minus incidence among non-exposed whole upon incidence among exposed. I mean this minus this whole upon this. This minus this whole upon this. So I tried hard. People, I tried very hard to explain you. So we are done with case control as well as cohort study with their analytic portions. Here we have revised the analysis, how to decide association, how to decide strength of association, how to decide association, how to decide strength of association. So please, you have understood. So you make understand your friends, colleagues, roommates, everyone. This is a difficult portion. I'm damn sure not every student is aware of this. But this is the simplest way of explaining them. I'm sure about it. Okay. The last thing, compare case control and cohort. Can you compare it? Okay. Yes, please. We will do the comparison. So you can see case control and cohort study. Case control ka design, cohort ka design. You can see the two study. Okay, here both exposure and outcome have already occurred. Before we start the study, patient already have the lung cancer and patient already have smoked. So both the things have occurred. Here only exposure have occurred. Outcome have not occurred. Here only exposure have occurred. Outcome will occur after 10 years, whether they have lung cancer or not. Oh, lung, the synonyms. This is retrospective, this is prospective. This is backward looking, this is forward looking. This is effect to cause, this is cause to effect. This is outcome to exposure, this is exposure to outcome. This is disease to risk factor, this is risk factor to disease. And here we calculate incidence rate and this follow-up rate. I hope you are getting all the names. You are getting all the names. Got it? So that is the synonyms. Okay, now see the pros and cons. Advantages. Whatever advantages are here, the disadvantages are here. Whatever disadvantages here, the advantages are here. They are like this. Okay, this study is rapid, conducted in 1 day. This is time consuming. Okay, it requires 5-10 years. This is an expensive. I just need one register or one computer. This is expensive. For follow-up, I have to follow up them for 10 years, calling 10 years, email 10 years, visiting 10 years. Okay. This is minimal ethical problem, no ethical problem. They already have the lung cancer. What can I do? God have given them lung cancer. But here I can have soft corner ethical problem because they are smoking. I know they will have lung cancer in the future. I can stop them if I wish, but I can't. Okay, because of study I can't. So ethical problem can be there. Here there is no loss of follow-up because I'm conducting the study in 1 day. I'm just interrogating them and let them go. But here loss and follow-up, that is attrition. Attrition bias is there. Here, this is suitable for rare disease, I will explain. And this is not suitable. This point I will explain. Okay, now come on the advantages of cohort. Here there is no recall bias and here there is recall bias. I hope you are understanding. I have explained you all these points. So you can write down the advantages. Whatever advantages are there, disadvantages here, there. Whatever disadvantages are there, advantages are there. I have shown you the cross connection. Here, for strength of association, we calculate odds ratio. You know the formula AD upon BC, cross product. And here for strength of association, we calculate relative risk and attributable risk. Okay, relative risk and attributable risk. Now for rare disease, if you want to study a rare disease, case control study is best. And if you want to study a rare risk factor or rare exposure, cohort study is best. Why? Because it is a starting point now. What is the starting point in case control? We start with 100 cases and 100 control. 100 cases and 100 control. If it is a rare case, so we can count the 100 cases from their expert hospital. No? Suppose lung cancers are rare, or let's say more rare cancer, brain cancer, or some cancers are very rare. Okay, neuroblastoma, they're very rare. Okay, so we can go to expert hospital and accumulate that cases. Okay, and we can do the start point. So for rare cases, this study is best because starting point is the case. But for rare risk factor, this study is best because starting point is the risk factor. So we can collect the data from some organization and we can do the starting point. So for rare cases, this study is best. I mean, case control is best. And for rare risk factor, rare exposure control, cohort study is best. I hope you got it. You get MCQ on that. So we are done. We are done. We are having some MCQs on cohort study. Read the question and tell me the answer. I'm not launching the poll. Write down the answer in the comment section, please. Please write down the answer in the comment section. Can you please write down the answer? Huh? The ratio between the incidence among exposed and non-exposed. What it is known as? Incidence among exposed upon incidence among non-exposed. That is A upon A plus B whole upon C plus D. What it is known as? What it is known as? So of course it's a formula of relative risk. Okay, I don't know why you people are not answering. It is a formula of relative risk. Okay, yes or no? What is attributable risk? What is the formula of attributable risk? It is incidence among exposed minus incidence among non-exposed whole upon incidence among exposed. You can create the formula, but they are asking about the relative risk. So correct answer is B. Odd ratio is AD upon BC. It is not odd ratio. It is not odd ratio. Someone is saying odd ratio. Okay, now one numerical. In this numerical, we have to find out the value of A, B, C, D. That's it. They are asking the relative risk. You already know the formula of relative risk. You can put it in the values in the formula. I'm not interested in calculation, people. I'm interested in finding out ABCD, as I told you. Okay, so what is ABCD? Read the question. Help me in finding out ABCD. Can you help me finding out ABCD, please? In a village of 1 lakh population, so total population A plus B plus C plus D is 1 lakh. Total is 1 lakh, whatever. Okay, among 20,000 exposed to smoking. Exposed to smoking. 20,000 is what figure? They are exposed. What is exposed? Exposed to smoking. So A plus B is 20,000. 20,000 exposed to smoking. Among them, 200 develop cancer. So among the one who are exposed to smoking, among the one 20,000 are exposed, 200 develop cancer. 200 develop cancer. Lung cancer is occurring in 200. So what is the remaining figure? I guess, I don't know. You can do the calculations here. Whatever is the remaining figure, you have to subtract this from this. Please write down the remaining figure here. Okay. Now, among the 40,000 unexposed people, 40,000 unexposed. Unexposed means they don't smoke. So this complete figure is 40,000. C plus D. C plus D is 40,000. Among the 40,000, 40 develop cancer. So 40. C is 40. Only 40. So you have to subtract 40 from this. Okay, actually this figure is not needed. If you don't do the subtraction, it's okay. Got it? So you got the value of ABCD. Now what's the formula? The formula is A upon A plus B whole upon C upon C plus D. Yes or no? So A upon A plus B is already to you. You don't want to find out B. So 200 upon 20,000, 200. It will be 200 upon 20,000 whole upon 40 upon 40,000. Okay, C upon C plus D. We don't need separate D. We need C plus D. So 40 upon 40,000. You do your calculations. I'm not interested in calculation portion. I hope you are getting it. I hope you are getting it. How to calculate, I have told you. So if you want to find out this figure is also written. Okay. So you have to subtract this from this. You will get this. You will have to subtract this from this. You will get this. Once you get all four values, you can do the calculation. I hope you got it. Everyone give me thumbs up. Okay. So this is how one more numerical I'm having, but leave it. You can solve it. People, we are done. We are done. We are done with descriptive. We are done with analytic. Experimental, I'm leaving it today. It's a big portion because it's already too late. And experimental we will do in the next, I guess 24th of October. We are having the next session of PSM. I don't know because we are having Diwali vacations in between. Okay, so the PSM next, whenever it is coming, first we will finish this portion and then I will continue. That day topic is epidemiology of infectious disease. So before starting that, first I will complete this and then we will go on epidemiology of infectious disease. Thank you so much. I hope you enjoyed the session. Wait. So first session is done. Second session is done. I taught you PSM, epidemiology. Okay, I taught you most of the epidemiology in one shot except experimental epidemiology. So epidemiology is completely over except experimental. Okay, tomorrow we are having forensic medicine session. Have you ever seen me teaching forensic medicine? Huh? Are you excited how I'm going to teach you forensic medicine? See it tomorrow. That too on YouTube. The session will be live on YouTube, not on app. On YouTube, I will teach you the most interesting portion of the forensic post-mortem changes. Don't you dare to miss it. It is on YouTube, not on app. Okay. The second session of forensic a day after tomorrow will be on app. Okay. That is legal procedure. So first on YouTube, then on app. For all 8 sessions, first on YouTube, then on app. 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 So you can see we are having 8 sessions. 4 on YouTube, the first session of everything, and 4 on app, the second session of everything. So don't you dare to miss tomorrow's topic. Tomorrow, forensic medicine I'm going to teach in the most interesting way. Post-mortem changes, that too on YouTube. The session will be uploaded on the app later on, but you have to watch it on YouTube. It will not be live on app. It will be live on YouTube. It's a demo session. Okay, all the people can attend it for free, the non-subscribers also, and it will be 6 p.m. sharp. As usual, it will be 6 p.m. sharp. For any further details, you can WhatsApp on this number. Please note down the support number. For any queries, you can WhatsApp. Calling is not available on this number, so kindly don't call. WhatsApp is available, and if required, you will get a call back from the team. Otherwise, upward calling is not there available, upfront calling. So please note down this number and you can WhatsApp whatever is your query on this. Thank you so much. See you tomorrow, YouTube, 6 p.m. Forensic medicine, not on app. It's on YouTube, on my YouTube channel, MedLive by Dr. Priyanka. Okay, you will get the link on your WhatsApp group. Have you joined my WhatsApp group? If not, please join the WhatsApp group. Okay, and 6 p.m. the session is sharp on forensic medicine, post-mortem changes. Don't you dare to miss it. Thank you so much. See you tomorrow. Bye-bye. Good night. Okay, bye. You can refer my notes only. Vivek, for books, you can refer my notes. It's complete, 100%, nothing else is required. You solve all MCQs as well as university exam. It's more than 100% complete. Thank you so much. I hope you learned today. Okay, I'm ending the session. Bye-bye.